We'll be starting with the arterial sessions part 1 today. Okay. So we'll have 3 of our jury members with us right now, and Girish sir will be joining us shortly. So we have Janish sir, CPS Chauhan sir, and Manu Gupta sir over here. And I'll invite our first presentee, Dr. Shivanand. Okay. Hi.
Good morning, everyone. I'm going to present a paper presentation today. Topic is comparison of TACE plus microablation versus balloon TACE alone for the large solitary or multinodular HCCs of more than 5 centimeter, a case series. A comparative review of the findings from the monocentric retrospective and prospective trial evaluating a new technique of chemoembolization for the liver cancer. Understanding hepatocellular carcinoma, HCC is 5th most common neoplasm and the most common primary liver cancer. The curative treatments like surgical resection or percutaneous ablation are limited to the localized tumors or good liver function. And despite screening for high-risk population, most patients are diagnosed in locally advanced stage, BCLC-B, intermediate stage. Transarterial chemoembolization is the recommended first-line therapy for BCLP-B disease. TACE acts as a bridging therapy for liver transplant candidates or a downstaging tool to meet the transplantation criteria. Local regional therapies and study rationale. Microablation and TACE are indicated for very early and early stage and unresectable intermediate stage HCC. Multimodal and combined local regional therapies enhances the treatment efficacy, especially for the tumors larger than 5 centimeter, by preventing incomplete necrosis without added risks. Previous literature fully describes the efficacy of balloon occluded TACE and single session combined microablation and TACE due to concern about the liver function deterioration after the procedure. Materials and methods. Evaluation of the safety was done by adverse events were recorded at 24 to 48 hours and 4 to 6 weeks. Later, adverse events were classified as clinical, biological, and radiological according to the CTAAV standards. Treatment efficacy or treatment response is evaluated using the M-RECIST criteria. Adverse events are classified as grade 1, 2, 3, 4, 5. Grade 1 having the mild symptoms after the procedure, moderate, and grade 3 severe symptoms, which needs further hospitalization and more hospital stay. And grade 4 is life-threatening, and grade 5 is death-related adverse events. And determine the objective response with the M-RECIST criteria. There are 4 types of responses we are observing. One is stable disease, and which is having the decrease in the size of the tumor less than 30%. One is partial response, more than 30% decrease in the size. Progressive disease, there is more than 20% increase in the size of the tumor in the follow-up, and complete response showing the no enhancing component within the tumor. Study. Materials and methods. Prospective and retrospective study of consecutive patients undergoing combination therapy versus balloon TACE alone, January 2018 to November 2025. Study population. Patients referred to the IR department of Rila Institute, diagnosed with the unresectable HCC or receiving neoadjuvant therapy prior to the transplantation. Patient triaged by BCLC staging criteria. Sample size. 23 patients, 23 patients for the combination therapy and 10 patients for the balloon TACE. Inclusion criteria. Adults with HCC more than 5 centimeter. Compensated liver functions, child score A and B. ECOG performance status 0 to 2. No radiological evidence of extrahepatic disease. Written consent is optional. Exclusion criteria. More than 50% of the liver volume. Metastasis, ECOG more than 1. Severe liver disease and encephalopathy. Overall response rate is calculated in both the cases. Transarterial chemoembolization performed in all the patients using the left radial artery approach. Hepatic artery angiography for the liver tumor evaluation is done. Superselective catheterization into the feeding arteries, superselective catheterization into the feeding arteries, and injection of doxorubicin and lipidol combination. 50 mg of doxorubicin plus mixed in 10 ml of lipidol plus 2.5 ml of sterile water and 1 ml of contrast. After the TACE procedure, we will block the artery with gelatin sponge particles, gel form, until the static flow and full saturation. Liver and kidney function assessed at 24 hours post TACE and combined therapy procedures. Microablation performed using the simultaneously with the TACE under the general anesthesia. Use 17 gauge microablation needle under the USG guidance. Needle inserted to the proximal tumor margin and then advanced to the distal margin through the center. Micro for 60 to 80 watts. Procedure duration is 5 to 10 minutes. Now, balloon TACE performed in all the patients via the left radial artery. Hepatic artery angiogram for the tumor evaluation is done. Superselective catheterization of the feeding artery is done. And temporary occlusive balloon catheter is used to occlude the feeding artery. After that, we perform the TACE procedure as mentioned before. It's a chart showing that inflation volume of the balloon when the we have to see the diameter of the vessel, and according to that we have to inflate the balloon. In case of balloon assisted chemoembolization, there is a technique where you should remove the air from the balloon completely so that you will be able to see the contrast inflation into the balloon clearly. First stage, we have to use the glass syringe to suck out all the air from the catheter, which takes around 30 seconds to come out. Once it comes out, we have to just close the lid and inflate using the 0.2 to 0.3 cc of contrast, and it will take around 30 seconds to inflate the balloon. It's very slow procedure, but you have to be patient during the preparation of the balloon. Time is up.
Yeah, so we have to like wind up.
Okay.
What is the time limit?
It's a total 8 minutes.
Okay.
Presentation to questions.
Yes.
Okay, I'll just go with the results. In TACE and microwave combination therapy, we have observed pre and post procedure values. The most contrast value we have observed in AFB values. Before the procedure, the mean value for AFB is 1277, while after the procedure is 118. PUCA value is 3538 before the procedure. After the procedure is 889. Most of the patients are A5, good liver function. Before choosing the patient, most of the patients are good liver function. 52% having the cirrhosis and 47 non-cirrhotic. Single lesion 52%. There are T types of lipidol uptake we have observed during the procedures. One is type 1, most of the patients having the type 1, type 3 response, and 13% having the type 2 response, and very less percent having the type 1 response. There are 4 types of treatment response we have observed. 8.7% of the people showing the complete response using the M-RECIST criteria, and 43% partial, 34% stable, and 17.3% showing the progressive disease.
I think you can summarize your presentation. You can summarize.
Okay, sir.
We'll move on to discussion now because your time is up.
Yes,
So
I'll
there'll
just
be a-
summarize the findings.
There'll be a 1 minute of discussion.
Yes.
So, because the time is already up.
TACE is the first line treatment for intermediate stage HCC and constantly evolving. This is the first step in comparing the efficacy of balloon TACE versus combination therapy in cases tumor larger than 5 centimeters. The microablation showed higher incidence of mild, moderate, and severe adverse events compared to the BTS group. All the patients maintained the good liver function, allowing them to receive the sequential treatment after the BTS. At 1 month, overall response rate per nodule is 60% for the BTS and 44.5% for the combination therapy. The technique showed fewer adverse events than described other TACE methods, highlighting its value in preserving the liver function, sir.
My one question is, how do you choose the patients category? Which patient will go for the BTS, which will go for the combination?
Initially, we will see the scans. If at all it's showing the single feeding artery supplying the large tumor, then we'll advise the patient for balloon TACE. And we'll give the options. Both options are available. If you are okay with this option, it's a patient choice only, sir, more than this one.
How was the liver function test after doing a B test compared to the microwave plus taste?
In comparatively microwave plus taste procedure, there is more chances on.
No, in your cases, any deterioration liver function was after B test compared to the other procedures?
Yes, sir. Sir, in B test, 30% showed the mild symptoms after the procedure, and one patient showed the moderate symptoms. While in combination therapy, 43% of the people showed mild symptoms, and 13% showed the moderate, and 2 people showed the severe symptoms. Especially in larger tumors where the tumors are very close to the capsule. In that case, we observed 2 patients having the tumor rupture in the long run, sir.
Size selection criteria in your study?
Previously, the studies were done for the tumor less than 5 centimeter. We thought of doing the study, it's very rarely done, like more than 5 centimeter tumors. Studies are very limited, sir. Few studies are not there. Combination therapy and separately, and balloon test is separately for the tumors more than 5 centimeters.
How, the question again lies same, how the B test gives advantage over combination therapy in a larger lesion which is more than 4 centimeters?
Yes, sir.
How it gives advantage?
Because the concentration and accumulation of the medicine inside the tumor and the in the long run, the more patients having the stable disease and progressive disease less in case of B test, sir, as compared to combination therapy.
I would request everybody to follow the time limit. So the presentation will be for 6 minutes and there will be a discussion for 2 minutes. All right? So our next speaker is Dr. Akshit.
Good morning, everyone. Good morning to the esteemed jury members. Good morning to Chauhan sir, Varun sir, and the Jinesh sir. Today, my topic of presentation is endovascular therapy for the renal vascular hypertension due to vasculitis, and it is the result of approximately 140 patients. Talking about the renal vascular hypertension, it is the cause of 5% of the secondary hypertension, and in our setup, the most common type of vasculitis is basically Takayama-arteritis, and out of the 6 subtypes, the pneumono type 3 and 5 is the most common where the renal arteries are involved. It can cause either uniform renal artery stenosis, occlusion, or rarely the renal artery aneurysms. Talking about the revascularization guidelines in the vascular form of renal vascular hypertension, there are no separate guidelines as such, and that's why, and it's because it's primarily there is absence of any large studies or large data set which helps to form certain guidelines, and basically the guidelines of the atherosclerotic disease is what we use to extrapolate in this set of the population. So aim of this study is to evaluate the technical success in percutaneous interventions for vasculitis RAS, and the secondary aim is to evaluate the complications, the predictors for technical failure, and need for repeat interventions. So basically, it's a retrospective study done between 2014 to 2024. It constitutes 140 patients. The inclusion criteria is basically Takayama-arteritis patients, which satisfies the ACR criteria, that is the American College of Rheumatology criteria, with hemodynamically significant RAS when any of these 3 following, which includes resistant hypertension, not responding to drugs, worsening renal functions, left heart failure. The exclusion criteria is basically atherosclerotic or FMD RAS. So the methodology is basically we did the retrospective search for renal IR in the RAS patients, excluded atherosclerotic FMD RAS patients, and after exclusion of the incomplete records, we are left with a final cohort of 140 patients. And we basically studied the 3 main outcomes: technical success, complications and intervention rates, and various demographic and angiographic parameters I will discuss in the further slides. Regarding the procedure details, we routinely do the pigtail run of the abdominal aorta. After that, to look for the lesion morphology, we cross the lesion using oven 4 guide wire, do the angioplasty. Here in the third image, we can see that we are doing the kissing type of the balloon angioplasty, and stenting is only done if there is obstructive dissection or there is poor results of suboptimal results of PTRA. The lesion is technical success if lesion is crossed, angioplasty is having less than 30% residual stenosis, is technical failure if lesion could not be crossed, or the post-angioplasty stenosis is more than 30%, or there is obstructive dissection. Regarding the results, out of 140 patients, 58% patients were females and with a median age of 26 years. Regarding the overall technical success rates, it was 83%, that is 175 cases were successful out of 214 cases. Now, this is the most important slide I want to highlight here. We divide the lesions on 5 morphologies. First is the osteoproximal lesion. Second is the mid-vessel lesion, lesion without with a stump, the lesion without the stump, and finally the branch versus lesions or the bifurcation lesions. Now, coming to the technical research data of these individual lesions, it is very good in case of the osteoproximal and mid-vessel lesions. It is poor in occlusion and the branch vessel involvement, and it's worst in the occlusions that is without the stump. It is only 7.1%. So we did the multivariate analysis of all the factors involved, and out of this, the anatomical factor, that is occlusions, is only independent factor that is statistically significant, causing the responsible for technical success or the failures. Regarding the complication analysis, the total complication rate was extremely high, it is 24.5%. However, the major complication rate was only 5%. Then again, if we see the complications based on the anatomical, on the anatomy, the crossing the occlusions has a 4 times increased risk of complication as opposed to the non-occlusions. Coming to the patency rates of the simple balloon angioplasty, it was around 75% in 1 year, 50% in 3 years, and 38% in 5 years. Coming to the reintervention analysis, the mean procedure per patient was approximately 1.5, and the independent predictors for reintervention was only bilateral disease and residual stenosis of more than 40%. Coming to the stenting data, we did stenting in 17% of the patients, that is 24 patients, and we had a follow-up of 16 patients available. The mean time of in-stent stenosis was 18 months, and primary unassisted patency at 1 year was 94, 3 year was 75, and 5 year was 56. Now coming to the discussion part. So the poor technical results, we have a poor technical results in occlusions, especially without the stump. The overcomplication rate was high, but the major complication rate was only 5%. And the complication restenosis were more than inclusions, and reinterventions. Regarding reinterventions, more than 1/3 patients require more than one intervention. If we compare our data with data of other studies, the technical success of our study was less. It is 83% as compared to Joseph et al. But maybe it is because that we have more of the occlusions. Regarding the stenting rates was 17%, which is comparable to the 15% of the Joseph et al. But the main difference is that we only use bare metal stents as opposed to the covered stents in the Joseph et al. It is 44%. Regarding the stent patency at 3 years, we had 75%. The problem with Joseph et al. Is they haven't mentioned specifically about the renal stents. But Park et al., it was 33%, which is usually the traditional thinking of ours. So the conclusion of this study was, first, before dealing with vasculitis patient in the renal artery stenosis, we can have a rough idea of the technical success and the complication rates. And the traditional thinking is that we should avoid stents in this age group because it is the younger patients. There is a high risk of reactivations and instant stenosis. But if disease activity is optimally controlled, then stent patency is usually better than the balloon angioplasty at the end of 3 and even the 5 years. And these are my references. Thank you very much. Yes, sir. Putting the stent has. Yes, sir.
As you said, in cases of 100% occlusions,
Yes, sir.
the restenosis rate was very high.
Yes, sir.
So, when
Stent-
you use stent graft will help?
Yes, sir. Putting the stent will help. We haven't used the stent grafts. We have only used the bare metal stents only, sir. But it's better outcome as opposed to the.
Very nice study. One important thing is that it was aim is to reduce the hypertension. So how was the control of hypertension?
Yes, sir. Sir, actually, the problem with this, the clinical success is that the clinical success is not very good, even with doing all these interventions. We only get the partial response, similar to that of the atherosclerotic either the amount of drugs we decreased or we get a partial response. We have and follow-up data of only 44 patients now. If we try to analyze the data, but power was less than 80% statistically. So in coming paper, we are coming with a part 2 of this paper, and where we will going to discuss the clinical outcomes of this patients also.
Look for the hospital EMR and convert this into an analytical study with a Kaplan-Meier for the outcome, patient outcome.
Okay, sir.
And what is the Joseph et al. From where that was published, Joseph et al. study?
So Joseph et al. is published in JACC from the CMC Vellore.
So there are thousands.
Yes, sir. Regarding renal interventions are slightly less, more than our study, but they haven't mentioned specifically about renal interventions, why they have used covered stent.
Sub-analysis in that same Joseph et al. study.
Okay, sir.
Where they had graph from 1995 to 2018.
Yes. Thank you very much. Sir, AIMS, cardiac informant, sir. So ISPR conference we have met multiple times. Yes. Thank you.
Thank you for finishing in time. So we have our next presenter, Dr. Abhay Bhujangrao, OP22.
Good morning, respected faculty. This is Dr. Abhay from Sion Hospital, and I am sharing our experience with clinical outcomes in chronic limb ischemia with directional atherectomy in SFA disease stratified by task 2 classification. So these are the images of directional atherectomy. Study overview, study design. It was retrospective single center study from tertiary care center in Mumbai. Patients were classified according to task 2 classification. 50 patients were included from January 2017 to October 2025, and our primary focus was wound healing, limb salvage, technical success and reintervention rates. So what is the principle of atherectomy? It actually removes plaque rather than compressing against the wall, and increases the lumen diameter without any foreign material like stent in the vessel. Unlike balloon angioplasty, which causes barotrauma and it will cause dissection, and again the disease may recur in further process. So atherectomy is a vessel preparation strategy which is helpful in preparing the vessel and for long-term patency. Materials and methods. Inclusion criteria were chronic limb ischemia patients with Rutherford classification 4 to 6, and exclusion criteria was uncorrected coagulopathy. In procedure, we usually took 7 French femoral access, antegrade or retrograde, and using Hawk-1 atherectomy device, and 5000 heparin was given intraoperatively with post-procedure dual antiplatelet therapy and factor 10A therapy in the post-operative period. Pre-procedure assessment was done using CT angiography and Doppler. Lesion treatment was done using crossing the occlusion with 014 command guide wire, and angioplasty and completion was done using low pressure balloon angioplasty after debulking with atherectomy. Follow-up schedule was patients were followed at 1 month, 6 months and 1 year, and then every 1 year. And clinical assessment and Doppler ultrasonography was done in the follow-up period. So what was the clinical success? It was freedom from major lower extremity amputation, lowering amputation level and wound healing. Technical success is defined as successful restoration of inline flow to foot with less than 30% stenosis, and primary outcome was limb salvage, that is freedom from major amputation. Patient demographics, majority patients were in the old age category, with majority were male patients, and hypertension and diabetes were the most common comorbidities, and Rutherford class 5, that is ischemic ulceration, was the most common presentation. So what are the lesion characteristics in our scenario? These are the task A lesions which is seen in these slides. This is task B lesion which were 20%, task C lesions and task D lesions which were 38%. So majority of the lesions were task D, C and task D category, with more than 10 centimeter lesions were approximately 62%, and 50% of the lesions were calcified, and 36% were chronic total occlusions. So what are the procedure? In technical success, 43 of 50% patients achieved successful restoration of flow. These are the some of the pre and post procedure images from the procedures. So this is the long segment occlusion which was successfully treated with atherectomy and low pressure angioplasty. This is another lesion, and this is the atheroma which was retrieved, and this is another long segment SFA lesion which was treated with significant luminal gain, and this was the atheroma which was there. In wound healing, 34 patients achieved complete wound healing, that is 68% in our case. So these are the pre and post procedure pics of the patients. We can see there is complete wound healing post procedure, and 28%, that is 14 patients achieved minor amputation and with successful wound healing. Like in this case, the second and third toe was gangrenous, and post amputation there was complete wound healing. Only 2 patients where sepsis was complicating the wound. These are the pre and post procedure images. So SFA angioplasty and atherectomy in severe occluded SFA disease, balloon angioplasty causes dissections and restenosis. So only 2 patients were in complications, only 2 cases of bailout stenting was there, and only 1 case of distal embolization, no perforations in our study. So we compared this study with largest study available in the international journal, that is the 800 cases in 41 different centers. So our study is 50 patients, so primary patency was even more as compared to that study. Freedom from major amputation, unplanned amputation was 98% in our case and 95% in that study. Distal embolization rate was only 2% and bailout stenting rate was 4%. So even if it is a smaller study in our scenario, that is only 50 patients, the results are significant and they are comparable to the largest study that is over there. So these are the largest studies that are there in the directional atherectomy case. So these are my references. Thank you. No sir, we did atherectomy and post atherectomy low pressure balloon angioplasty with plain balloons. No sir.
And what you are doing for the distal emulations? Are you using protection devices?
No sir, we are not routinely using protection devices. There was only one case of distal embolization in our these 50 patients. So that was successfully managed with post procedure tirofiban and this. Yes. Yes sir. Yes sir, secondary patency was approximately 94% in our case. Yes sir. Thank you sir.
Guys, please stick to the time limit. So there'll be a single bell at 6 minutes. You'll have to complete the presentation by then. And there'll be 2 bells for 8 minutes, and we'll have to end the discussion by then. So our next presenter is Dr. Venkatesh Pothula, OP23.
A very good morning to all. I'll be presenting clinical outcomes of uterine artery embolization after cesarean delivery in placenta accreta spectrum disorders. So, increasing cesarean deliveries are the main cause of this rising pattern of placenta accreta spectrum disorders, and PAS causes massive obstetric hemorrhage, which is defined as blood loss of more than 1500 ml or a fall in hemoglobin of 4 grams. So the cesarean hysterectomy is standard but morbid, and fertility preservation is the major concern. Coming to the management strategies, conventionally this entity is dealt with cesarean hysterectomy, which is coupled with high blood loss and permanent fertility loss. Alternatively, what we can do is leave the placenta in situ, proceed with uterine artery embolization where you can preserve uterus. So the aim of our study is to compare maternal outcomes of cesarean and then uterine artery embolization versus cesarean hysterectomy in case of placenta accreta spectrum disorders. It's a retrospective study from the data between 2017 to 2022 from Sri Ramchandra Institute of Higher Education and Research, Chennai. In embolization group, we had 60 patients. In hysterectomy group, we had 43 patients. Outcomes, we divided into primary and secondary. The primary is requirement for PRBCs, and the secondary is estimated blood loss, length of ICU stay, hospital stay, and adverse events. So coming to the results, there were no cases requiring massive blood transfusion in uterine artery embolization group, compared with 11.6% of cases of cesarean hysterectomy group which required massive blood transfusion. And there were no intraoperative deaths from hemorrhagic shock in embolization group, whereas it occurred in 2 patients of hysterectomy group. And on follow-up, we followed up those patients tenifolically, and we confirmed that 8 patients of uterine artery embolization group conceived naturally and delivered by repeat LSCS on follow-up. And these were the results. You can see a non-embolization group, out of 43 patients, 41 patients ended up in hysterectomy. And in embolization group, out of 60 patients, 5 patients ended up in hysterectomy. And if you see the estimated blood loss, In average, it is 1700 ml in non-embolization group and just 700 ml in embolization group. So this is a representative case. It's a case of placenta accreta, where this is an intraoperative image. You can see the placenta is left in situ with this umbilical cord, and this is a pre-embolization angiogram. You can see hypertrophied uterine arteries bilaterally with extensive placental hypervascularity, which was completely devascularized after embolization with a gel foam. And this is a case of placenta increta. You can see the placenta subserosally in this image. And this is a pre-embolization angiogram. You can see the placental hypervascularity, which was addressed with embolization with gel foam. So to conclude, urinary embolization after cesarean section in a case of placenta accreta spectrum disorders are safe and effective. It significantly reduces transfusion and ICU stay, and it preserves uterus and fertility in selected patients of placenta accreta spectrum disorders. So the UAE helps save both life and uterus. Thank you. Yes, sir. But balloon occlusion, you can't have a persistent blood flow control or blood loss as a solution, because you can't keep the balloon and just leave it like that. Yes, sir. Yes, 100% occlusion can be achieved, but at some point you have to deflate the balloon, sir.
So your gynecologists, they must be very fantastic, because during surgery, patient will bleed
While doing, you are telling about urinary.
after cesarean. So
Yes, sir.
So sometimes it bleeds a lot, and they end up with the hysterectomy only. If it is primary patients, it is first pregnancy. Would choose a pregnancy goal are very strong, then it is a clinical issue. That is right.
No, sir. You are asking that only balloon occlusion while doing cesarean section. So while anyway, the patient will lose the fertility, no, sir, if they go for.
We will remove the balloons after the suturing and all, no?
It's a very simplest.
Before
Yeah.
placing the balloon in both the islets.
Yes, sir. Yes, I understood, sir.
And immediately after clamping the cord and removal, we used to inflate the balloon on table itself.
But they try to remove the placenta, sir. If they don't come easily, they'll leave out. In that case, even if you just inflate the balloon after delivery, after cesarean is over, you have to deflate the balloon where the bleeding goes on. So you have to.
You go back to replace and you repeat it, man.
Once we inflate the balloon, the baby is out. They will not remove the placenta first. They will ligate the uterine artery. Then you will deflate the balloon, and they will remove the placenta afterwards.
Dr. Prashant is presenting on this topic. He had done more than 100 cases in Dehradun.
Okay, sir.
You can attend that.
Okay, sir. Thank you. Thanks.
Our next presenter for the session is Dr. Pari, OP24. I'll be calling our next speaker. The presenter is not ready with the presentation. He'll be submitting it again. So our next speaker is Dr. Vineet KM, OP25.
Good morning, everyone. Good morning, jury. So I'll be presenting on this is RCT basically, either using glue or PVA particles for bronchial artery embolization. I am Dr. Vineet from Gangaram Hospital, Delhi. So hemoptysis is a common symptom in 10% of patients with chronic lung disease. The incidence is 0.1% in outpatients and 0.2% in inpatients. So massive hemoptysis is a respiratory emergency which has got a high mortality rate of 50 to 100% without any treatment, which decreases to less than 20% with bronchial artery embolization. So etiology differs based on the nations. In developed nations, it's because of autoimmune conditions, whereas in developing nations, it's because of chronic TB. And the main culprit bed is bronchial artery. So bronchial artery embolization has emerged as the minimally invasive, effective non-surgical therapy for hemoptysis control. So earlier we used to have gel foam, PVA particles, and coils as embolizing agents, while newer we are shifting towards NBCA, that's glue, onyx, and fill or spit. So the disadvantage with PVA particles were they were of irregular shape, which used to cause catheter clumping or the proximal vessel occlusion because of clumping within the proximal vessel. And also they were degraded by hydrolysis and dehydrogenase present in the serum. So they were kind of semi-permanent in nature. Whereas the glue, it has got a rapid and complete vessel occlusion. The embolization rate can be controlled and the penetration can be adjusted by dilution with lipidol. It has got very shorter procedure time compared to PVA, and it is more of permanent nature as compared to PVA. So the concerns for use of NBCA is the risk of tissue necrosis because of much distal embolization, which can cause mucosal necrosis of esophagus as well as trachea. And the other thing is the uncontrolled reflex, which can lead to non-target embolization. And there's lack of robust evidence. There's no randomized control study across the globe. So we conducted the first RCT. This was the first RCT across the globe after ethical approval from our committee, and we got it registered under CTRI. So this study included 44 patients. The recruitment was done from June 23 to December 24, and we followed up the patient till July 25. So it was a single center randomized control study done at Gangaram Hospital. So inclusion criteria: patients who presented with hemoptysis volume more than 150 ml per day, or with recurrent hemoptysis referring to coughing of blood or blood thin sputum for more than 10 days in a month. So exclusion criteria: we excluded patients who are allergic to contrast, who had renal insufficiency, less than 18 years, who are not willing to participate in study and who can't give consent for the study. So pre-procedure evaluation, we took a detailed history. We had a review of medications, all routine blood investigations. We did CT angiography. Randomized was based on computerized random number set generation, and we randomized based on the sealed opaque envelope method. So immediately before procedure, the sealed opaque envelope was opened and the group was decided. All patients underwent by right common femoral retrograde access technique. We used, most of the cases we used Judkins left catheter. If it is not possible to cannula, then we used switch to Cobra or SIM1. And the microcatheter we took was 1.98 Asahi in the most cases. And if arteries were very large, we went ahead for 2.4 prograde. So embolic material in PVA group was 355 to 500. If there were no shunts, if shunts, we used up to 700 micrometers. And glue, it was 1:4 or 1:5 ratio mixed with lipidol. So the procedure involved thorough review of all CT angiography and meticulous search for all bronchial arteries as well as non-bronchial systemic arteries. So for glue, there were two techniques. We commonly followed the flood technique. The other one was the sandwich technique, where we use the dead space of the catheter to form a bullet within the catheter with sandwiched with the dextrose solution on either side. So definitions: the technical success was defined as a successful catheterization of all the arteries, all the abnormal bronchial as well as non-bronchial systemic arteries. Clinical success was defined as complete cessation of hemoptysis for at least 14 days without requirement for any further intervention. Follow-up, it was cumulative with a minimum of 6 months. So results, we had 44 patients in total, 20 in PVA group and 24 in NBCA group. Technical success was 100%. We could find and embolize all the arteries in all patients. Clinical success was 41, overall 93.2%. So tuberculosis was the main cause of hemoptysis in our patient populations, and there was usage of anticoagulants and antiplatelets in 13% of patients. So the maximum number of patients, that is 16, had hemoptysis volume in between 100 to 200 ml per day. So the groups NBC and PVA were well matched. There was no statistically significant difference between the two groups, depending on the baseline characteristics as well as hematological parameters. So clinical success, there were 24 patients. All 24 patients were attained clinical success in NBCA group, whereas in PVA group, among 20, we had 3 recurrences within the 14 days. So clinical success was only 17 patients, that is 85%. Complications, we had 1 complication in NBCA that is not related to the glue injection, but it was of ostium dissection by the catheter itself. And the recurrence, it was seen that recurrence was more in PVA group, that is 7 patients, amounting for 35%, and it was statistically significant. So the hemoptysis free days were more in NBCA group as compared to PVA group. So based on Hazard and Kaplan-Meier functions, the estimated cumulative recurrence rate at 2 years was 61% and 26% for PVA and NBCA respectively, and it was statistically significant. The hazard ratio was 4.38. So people who underwent PVA embolization had 4.38 times higher the risk for recurrence of hemoptysis. The mean hemoptysis free survival was 21 months in NBCA group as compared to 17 months in PVA group. So there were a few recent studies demonstrating the similar efficacy of more than 90% clinical success in NBCA group. There were 2 retrospective comparative studies which showed more hemoptysis free survival rate in glue group, that is NBCA group. So recurrence, we can see recurrence in two groups, the two peaks, that is 1 to 2 months or 1 to 2 years. The earlier recurrence was because of incomplete embolization, was the late was because of revascularization of the previously embolized vessels or neoangiogenesis. So this was another study which showed that presence of aspergilloma, angiographic stents, and diabetes mellitus, they were associated with higher chances of recurrence. The other study which showed the more dilute we go ahead with the glue, it's more distally and there's less the chances of recurrence. So our study had two limitations. The time period for embolization procedure was not recorded, and we lacked the data on the repeated interventions on the patients who presented with recurrence. So to conclude, glue has lower recurrent says, longer hemoptysis-free interval, and improved 1 year hemoptysis-free survival rate without increasing any significant complications.
In case of shunting, do you use glue?
Yes, sir. We use higher concentration of glue so that it won't either 1:3 or 1:4, sir.
And drawback of PVA is irregular shape particles, na? Clogging, proximal
Clogging.
embolization.
Yes, sir.
So, why can't we use embospheres in that case of uniform shape and size?
Sir, even embospheres is known to be semi-permanent in nature, sir, and it gets hydrolyzed by the serum dehydrogenases and hydrolysis.
It's a randomized control trial. So how did you get the number size of 22 to get a conclusion for that?
No, sir. Actually, the study is a bit large. So this was the initial part, interim analysis. Actually, the study included 80 patients. So currently we have 64 patients, and study is still ongoing, sir.
Second thing is that you told the patients were not matched. In a randomized, there is no need to match the patient. Already it's randomized. We don't have to compare the two populations and tell it's not matched or not. Randomization itself is matched.
Yes, sir. But to be on the safer side, that both groups should be comparable to each other in baseline characteristics, sir. So that's why we. Thank you, sir.
I'll be inviting the next presenter. He's yet to submit the presentation. So, Dr. Akshit Kumar. Dr. Akshit, is he there? Dr. Varun Katyal?
So good morning everyone. Today I'll be presenting 9 cases of native SFA recanalization in thrombosed femoral popliteal grafts. It's a case series of 9 patients with early outcomes. So coming to the background, we all know that the femoral popliteal bypass grafting is the preferred treatment as of now for the SFA CTOs involving TAS C and D, as they offer high technical success and good clinical outcomes. However, there are high chances of FEMPOP graft failure, and early failure incidences are 5 to 10%, that is when the graft failure happens in less than 30 days, and late when it happens more than 30 days, it is 20 to 50%. So after graft failure, the options of further recanalization either will do redo bypass or endovascular recanalization. So this is the chart explaining what are the options if there is a graft failure. We can either go with the redo bypass surgery, but it has very high perioperative morbidity, and also the results of limb salvage are not that good. It's 66% limb salvage rate at 5 years, and very high mortality at the 30 years and 1 year is there. And it is also limited by the advanced age of the patients and lack of the great saphenous way for the graft. Another option is endovascular treatment of the bypass graft either by CDT or thrombectomy. Its advantages is it is less invasive. However, challenges is poor long-term patency of the graft, high reocclusion rate, and due to the high thrombus load, there is very high risk of distal thromboembolism, and it is less effective for chronic occlusion. Then the option of native SFA recanalization comes. We chose this option because it helps in preserving the collaterals. It is suitable for the high-risk patients who are not fit for the surgery. And in same setting, we can treat the BTK disease and establish the inline flow, which can reduce the further chances of native occlusion or graft occlusion. However, the challenges is lower primary patency than the surgery. Long CTOs are difficult to cross technically, and it often requires stenting and multiple reinterventions. So as I explained, the challenges with the secondary femoral popliteal bypass is high perioperative morbidity and very high mortality. So this was the landmark study which was published in 2021 in CVIR. They did study with the same motive in the cohort of 54 patients, and among them 77.8% was TAS 2D lesion with average length of 26.8 centimeters. They achieved high technical success rate of 94.4%, and primary patency at 1 year was 93%, and at 5 years was 76%. Limb salvage rate was also very high, which was 94% at 1 year. In 48, key insight into this study was that the 48 out of 54 patients, that is 88.9%, needed stent. And also, as I mentioned, the rationale behind is preserving recanalizing the native SFA is because it helps in preserving the collateral branches via the endovascular approach. So this is the comparison I did, which shows that the native SFA recanalization shows the maximum limb salvage rate when compared for the 5 years, which is 88% as compared to the other options that I already discussed. So the patient selection criteria was, we did this retrospective analysis in prospectively collected data. We did this analysis in last 2 years, that is 24 and 25. The patients who presented with critical limb ischemia of 3 to 6 had failed femoral popliteal bypass graft, native SFA CTO, which was amenable to recanalization, TAS C and D lesions only, and suitable anatomy either for antegrade or retrograde femoral or pedal access. All the cases was discussed in MDT with vascular surgery team, and when they were unwilling to go for any other option, then patients were taken for the endovascular recanalization. So these were the techniques we used. Access was either ipsilateral antegrade CFA or retrograde contralateral access, or we had to take the retrograde pedal access. And sometimes we had to go through antegrade CFA and the pedal access for the Safari approach. And most of the cases we are able to cross subintimally, and adjuncts where we have to use the drug-coated balloons, atherectomy, or bare metal stents. So this is the demographic details of the patients. Mean average age was 62.2 years, and the most common associated comorbidity or risk factor was all of them were smokers. So this is lesion characteristics. In 5 patients were TAS D and 4 patients were TAS C. Average lesion length was 19.2 centimeter, and technical success was 100%. We were able to recanalize the SFA in almost all the patients. So procedural details, 3 patients we had to take antegrade access, 6 patients retrograde access. Almost all had subintimal crossing. And in 1 patient we could not re-enter into the popliteal region, so we had to take the retrograde pedal access and do ballooning, parallel ballooning to re-enter. Devices used, 1 patient had to use Rotarex as there was already stent was there in situ. So we had to use the Rotarex to clear the instant thrombus. Complication, 1 patient has very early stent thrombus within 2 days, for which we had to do the catheter-directed thrombolysis. So this is the representative case. This is the patient who presented with non-healing ulcer. Patient had already undergone FEMPOP bypass graft, and already there was the SFA stent. So on presentation, patient also had the graft abscess, which we can see. So this graft was first explanted, and patient was taken for the native SFA recanalization. This is the angiogram which was there. This is the crossing. This is the crossing through the stent, and this is the Rotarex, use of Rotarex for the thrombus removal, and the final angiogram was this after Rotarex. So these are the clinical outcomes as compared to the landmark study, which also had very high technical success. We were able to achieve recanalization in all patients. 8 out of 9 patients had clinical improvement, and 1 patient didn't follow up with us. Limb preservation at 1 year and 5 year of the Minici et al. Was 94% and 88%. In our case, we only had follow-up till of 1 year for the 5 cases, and it is the 100% limb preservation is there. We are studies still going on, and we are still following up. These are only the early outcomes. So this is the another case which is showing the technical, the crossing, and here we could not re-enter into the popliteal, so we had to cross from the below, and we had to deploy the stent. This is the final angiogram and final wound picture. So advantages over the surgical redo bypasses, Minimally invasive, preserve collaterals, lower morbidity, shorter recovery, and repeat intervention is feasible if required. So future direction is optimization of the devices, stent selection, whether to use DCB, DES, drug-eluting stents versus stent graft, and using other imaging techniques like IVUS or OCT for device sizing. Long-term patency still needs to be evaluated, and other predictors of success in restenosis needs to be evaluated. These are my references. And in conclusion, native SFA recanalization in thrombosed grafts is safe and effective alternative to surgical redo bypass with very high technical success rate and preservation of arterial anatomy. Thank you.
So our next presenter is Dr. Pari, OP24.
Good morning everyone, myself Dr. Pari, DNB resident. My topic is endovascular thrombectomy for acute peripheral thromboembolism, a case series with excellent clinical outcomes. Acute and subacute lower limb ischemia result from sudden reduction in arterial perfusion commonly due to embolism or in situ thrombosis. The signs of acute limb ischemia includes pain, pallor, pulselessness, paresthesia, perishingly cold, paralysis. The management includes thrombolysis, intraarterial lysis, mechanical thrombectomy, surgery. Rutherford classification guides treatment decisions and prognosis. Class A means viable limb not immediately threatened. Class 2A is marginally threatened limb, salvageable if promptly treated. Stage 2B means immediately threatened limb and immediate salvation is required. Stage 3 is irreversibly damaged limb. Aims and objectives are to evaluate the role and outcome of endovascular aspiration thrombectomy in acute lower limb ischemia, to compare outcomes with surgical thrombectomy literature data for Rutherford Class 2A ischemia. Materials and methods. My study is a single center retrospective observational study including 26 patients for a time period of 2 years. The study participants were patients presenting with acute lower limb ischemia to our institution. Procedure details. The access is use-guided, antegrade or retrograde femoral access. Device used neuroguide sheath and neuroreperfusion catheters. It's chosen due to high cost of dedicated peripheral thrombectomy devices. Techniques: if wire traversal test is positive, then proceeded with aspiration. Iliac, femoral and popliteal artery occlusions were aspirated using guide sheath because the caliber is comparable to the carotid artery. Tibial vessel occlusions are occlusion is aspirated using neuroreperfusion catheter because the caliber is comparable to proximal intracranial vessels. Submalleolar occlusion with single vessel runoff was attempted using 3-max aspiration catheter. One refractory case required stent retriever. Inclusion criteria: primary admission diagnosis of acute lower limb ischemia, clinical classification of Rutherford Class 2A at presentation, confirmed occlusion of iliac, femoral, popliteal or tibial arteries on CT angiogram, first time intervention for the affected limb. Exclusion criteria: Rutherford Class 2B or 3, chronic limb threatening ischemia, contraindications to anticoagulation. Results: among 26 patients, 25 cases were successful, 1 case was unsuccessful due to acute and chronic wall adherent thrombus. Complications are distal emboli, wall dissection, underlying stenosis, puncture site pseudoaneurysm and hematoma. Among our samples, there were 3 cases of distal emboli in pedal vessels, which was managed with anticoagulants, 1 case of underlying stenosis stented simultaneously, 1 puncture site pseudoaneurysm treated with direct thrombin injection. Let's see few sample cases. Here we can see femoral, popliteal, tibioperoneal trunk and ATA thrombosis showing good post-thrombectomy revascularization. Here we can see tibioperoneal trunk and distal PTA thrombosis with reformed flow after thrombectomy. Here we can see femoral, popliteal and ATA thrombosis showing satisfactory reflow after thrombectomy. An example for complicated case. Here there is a near complete thrombotic occlusion of popliteal artery. On post-thrombectomy there was a flow limiting dissection in the peroneal artery, which is a single vessel runoff. So it's managed with stent placement, reinforcing distal PTA and DPA flow. Endovascular aspiration thrombectomy showed excellent technical success, that is 96% in our study, comparable to surgical outcomes reported in the literature, more than 90%. Advantages are minimally invasive approach, short procedural time and hospital stay, low complication rate, reduced vessel wall injury, unmasks underlying lesion for targeted treatment. Limitations: small vessel caliber, floating thrombus, chronic wall adherent thrombus. The goal is to achieve timely revascularization with minimally invasive techniques. Key advantages are lower procedural morbidity and mortality when compared to open surgeries, highly dependent on anatomy and clot characteristics and may require adjunctive procedures like thrombolysis. Fresh thrombus and soft emboli respond better than chronic fibrotic thrombi. Rutherford Class 2B often requires open surgical intervention for optimal outcomes. Fast diagnosis and effective reperfusion strategy are important measures for patient wellness. Thank you.
Why the TP was not done in this immediately treating patients?
Sir.
Which catheter you are using? Indigo.
Sir.
Which catheter you are using?
Catheter, neurocatheter, cerebris.
Lightning?
Yes, cerebris catheters and
Which catheter aspiration device you are using?
No.
Indigo aspiration devices.
yes.
Which one? Lightning or CAT 7, 8?
Sir,
And which catheter below you are using your OT?
it's a red 68, means reperfusion red 68 catheters commonly.
Because we started, you said that your patient category 2B was kept out of this.
Yes, sir. Sir, we can attempt to be, sir. If it fails, then we have to surgically open, but it may, like 2-3 hours may have wasted its.
We can also done with using these indigo aspiration devices, lightning 7, they are very good
Yes.
aspiration power. Now, yesterday only the board devices already this one launched, which is 12 fans, which can be used up to the 4 also. But challenge with we using 12 fans, we have to use pre-close, and then we can't do thrombolysis. But we don't need, if there's acute thrombus, we don't need even surgical hospital. So this is endoscopic treatments,
Yes.
even in 2B patients, immediately treating patients, if thrombus is going,
Yes.
gone to that ATA, PTA, there's no feeding of the limb is good, there's no feeding of the ATA, PTA and any dorsal pedis artery, the patient is the on verge of the amputations. Better to go with endoscopic techniques, even in 2B patients, aspirations and then thrombolysis, or using your neuro devices. We use 2 alone.
Okay. We can use.
These are excellent results using these devices.
Only if it fails, it's a disadvantage. Success, it's good.
Patient has no choice.
Okay. Okay.
Good, very good.
Thank you.
Our next presenter is Dr. Shiva Chandra Shivaji, OP31.
So good morning. I will be presenting the clinical outcomes of the matched versus mismatched target arterial pathways in a BTK angioplasty, a diabetic versus non-diabetic comparison. So introduction, the BTK angioplasty is essential for limb salvage in chronic limb-threatening ischemia. However, here the concept is that there is a target arterial pathway where that we have to select a continuous route of inflow line from the groin till the ankle, and TAP usually involves usually select the least diseased infrapopliteal artery, and sometimes maybe an angiosperm based one also. So what we here do is we usually grade the infrapopliteal arteries, like if there is a focal stenosis, it will be grade 1, and if the stenosis is more than 1/3, then it's grade 2, and if the cross CTO is more 1/3 of the length, it's grade 3, like that. We used to classify. And what we did was we compared the clinical success between the TAP matched and mismatched in BTK angioplasty patients, and we assessed the modifying effect of the diabetic status. And the total patients we recruited were around 44 undergoing the BTK angioplasty who had Rutherford 5 or 6, and 2 were lost to follow-up. And the clinical endpoint was complete wound healing in 6 months, and or if there is a MACE or male event. So coming to the demographics, comparing the diabetic and non-diabetic group, the age and sex and smoking history are comparable in both groups, and so there is no confounding factor between the two groups. And this is an example where 58-year-old male with chronic non-healing ulcer presented in the dorsum of the foot and amputation of the 4th and 5th toes presented to us. And this is the diagnostic angiogram where we can see that the ATA has chronic total occlusion and along with the multifocal areas of stenosis also. So it was having grade 4, and PTA was having grade 3, and the peroneal artery was 0. There is no disease in the peroneal artery. And so we went ahead and we tried to recanalize the ATA and PTA in this case. And after that, this was the post-plasty images. So in this case, according to the glass, they say that we have to recanal the least diseased one, or sometimes we can recanal the angiosperm based one. So here the results coming to the results of mismatched target arterial pathway. Of the all 18 patients, the glass stage was 1, except for one patient where the glass stage was 2. In comparison, the matched group had a mean of 1.71. So more difficult artery was revascularized in the mismatched target arterial pathway group, and this is the mean one where we can see that according to the class it was mean TAP grades were less. However, we revascularized the one where the disease is more, like 3.2, 3.6 and all. And this is the result which we got, where we can see that the matched patients had around 80% success rate. In the mismatched group, it was around 88. However, the p-value was 0.691. It was not statistically significant difference between the in clinical success between the matched and mismatched group. And coming to the diabetic patient population, here we can see that the matched had 10 and mismatched people had 7. And trend was that the mismatched one was successful. However, we didn't get the statistically significant difference. And this is the total result which we got. Here we can see that in matched diabetic pathway, it was around 70% success. However, in mismatched one, it was 100%. And the non-diabetic population, it was comparable between the two. So overall, the result is that if matched versus mismatched, there is no difference. However, in diabetic population, that mismatched has scored well. However, it is not statistically significant. And in the non-diabetic population, there is no difference. So coming to the conclusion that after post hoc analysis we did, where we can see that our study was underpowered. We required almost 30 people to prove this study actually. And recommendation is that we do not change the practice based on statistics alone, and we can consider TAP mismatch strategy in diabetic populations for exploratory use due to 100% observed success, and prospective registry or RCT is required to validate it. Thank you.
Do you have keep a check on direct and indirect revascularization? How many patients have underwent direct revascularization, or you have attempted an indirect revascularization?
So based on the target arterial pathway use.
Yeah, based on target and that angiosome concept, no?
Angiosome concept, it was equally distributed among the two groups, sir. Actually, we did equally distributed. We didn't take the angiosome here. It was merely based on the whether we are validating the glass concept or not.
In both the scenarios, we have to opt one way. Either we will go for a direct revascularization or we will go for indirect revascularization.
Indirect revascularization.
So we haven't classified on the basis of.
It was equally distributed on the both groups, sir.
If you are not able to open the artery which is going directly to wound, so if you open another artery which is not directly going to wound but it's supplying through collaterals, so your outcome would be still good. It would be, I mean, the
direct artery will be the good compared to indirect one, but however the angiosome concept few people agree on and few people don't agree on.
So the question is that if you are not able to open the artery which is directly going to the wound, but there is another artery which is going till the foot, but you can open it. So would opening that would still be beneficial? Would the wound healing be achieved or not?
Yes, sir. Wound healing will be achieved.
Our next presenter is Dr. Pooja Sai Mudana, OP32.
All right, thanks Shreya. So good morning all. I'll be presenting on our single center experience with large bore access and vascular closure devices, particularly looking at the pre-close method. So I'll be looking at the technical results and the factors affecting complications. I'm from Sri Chitra Tirunal Institute in Trivandrum. So basically, use of large bore access devices is coming up, especially in the aorta component for all of us. However, there's a critical Achilles heel where we are dependent on vascular surgeons for surgical cut down and access. So this has been partly resolved by pre-close technique with the advent of suture-based vascular closure devices. So I'll be looking at our experience with the pre-close technique and use of suture and plug-based devices for closure of these large bore access. So the aims of this study is to look at the safety and complications of this method and look at the factors affecting the complications. So for this purpose, this is a retrospective study over the last 10 years. I have defined large bore access devices as anything about 10 French, and the complications have been graded as major if they require any additional intervention. So I have looked at 152 access sites in over 138 patients, and majority were male. And 15% of patients were EVAR and 80% were TAVR cases. And 40% of patients had posterior wall calcification, and the median sheath size was 14. So 14.5% of patients had complications overall, of which immediate complications, device-related complications were seen in 9% of cases. And major were also around 13 cases. So coming to the additional interventions, overall 15% of the patients who had complications required additional interventions, which I have detailed in this slide. So we had done a univariate analysis to look at the predictors for overall complication, on which CFA diameter, sheath size and sheath to artery ratio had a significant correlation. And univariate analysis for major complications, that is complications which required further intervention. In addition to the CFA diameter and sheath to artery ratio, presence of posterior wall calcification also had a significant association. However, on multivariate analysis, as expected, the sheath to artery ratio was not significant. However, the CFA diameter prior to puncture and the posterior wall calcification still held good. And a prediction model was derived based on the multivariate analysis. And also to be noted, the CFA diameter cutoff greater than 8 mm was found to have a specificity of 70% and sensitivity of 70%, specificity of 65% for predicting odds of major complication. So as we found posterior wall calcification to be a major risk factor, I would like to show a few possible mechanisms how this would work out. So as most of us are aware, anterior wall calcification is already an established risk factor for vascular closure device deployment. So this, as you see, this is the foot plate and that is the axis we are coming from. So the anterior wall calcification, the foot plate won't sit properly and will get dislodged, shifted away due to the anterior wall calcification. However, presence of a posterior wall calcification also can work in the same fashion, with the foot plate not hitting against the posterior wall and just getting stuck to the calcification per se, or it can lift up the calcification and cause dissection and thrombus, resulting in stenosis, or improper deployment can lead the sutures to go through and through the wall and even get adherent to the posterior wall and pull the posterior wall anteriorly, and it will get squished. So basically occlusion. So these are the possible mechanisms through which this might be working out. So I would like to show a few representative cases to demonstrate the same. So this is a 66-year-old male patient with infrarenal aortic aneurysm, and EVAR was attempted. He had a 18 French access on the left side and 14 French on the right side. Both pre-close technique was already done. However, after the procedure, he was found to have poor flow in the left iliac limb, and angiograms through the pedal and the contralateral injection showed focal occlusion, and which had to be angioplasty. However, after angioplasty, there was a return of moderate flow, but the next day, patient again had acute limb ischemia features, and the surgical opening was done, and it was found that this the suture material was actually strangulating the vessel, and it was causing complete occlusion. And this is another case by our cardiology colleagues where they had done a TAVI. And so pre-close technique was again used, and after the closure, again another focal dissection and occlusion was done, happened, and which had to, and following that angioplasty was done, and despite, so due to persistent narrowing, even and dissection, a covered stent was also placed. So this is a 64-year-old male patient with a thoracoabdominal aortic aneurysm. TVAR was planned for him. So due to the pre-op CT showing left-sided moderate iliac stenosis, the plan was to originally put through the right side. However, beyond the iliac, it was not tracking. So the left side was also attempted. So after attempting on the left side, this was the angio run. There was occlusion of the left external iliac artery. So balloon occlusion was done, and despite poor reopening, on-table exploration was done, and he had to undergo a bypass graft from the CIA to the CFA. And during the same time, a CIA conduit was placed, and the TVAR was completed through the conduit. So thank you for all.
Your conclusion, so summarize, what did you find in your study?
So finally, we found that larger CFA diameter and absence of posterior wall calcification are associated with lesser major complications which require intervention post.
If the diameter is less than, like, say 6 or 7 mm, or if there is a posterior wall calcification, should you still go ahead with the endovascular deploying or perclose, or should you go for surgical arteriotomy?
What we felt was the presence of posterior wall calcification was significantly associated with the major complications. However, we have generated a prediction model for the same. So we have generated a prediction model for the possible odds of having major complication with the presence of posterior wall calcification and the pre-puncture diameter of the CFA.
So if you are doing a patient and you get a posterior wall calcification, so would you still go ahead with perclose, or you will no, this is highly associated with complications, so let's go for surgery? So what would you do?
We did try to grade the calcification and see if that is associated. So for our study, we did not find any significant association with the amount of calcification. So here we have done like 25, 50, 75, and all these grades are not associated. So presence can indicate there is a higher risk, and the operator might choose to go for if not a pre-close, initially put 2 devices, and then if there's further use, complemented by use of plug closure also.
Thank you.
Thank you.
Next presentee is Dr. Amisha Gupta, OP33.
Good morning, everyone. I'm Dr. Amisha Gupta, PG resident at Safdarjung Hospital, here to present on the endovascular triumph in peripheral pseudoaneurysms. What are pseudoaneurysms? Pseudoaneurysms are contained disruptions of the vascular wall which lead to turbulent blood flow and eventually hematoma formation. What we did was a retrospective analysis of clinical records and imaging data of 53 patients with peripheral pseudoaneurysms who presented to us at our hospital. The aim of our study is at unfurling the myriad of endovascular options which are available and reviewing the technical outcomes of endovascular treatment, assessing the post-operative course of patients with special emphasis to the clinical outcomes, their initial symptoms, the The initial symptoms, the VAS score for pain, color Doppler, and CT angiography findings for morphology were documented. The choice of treatment, success rate, post-operative course, and complications were discerned, along with 6-month to 5-year follow-up in patients for symptom improvement, recurrence rate, and need for reintervention. What we found in the retrospective analysis was that most of the pseudoaneurysms are either post-traumatic or post-iatrogenic. Very less of them were due to infections or systemic vasculitis. There was no significant difference in the incidence of pseudoaneurysms in males and females. Different embolization techniques were used, which included stent grafting, percutaneous thrombin injection, percutaneous glue embolization, coil embolization, even hybrid procedures like balloon-assisted glue embolization and balloon-assisted thrombin injection were done. Here are some cases. A 25-year male presented with post-traumatic swelling in the right subclavian, right clavicular region. Ultrasound Doppler image showed there was an anechoic lesion with flow, which showed yin-yang appearance on color Doppler. CT angiography was done, which confirms the presence of pseudoaneurysm. The patient was taken up for DSA. There is a saccular filling, saccular outpouching seen in the second part of the right subclavian artery. A stent grafting was done. The video is not getting played. A stent grafting was done, and the stent was deployed in the subclavian artery. Post-stenting, the run showed there was no opacification of the aneurysm. This was another case of post-traumatic ATA pseudoaneurysm. We can see there is a narrow-necked aneurysm of the ATA. Since it is a non-crucial artery with a lot of collaterals, so coil embolization was done of the proximal and the distal segment to avoid any filling from the collaterals or retrograde filling. Post-contrast runs show there was no filling of the pseudoaneurysm. This is a case of a 35-year-old female which presented to us with a swelling in the cubital fossa region. She had an AV fistula. Post that, she developed the swelling. A DSA was done which showed a narrow neck, large pseudoaneurysm. This was, it had a narrow neck. It was less than 1.5 mm. So we went for percutaneous thrombin injection. And post-embolization contrast, color Doppler showed that there was no color flow and it was thrombosed. Thrombin is reconstituted with diluted with saline, and we can give 1,000 to 2,000 units of thrombin. Then this was a case of brachial artery pseudoaneurysm. It was multilobulated and it had a neck of approximately 3.5 mm. So what we did was a balloon-assisted percutaneous thrombin injection. The balloon was used to prevent the backflow of the thrombin into the parent artery and prevent its embolization prevent embolization and thrombosis of the parent artery. Post-embolization runs show that there was no opacification of the brachial artery. Similarly, this was a case of proximal SFA embolization, pseudoaneurysm. The patient had undergone some coronary artery angioplasty, coronary artery stenting via femoral. After that, the patient developed swelling in the right femoral region and ecchymosis. So, color Doppler was done, which showed a pseudoaneurysm. We can see the SFA, there is an outpouching, which is irregular shaped. So, in this case, we did balloon-assisted NBCA glue ingestion. And post-contrast runs show that there is complete non-opacification of the pseudoaneurysm, and we can see the NBCA glue cast at the site of the pseudoaneurysm. So we achieved 100% technical success. No filling of pseudoaneurysm post-procedure was seen. Only 2 patients needed re-intervention. One of them had, we had injected thrombin and it needed re-intervention after 2 weeks because there was mild increase in the swelling and pain. In the second case, there was, we had done stenting. In that, there was a mild increase in the pain and the swelling in this region. So it was due to stent leak. There was no recurrence of symptoms post 3 months. Average drop in VAS pain score was 4 points. 90% of the patients had complete resolution in swelling within 2 months post-procedure. Average hospital stay post-endovascular treatment was 2 days. So when a patient presents to us with a peripheral pseudoaneurysm, we look for the neck of the aneurysm, whether it is narrow or wide. If it is narrow, and we can then percutaneous thrombin injection or percutaneous glue injection is done. If it is wide, we look whether it is a crucial artery or non-crucial artery. In case of a non-crucial artery, we can do coil embolization, as in we did in ATA. If it is a crucial artery, then we prefer stent grafting. We can also do balloon-assisted or stent-assisted coiling of the aneurysm, pseudoaneurysm itself in case of crucial arteries. Thank you. Yes, sir. Yes, sir.
Why we haven't gone for a balloon-assisted glue or thrombin injection? Putting a stent, letting a patient into antiplatelet. Secondly, stent thrombosis or stent fracture might occur against clavicle. So why stent graft, not balloon-assisted glue or thrombin injection? You are able to see it on ultrasound, na?
Yes, sir.
Then we would have put DSA and balloon USG guided thrombin injection.
So the patient had a clavicular fracture, so it would continuously irritate and there is an increased risk of more pseudoaneurysm formation. So a stent is more protective in that case. It can prevent, and there is also a risk of coil being displaced or coil going distally.
I am asking why not glue balloon-assisted
Sir, sir, it can go distally, it can thrombose.
That's why we are putting a balloon. Na? You have told na ki we are using combination directly.
Yes, sir.
So, I hope you have understood what Dr. Manu
Yes,
is
sir.
asking. So, in this case, yes, he is right, but we get so many subclavian artery pseudoaneurysms, and we normally put a stent graft. It was a large sac. Thrombin might not work well because recanalization rates are high, but as Dr. Manu has said, we can use glue. So I think in this case it was open wound also.
Yes, sir, that was a clavicular fracture.
Yes, in open wound, if you inject glue, that glue can come out and it will cause granuloma.
Yes.
But yes, we should have different options on the table when we get, and if like we can use that option in this case, when especially if the sac is accessible, it is easily seen on ultrasound, and the neck is narrow. But if the neck is more than 5 millimeters, then I would prefer to use a stent graft. Although people say that stent graft, because of the clavicle and the rib, there are chances of getting crushed. But in our follow-ups, the patients are doing well. So,
Thank you, sir. Thank you, sir.
Next presentee is Dr. John V. Alexander, OP40.
So, good morning, respected chairpersons and colleagues. So, I'll be talking about the role of angio-CT in prostate artery embolization. So, as we all know, PAE has matured a lot in the past few years, and it is one of the major treatment options for drug refractory BPH. So, the problem with PAE success is most of the times we might go for incomplete embolization, and there is marked variability of the prostatic artery. And the other thing is that we have to be very careful about the anastomosis, which can go to the bladder, rectum, or the penile region. Now, when we go for DSA, the limitation is that it is a 2D imaging. So, we will miss the vessel overlaps and the perfusion confirmation won't be there. Now, going to why we went for catheter angio-CT. Now, we have, of course, the availability of a hybrid suit is there in our institution. So, apart from that, we can actually see that after the DSA run, once we take a catheter angio-CT, we can see the perfusion. We can see the perfusion of the prostate, and apart from that, we can see the non-target perfusion also. And this actually converts the prostate artery embolization from an artery-based to a parenchyma-based PAE. So this was our index case. I am showing an index case where you can see the prostatic artery that is coming from the obturator, and we have done the superselective cannulation. And after that, we did an angio-CT. These are the VR reconstruction where you can see the formation parenchymal blush, and which was followed by embolization. So our study, it was over a period of 2 years, and we selected 24 consecutive men with symptomatic BPH. It was a retrospective study, and of course, the routine contraindications were avoided, and we selected the patients according to the guidelines. And our suit is the hybrid DSA CT, which is Siemens Artis Miyabi, 64 slice. And follow-up was done at 1 and 6 months. So coming to the workflow, so we went for transfemoral access in all 24 patients. And for intra-op identification, we inflated the Foley's bulb with diluted contrast. And 5 French diagnostic catheter, either RUC, Picard was used, and most of the cases we could cannulate easily with Picard. And after that, in most of our cases, we did not have a pre-procedure CT angio. So if there was any confusion in DSA, we would take a catheter angio CT even from the internal iliac artery, anterior division. And for that, the protocol is we can actually, we do this so that we can actually reduce the amount of contrast used. And for internal iliac artery angio CT, the contrast used is almost 20 to 25 ml with an injection rate of 2 to 2.5 ml per second. And once we identify the relevant arteries, we go for selective cannulation with a 1.7 microcatheter. after injection of NTG. And after that, intraprocedural angiosity is done to see for the parenchymal perfusion. And apart from that, we can see the cross perfusion also to the other side of prostate. And if there is any non-target embolization areas, we can see that also. So coming to the step-by-step workflow, coming to the last step where we can see actually the prostatic parenchyma enhancement, and post-embolization we can actually take a NCCT, same way, to see the completion of embolization. If there is any missing target area, we can look for any accessory feeders as well. So we did, even after just prior to injection of the embolic agents, we again give vasodilator so that there is better uptake, and embolization is done with 100 to 300 micrometer microspheres using perfected technique. So how angiosity altered in our cases? In about 40% of cases, there was change in decision making. We could identify accessory feeders in few cases, for which we did additional selective embolization. Few cases we could identify non-target blush, which was not visible in DSA, and for that we did microcatheter repositioning. And in 1 or 2 cases, inadequate parenchymal blush was seen, along with the non-target embolization site, so we aborted embolization in such cases. So these are few of the cases. Now this was a case where you could see that the angiosity is showing there is enhancement of the rectum. So this was avoided by catheter repositioning, and it was after that we forwarded with the perfected technique. Now this is another case where you can see, apart from the normal prostatic artery, you can see another supply from the obturator, which was an accessory supply. This was actually supplying the contralateral lobe. So this was also identified, and we could embolize the prostate completely. So coming to the technical outcomes, all the patients, we could do prostatic artery cannulation, but 2 patients we couldn't do, we couldn't do bilateral, it was limited to unilateral. This was due to anatomical difficulty. And there was, coming to the clinical outcome, there was significant symptom improvement in all patients, with the baseline IPSS coming down to 10 in 6 months, and quality of life index coming down to 2. So why angiosity matters? The prostate artery is notorious for its variant anatomy. So we can actually identify the prostate artery with precision and see if there is any abnormal parenchymal blush, which can go to the, which can lead to non-target embolization. So avoiding that is very important, because if non-target embolization happens to the bladder, to the rectum, it is going to create complications that are difficult to deal with. So this is actually very useful for that. And in cases where an operator is learning, this angiosity can actually give more confidence in identifying the structures and to navigate the complex pelvic arterial anatomy. So coming to the limitation, this was a non-randomized design and retrospective study. And the problem is that many of the institutions won't be having a hybrid DSA-CT availability, so that might be a limiting factor. And all the patients in our study were more than 60, so we are not very concerned about the radiation dose analysis, but with the angio-CT, we could actually reduce the number of DSA runs taken, so it was not that high. So coming to the conclusion, we can tell that angio-CT guided VA is safe and robust, and it can increase the precision of the procedure to a great extent. Thank you. Yes, sir.
Do you go for prior CT angio of pelvis in view of variations in prostatic artery origin?
No, in most of our cases, we did not take a pre-procedure CT.
If it has been taken, we could have reduced the patient radiation dose, our operator radiation dose. Definitely, China CT or expert CT on table itself has an edge. But looking at the variations in prostatic artery origin, we can go for a CT angio prior to embolization of prostate artery.
We can do that, but in our case, most of the patients were on the older side and they had borderline creatinine. So we did not want to overload the patient with more contrast. So most of the cases yeah, like 1.3 was, most of the patients had 1.3.
If we go for Yamiki classification,
yes, sir.
variations in origin of prostatic artery.
Yes, sir. Type 4, sir. Then. It was more like because we have an angiosity, we could actually go in and see the angulation also, the angulation that can help in opening up the prosthetic artery also nicely.
What I am saying, though we had an edge of
Dynasty.
but prior to origin of prosthetic artery,
Okay.
after having an internal artery, everyone goes for a
Pre-op setting. Yes. Thank you, sir.
Our next presentee is Dr. Shweta Chayapathy, OB41.
Good morning. I'm Dr. Shweta Chayapathy from the Department of Endovascular and Interventional Radiology, Apollo Hospitals. Today I'll be talking about our experiencing, highlighting how one target vessel, the uterine artery, can effectively treat 8 distinct and diverse obstetric and gynecological pathologies. Over the years, uterine artery embolization has evolved from a fibroid-centric procedure to multifunctional therapeutic tool. It plays a critical role in acute life-threatening hemorrhage, high-flow vascular anomalies, and chronic uterine pathologies. Our study illustrates the effectiveness of UAE performed for 8 distinct pathologies, which include pseudoaneurysms, arteriovenous fistulas, AV malformations, postpartum hemorrhage, retained products, adenomyosis, and of course, uterine fibroids. The objectives of the study was to analyze the indications for UAE, illustrate disease-specific responses, and highlight the multifunctionality of UAE. This was a single-center experience spanning over a time period of 2 years, which included a total of 55 participants. Majority of our procedures were performed under local anesthesia with conscious sedations. Standard angiographic techniques were used with superselective catheterization of the uterine artery. Embolic agents were chosen based on the flow dynamics and the target pathology. The most common pathology encountered was uterine fibroid, which constituted 49% of our cohort. The second most common pathology encountered was adenomyosis. Clinical success was defined as complete resolution of bleeding or significant reduction in the presenting symptoms without the need for repeat embolization or surgical intervention. At a 3-month follow-up, sustained clinical success was maintained in 93% of the total patients on whom uterine artery embolization was performed. Complications were classified based on the Society of Interventional Radiology criteria. Majority of the complications were graded as A or B, which included transient pelvic pain, fever, and amenorrhea. These were all managed conservatively. Highlighting the safety profile of UAE, there were no procedure-related mortality in our series. 12.7% of the patients had minor complications which were managed conservatively. Most patients returned to normal daily activities within 5 days of the procedure with a mean hospital stay of just 2 days. This is a case of a 37-year-old woman who presented with severe dysmenorrhea and frequent urination. Pre-procedure MRI showed a large fundal fibroid. Angiogram shows the dilated tortuous uterine artery. Embolization was done using PVI particles, and the post-embolization run showed good resolution. A follow-up MRI at 3 months showed significant reduction in the size of the fibroid, as well as good distension of the bladder. This is a case of a uterine artery fistula with the angiogram depicting the feeding arteries and the draining veins. Glue embolization was done and the post-embolization run shows the glue cast with preservation of the uterine vasculature. Post-procedure follow-up ultrasound shows the resolution of the vascular lesion. A 32-year-old woman post-cesarean section presented with secondary postpartum hemorrhage. Angiogram showed a large pseudoaneurysm. Selective catheterization and embolization using glue was done, and post-embolization glue cast showed good resolution. This is a case of a 27-year-old woman who presented with persistent bleed PV post-abortion. Pre-procedural imaging showed a vascular RPOC. Embolization was performed using PVI particles, and follow-up imaging showed resolution of the lesion. This is a case of a 29-year-old woman who presented with heavy menstrual bleeding with history of curettage in the recent past. Pre-procedural MRI and USG showed a AV malformation. Selective uterine artery catheterization and embolization with PVI particles showed resolution of the lesion. UAE has consistently demonstrated high success and low complication rates with excellent patient recovery. It effectively bridges the gap between medical therapy and invasive surgery. It is a revolutionary uterine preserving approach for a wide range of uterine pathologies, and it must be considered a first-line treatment option. Uterine artery embolization is no longer disease-specific. It has evolved to a strategy-specific therapeutic entity. Thank you. Sir, the mean age of patients in our study was 36 years old, most of whom had completed their families and they were not looking for any further pregnancies.
What literature says?
Sir?
What literature says?
Sir, literature in one of the largest studies says that out of 100 patients who had undergone uterine artery, about 9 to 10 patients had further fertility, sir.
Present, you still left to present?
Good morning, everyone. I'll present our study on the clinical and radiological risk factors contributing to recurrent hemoptysis after bronchial artery embolization. So in our institute, the following indications for bronchial artery embolization are being followed, out of which the second and third, that is, patients with moderate hemoptysis having recurrent episodes within a week, or chronic mild hemoptysis not responding to medications, are the most common indications which are being referred to us from pulmonary medicine. The hemoptysis grading is as follows. The methodology of the study was a single center prospective observational study carried over 18 months with universal sampling, and all the patients which were being referred to intervention radiology were included, apart from those who either did not consent for the study or those who had any contraindications. The study design, after the consent and exclusion criteria was ruled out, a detailed clinical history of the patients was obtained and CT bronchial angiography was performed. The bronchial artery embolization at our institution is performed. Firstly, it starts off with an aortogram. It is generally performed from the femoral axis. Flush an aortogram is done, and cannulation of the bronchial arteries is generally performed using the Cobra catheter, and embolization was performed usually using ProGrade 2.4 French microcatheters. Using PVA particles and gel foam particles gel foam was used as and when required. Follow-up, the patient was assessed for recurrence on short-term follow-up after 1 month and medium-term follow-up after 6 months. So this is the case of a 43-year-old male who presented with fever and as well as hemoptysis, moderate hemoptysis over the past 2 weeks. On CT bronchial angiography, the patient had signs of active tuberculosis in the form of multiple central lobular nodules and ground glass opacities. The next image we can see that the patient has both fibrobronchiectatic cavities as well as aspergilloma cavity, and the angiography revealed 2 dilated bronchial arteries on the right side. The images in the bottom row show the pre and post embolization angiograms, which initially showed hypervascularity and tortuous vessels, and in the latest images they are showing the cutoff. So as for the results, the average age of the patients was 45 years and 3/4 of the patients were male. Majority of the patients had moderate hemoptysis. More than 50% of the patient had history of chronic tuberculosis. However, 11% of the patients had active tuberculosis at the time of bronchial artery embolization. About the radiological factors, a majority of the patients had a fibrocavity. 15% of the patients had aspergilloma. 15% of the patients also had bronchiectasis. In terms of the angiography findings, 30% of the patients had non-bronchial systemic arteries, and a quarter of the patients had more than one dilated bronchial artery. So coming to the procedural outcomes, we obtained a technical success rate of 93%. Our success rate was defined as successful embolization of a culprit artery. So out of the 73 culprit arteries, we could successfully embolize 68. 5 non-bronchial systemic arteries could not be embolized. The reasons included, in most of the cases, excessive tortuosity and vasospasm and ostial narrowing. In one of the cases, the non-bronchial systemic artery was seen supplying the anterior spinal artery. Short-term hemoptysis recurrence at 1 month was seen in 4 patients, and medium-term hemoptysis recurrence at 6 months was seen in 7 patients. So looking at short-term recurrence, this is a comparative bar chart in which the relative proportion of each finding has been depicted. For the orange bars show the proportion of that finding in patients with recurrence, and the blue bars show the proportion of that finding in patients without recurrence. So as we can see, that the presence of fibrocavities, bronchiectasis, and active infection were seen in was higher in patients in the recurrence group than the non-recurrence group at short term. However, on applying the statistical analysis, which was a Fisher exact test, only the presence of active TB infection was deemed statistically significant with p-value of 0.01. When the same factors were evaluated for at 6 months, so the proportion of patients with aspergilloma and active tuberculosis were higher in the recurrence group. However, of the 7 patients with aspergilloma in our study, 3 had recurrence, but 2 of them also had active tuberculosis. So because of the small sample size, an independent analysis could not be done. In terms of the radiological factors, the increase in number of, there was an increased rate of recurrence in the patients with non-bronchial systemic arteries, as well as an increase in the number of recurrence in the patients with increased number of dilated bronchial arteries. So to summarize, the following factors were associated with a statistically significant increase in recurrence rate. That was active tubercular infection, in the presence of non-bronchial systemic arteries, and increase in number of bronchial arteries. Thank you. Sir, we chose the PVA particles, which was mainly an economic concern for us. Sir, for after the distal after the hypervascularity has gone and we are still seeing a very dilated proximal stump, we sometimes use a gel foam. It was used in 2 to 3 patients only in this study.
Why gel foam? Why not PVA?
So generally, we use PVA only, but if after a significant amount of time has passed and the vascularity is still not getting
Gel foam is a temporary embolizing agent, na?
Yes, sir.
We should have not used gel foam in bronchial artery embolization. Definitely the artery will recanalize.
Yes, sir.
Either use glue, PVA, or embosphere.
Yes, sir.
Thank you everyone for joining for the session. Thank you, jury. We are ending the session now. Thank you.
It's a wonderful day outside. So, interventional radiology. Welcome to the Global Interventional Radiology session at ISVIR 2026. Interventional radiology is evolving through global collaboration, shared learning, and sharing training pathways. This session brings together international leaders to discuss building the IR pipeline, bridging regional gaps in access, and strengthening education, mentorship, and support across borders. We are honored to have representatives from leading global IR societies sharing their perspectives and experiences. So let's begin the important and inspiring session. Our first speaker represents the British Society of Interventional Radiology. He is a consultant interventional radiologist from the UK and strong advocate for introducing interventional radiology early in medical education. Please welcome Dr. Raghuram Lakshminarayanan. Okay. Yeah, so unfortunately, I think he's with the other session. So shall I move on to the next speaker? Our next speaker joins us from Singapore. She's a senior consultant in vascular and interventional radiology at Singapore General Hospital and a leader in IR, education and curriculum development. Please welcome Associate Professor Farah Gillan Irani.
Thank you so much, and I'm sorry I got a bit late because of another session. Introducing interventional radiology to medical students, why early exposure matters. We all know why it matters. There's no reason for discussion. Because the thinking is that when you want to get interventional radiologists, you're fishing in the wrong pool if you're looking at people at their fag end of the radiology community trying to get into intervention. Professor Waugh is here, and she, along with me, we looked at what is the state of interventional radiology available within undergraduate students. And when we looked at that, the number of sessions, 1 hour for the whole year, is less than 1%. So there's basically no sessional time available for these interventional radiologists, and likeliness for them to consider an IR, therefore, is very low, is less than about 8%. So how does it work in India? We did this survey in India, myself along with Sham and Bibin, and there were about 1,024 respondents. 16% had a teaching session or talk related to IR in their entire medical school. So basically, when you look at it, once again, very likely to do IR is around 23%, and lack of awareness is around 61%. So essentially what it says, both from a UK perspective and an Indian perspective, is the exposure is very low and the lack of awareness is very high, and therefore people are not choosing IR as a specialty. Those QR codes will take you to those papers. So in the UK, there was an interesting thing that started. There's the BSIR juniors who are a community of medical students who have interest in interventional radiology. And the way it started was, it was started in 2019, by a set of medical students. They started deciding that these were very committed students who started deciding that they want to do something in IR. Then fast forward to June 2020, they did a session called Taste IR, and then they started doing other programs, and finally 2023, they got amalgamated into the BSIR as a BSIR juniors, and then various activities are done along with BSIR juniors. There's a podcast, there are sessions face-to-face, there are online sessions, and all these sessions are now supported by BSIR in order as an initiative towards these particular juniors. So the Undergraduate Radiology Society Network, there is something called RADSOC that are available in multiple medical colleges, and the whole idea is to try and dip into these RADSOCs in order to expand interventional radiology. So there are a lot of events that happen. One such event which me and Z are arranging is happening in February for medical students. It's the Yorkshire meeting. So there are a lot of meetings that happen for medical students. And the second thing that is happening in the UK is one has to do, after something like internship, foundation years, and then do clinical radiology and IR subspecialty training. So we have started providing foundational training opportunities right before they get in, so that they get a taste of IR. And then there is a direct entry into IR called the ST1 IR program. So when they enter radiology, there is a decision made that they will do IR. So they enter directly to it. So BSIR is acutely aware of this problem. We encourage RADSOCs to get collaboration going. And as of a few weeks back, we have brought out a BSIR visiting professorship, which will be a visiting professor who will go to medical colleges in order to inspire people. And we also support regional and national activities through these RADSOCs and IR Juniors network. With that, I'd like to invite you to the BSIR 2026 meeting, 4th to 6th November at the brilliant city of Birmingham. Thank you.
We can't load it anywhere else. Thank you so much, sir. So I welcome our next speaker, Associate Professor Farah Gilani Rani.
Good morning, ladies and gentlemen, and I thank the organizing committee for giving me this invitation to speak at the Global Summit. My talk is on the international IR curriculum, what can be common and what must remain local. It's quite difficult to actually synthesize all the data, but IR training and education remains very heterogeneous through countries as well as institutions. And I think that the IR curriculum should encompass these core domains of knowledge, which have been listed, basically the proficiency in imaging, technical skills, and longitudinal patient care in terms of clinical care, and professionalism, which mainly encompasses communication, ethics, and leadership. And all these should be tied together, centered around patient-centered care, audit, quality improvement, and your own personal ethic to lifelong learning. So then what must be international in this curricula? The most important thing is that the core procedural and knowledge competencies should be international. That means we should all be able to do a PCN, whether you do it in India, whether you do it in Singapore, whether you do it in Britain, it should all be the same. Safety, ethics, and quality standards in terms of radiation protection, operator safety, infection control, and complication management should be standardized. Ethical principles like informed consent and data-driven quality assurance should also be internationally governed. Assessment of structures and certification benchmarks, now these should also be internationally certified because examinations and certification schemes articulate the minimum knowledge and the minimum skill thresholds that we should have. And it also provides shared benchmarks that facilitate international recognition of competency and enable mobility of trainees as well as specialists across borders. I don't think the human body changes whether you're in America or in India, but we, as in medical certifications, don't allow that to happen. Sorry. And then why should it be international? Why do we want this international body to recognize these things? Because standardization promotes consistency, it promotes mobility and quality assurance, and irrespective of the geography. Standardized competence and global mobility, they facilitate mutual recognition of training. They support cross-border mobility of trainees as well as specialists, especially when you want to do collaborative networks, you want humanitarian initiatives, and whether you want telemedicine supportive IR services. You have engaged in research and educational collaborations because when you are trained in a certain way, you talk in a certain way, and this promotes multi-center educational initiatives, it promotes multi-center research initiatives, and also it allows for competency development and facilitates development of standardized online training resources. And patient safety and public accountability. International benchmarks convey to patients as well as regulators and hospital systems that IR practitioners meet widely accepted standards of training and practice, and based on a competency-based curricula and formal certification, you can then get good quality assurance, which safeguards against unsafe and inconsistent practices. And if you have this, this helps you also fight your turf war, because now you're not locally recognized, you're going to be internationally recognized. And that's why an international curriculum does become very important. Then what must be local? This is to account for the sustainable differences in disease burden and resource availability and health system organizations. So your curricula should also be based on local epidemiology and case mix. So you need to tailor your procedural portfolio to the routine and frequently seen procedures that are done in your setting. Local programs determine the procedural list based on local disease patterns, caseloads, and equipment access. And this is very important when you're talking about, say, a lower or medium income country where infectious diseases, related procedures, and maternal health related interventions are more important than, say, oncology. Resource-sensitive training pathways, it's important that you train depending on what your needs as a country are. You need to train people who can then go and work in very remote areas. So therefore, your training should encompass what your own personal needs, and that's why local becomes important as well. And regulatory, cultural, and educational framework should also be local. That means your colleges decide define your training duration, it defines your accreditation and your integration into the broader medical education standards. Cultural norms are also very important because they do determine communication, they do determine consent taken, and end-of-life care as well as decision-making. And your national service priorities in terms of workforce planning should also be determined at a local level because it increases the IR's presence in underserved regions. So why should you have a local curricula? Because it allows for flexibility, contextual relevance, and equity in medical care which has been given. It aligns with the local needs and the health system priorities. Therefore, it allows for directly addressing regional specific disease burdens, health system structures, and service delivery gaps. It adapts procedural content based to local epidemiology, and it allows tailoring of the IR's load to the regional needs and workforce planning, especially when you're talking about rural and remote areas. It also allows for the accommodation of resource constraints and growth trajectories. Just because you're a low-income country doesn't mean that you shouldn't have international standards. You should just base your international standards on whatever equipment you have and what procedures you can do. And once you get good at that, you can then further push it up, and your benchmarks can then evolve as your program evolves, as your training evolves. And you need to preserve regulatory autonomy and cultural specificity, and that's why it should remain local. And this is especially in terms of national educational traditions, means how much you're going to train, how much is going to be service work, and your existing postgraduate structures. And it also enables the curricula to incorporate country-specific medico-legal frameworks, consent standards, and cultural expectations around risk discussion and family involvement in decision-making. And that is why you need to have two sets or two thinking hats when you're designing a curricula. That is what you want as in constant standards and what can be local. So the hybrid model, you should have an international organization which provides an overarching architecture where you talk about the core procedural lists, the safety and ethics standards, generic competencies, and the exemplar assessment strategies, whereas your local institutions can contextualize and implement the international curricula at the local level, which can be locally relevant. This integrated approach leverages the strength of both the international as well as local governance, and it supports high-quality, context-sensitive training for interventional radiologists worldwide. And with this, we can then take our specialty to a higher level, whereby we can just be better than anybody else, and therefore we can fight our battles not as a single individual, but as a group, because your fist is always more powerful than your single finger. And with that, I thank you for your attention.
Thank you so much, ma'am. That was a wonderful session. So our next speaker, representing the Asia Pacific Society of Cardiovascular Interventional Radiology, head of interventional radiology at a major academic center in Australia and passionate educator in IR training. Please welcome Dr. Gerard Goh.
It's a pleasure to come to India and to be involved with this global curriculum and to share some experiences and discussions with some colleagues from around the world. So there are a number of different ways interventional radiology training can be outrolled. So it can be an independent training process, and historically this is a very common occurrence where a person or a doctor does radiology training first, and then they will do some advanced training or fellowship in interventional radiology. And in a lot of countries this is largely an unstructured process. Whereas there are some advantages of integrating this into the core radiology training, because when we do this, what we're doing is that we're identifying doctors who are interested in becoming an interventional radiologist, rather than trying to find an interventional radiologist from a pool of diagnostic radiology. Because a lot of doctors, when they make that decision, which is often a life-changing decision that they want to do a specialty, we're then trying to convince them not to do diagnostic, but then to do interventional radiology. And so this is a graph from the SIR website that shows a few different pathways where they've been able to arrange training either at the end of diagnostic radiology training or integrate it in part of radiology residency. So every country around the world has very complex relationships of how medical specialist training and registration occurs. And this is just an Australian one for an example, but there's oversight obviously by a government Department of Health, but then there are lots of different bodies such as a medical board or medical council, as well as different specialist medical colleges that all have input into specialist registration. And so as you can understand, it's quite a complex process. And so to navigate this, a lot of the specialist colleges, such as the radiology colleges, already have a very good understanding of this process. And so if we're able to integrate interventional radiology training into diagnostic radiology or the radiology residency, it allows interventional radiology to leverage all this knowledge and all these existing pathways and resources. For example, many of these colleges and societies have existing training and assessment pathways. There's training accreditation processes, selection processes, lots of different documents around standards of practice and a curriculum. So really there is a lot of advantage of being able to use the infrastructure of a college or training organisation. And so when we incorporate IR training into radiology residency, it's important that this process has to be driven by the interventional radiologists, because we are the ones who understand what we need out of our trainees. For those countries who have not done this, what you need to do is really to advocate the need for specialist or subspecialty recognition of IR, identifying that very first important piece of the puzzle. And from here, then it's about lobbying your local IR society or your college or your training body about why it's important and formulating a plan, because it really is a mountain of paperwork that you can't be done by one person. In fact, this is an image generated by Google Gemini. It was quite fun making it, but it really just shows that it can't be achieved by just one person. It's a group effort. And so I think the future in most jurisdictions around the world is that IR training should be part of radiology residency. We know that there are some certain societies, such as the Americans, where they've managed to do a separate training pathway, which is fine, but you really do need the resources to be able to do that. So I think the future is quite bright around the world. We're seeing IR specialization occur in lots of countries. And so by integrating it, just to finish, it also allows some of those diagnostic radiologists to think, okay, maybe I want to do IR as a subspecialty. And so we heard from a previous speaker that you can enter these early training pathways. It also allows those diagnostic radiologists who are a little bit further in the training, if they change their mind, that they're able to get some recognition of prior training towards interventional radiology. And also it allows the colleges to be able to grandfather the existing IRs in. So thank you very much.
Thank you so much, sir. That was a wonderful session. So our next speaker represents Sri Lanka and brings valuable insight to expanding interventional radiology access in developing healthcare system. Please welcome Dr. S. Maniharan. Over to you, sir.
Very good morning. First of all, I would like to sincerely thank ISVR for inviting me for this fabulous meeting. I'm Dr. Satyasilan Maniharan. I'm from Sri Lanka. I'm going to talk interventional radiology in Sri Lanka, bridging the gap between need and access. First of all, why we need IR in Sri Lanka? I think that we don't need to explain that IR is having very, with several advantages. IR is must. So if you take Sri Lanka is a small country, it's an island having 22 million population. Public sectors covers 95% of patient care with free of charge. Hospital beds, we have 4.1 bed per 1,000 population. You take radiologist workforce, we have less than 1, actually 0.78 for 100,000 population. It's very small compared to Europe, you can see the graph. And if you take the IR, is like even harder, you find people altogether, you can find less than 10 all over the Sri Lanka. But health burden is rising. I'm sure it's almost like India, is neighboring country. Stroke, still 6th leading cause of death, but we have thrombectomy facilities in just 1 hospital. And cancer incidence are rising. It has gone double since 2005 to 2021. And around 30% of cancers still be diagnosed at later stages. Those patients need palliation and treatment related to IR. And also there is a rapid rising requirement for vascular and hepatobiliary intervention and also neurointerventional procedures. What are the gap we have? We have, as I told you, we have very limited number of interventional radiologists. At the moment, only 2, and I mean, like, especially trained in IR consultants available in the country. And there are 9 trainees in the process. And there are few radiologists who can do the interventional. So at the moment, we have less than 10 people who can do the interventional radiology. And there is no separate entity for neuro IR or ped IR. So you have to cover everything from head to toe. If you take the infrastructure facilities, I mean, like IR suites and angiography facilities are only available in 3 hospitals where we have 5 suites. And the equipments and hardwares, I mean, like, it's expensive. So we have very much limitation with cost and availability of the hardwares. And it takes time, like, for even diagnostic imaging because of the infrastructure limitation. I mean, they have to wait for like weeks to months to get done the CT MR scan. So even with that several limitations, still we are progressing. I think we are moving good. And the good thing, we have started a local interventional radiology training pathway. It was started in 2017. So from that, the pathway, now we have like 2 specialists completed. And as I told you, there are 9 in the training process. And the interest of IR is growing. And regional hub, we are trying to establish the regional hub. As I told you, we have 5 suites at the moment. We are getting 4 more suites by next year. And another main issue we had, like getting the equipments. Even companies, we have few companies. There is no direct vendors, so they are only dealers. So now, unfortunately, the vendors also, we are getting now the numbers are increasing. So in addition, we plan to increase IR training position, and also we have to, we think to, encourage them to, giving the opportunities. And also, as I told you, we are getting the new angiography suits. And also, we have to, move forward and discuss with the clinicians. And we have to make awareness to get early referrals. That will be, help us to manage the patients early. And also, we have to, we are in the process to manage with, ministry, health ministry, to prioritize the IR needs. And also these sort of, these type of conferences and international things will be helpful for us. We will be getting opinion and advices. It will help us develop further. So the closing message, the need for IR is very clear. The skill and interest are growing, fortunately. And also increasing IR facilities and number of consultants gradually. So our challenge is equal access to all the Sri Lankan with IR facilities. I think the gap we will be able to achieve with a collective effort probably very soon. Thank you.
Thank you so much for the insightful session, sir. So representing the Bangladesh Society of Vascular and Interventional Radiology, Our next speaker will discuss opportunities and challenges in building IR services at a regional level. Please welcome Dr. Brigadier General Syed Sohail Alam. Okay. So unfortunately, he is not able to attend the session now. So we'll move on to our next speaker, representing the Korean Society of Interventional Radiology. Yeah. Speak on global training and research support in IR. Please welcome Dr. Hwan Jun-jae.
I'm Dr. Jae from Seoul, Korea, and I'm current Vice President of KSL. And today's my talk is about global training and research support in IR. Where do we go next? Global IR societies, a big picture. Historically, 3 major societies have played central roles in the field of IR. SIR in North America, SOCI in Europe, APS-CPR in Asia. So these societies serve as gateways for global training and research. Global societies can provide accreditation framework, curriculum guidance, seed funding for collaborative research, and platforms for cross-border networking. While historically, SL has been US-centered with a primarily domestic membership base. So it has a highly mature systems for training, certification, research funding. In recent years, international engagement of SIL is expanding. However, domestic role remains dominant in SIR. SOCI is somewhat different. It's a European-based, but inherently international organization. So SOCI actively collaborates beyond Europe. So they collaborate with non-European societies and IR communities in emerging regions. Also, they are very strong in structured education research network, especially in group memberships and EBIR certification. APS-CPR, it's a relatively young society, and it covers the best diverse AP areas. So we have several unique challenges in Asia. We have very large and diverse region. Also, we have wide differences in economic system, healthcare system, and IR maturity. And also, training and research systems are less standardized compared with SIL and SOCI. Of course, collaboration already exists in Asia. Training educational activities occur through APS-CPR, regional societies, and personal and institutional networks. But we have fellowship, visiting faculty program, joint workshop, etc. But are still fragmented and informal. So we need more structured collaboration. KSL have been contributed to regional IR collaboration. We made the annual international IR course, IICIR. It's a one-week intensive hands-on training program with animal labs. So we have built a network of more than 1,000 young Asian IRs over 22 years. Also, we have international fellowship program in Korea. So more than 100 fellows from Asia and beyond participated in this program. And we are focusing on long-term mentorship after training. Also, we have annual IG Live Symposium with real-world procedural teaching. So KSL supports the development of regional IR expertise through education, training, and long-term partnership. However, global environment is changing. While we have emerging global risks, including rising nationalism, geopolitical uncertainty, and global support may weaken in the future. So collaboration is becoming harder, not easier. But we need collaboration in spite of these global risks. Why? Collaboration still matters. You know, IR is tech-based, patient-focused, and solves problems. So gaps in training, research, hurt patient care. So no single country can fix this problem alone. So we need mutual help for sustainable IR growth. So each society is shaped by its religion, but all recognize the need for global collaboration. So the future of global IR will not depend on one society or one region. So where do we go next? I think the answer is together with shared responsibility and sustained collaboration. Thank you. Thank you for your attention.
Thank you so much, sir. So next, joining us from Nepal, our next speaker will share an inspiring model of cross-border mentorship and faculty support for emerging IR programs. Please welcome Dr. Amrit Koirala.
Are being set up. It's my honor and privilege to represent Nepal and NSVIR, and I would like to especially thank Dr. Kesava's leadership on this global IR forum. Although in a short notice, I can see that there are a lot of world leaders in IR here, and together from this room, I think we can make a difference. So just to give you, because many of you might not know about Nepal, so I'm just going to give you a brush up on how Nepal IR is. So for all of us in geography, Nepal is situated right between Asia, in India and China. So if you look at our terrain, it is mountainous. It consists of mountains, hills, and flatlands. So this is the geographic location. So our care is a bit difficult and challenged because many people lie where there are no transport access, and transportation is a major hurdle. And the IR services are limited to the major centers only. So the background, we have 30 million population. The population density is about 201 and increasing. And for now, the major IR centers are in these cities. And as I made the slides, there are also some provisions like in Nepalganj, in other cities also, there are in Tier 2 cities also IR services are being increased. So this is the Cancer Referral Center. I just want to give you an example that in the National Cancer Referral, the largest institution, we still do not have an IR. So that states volume of where our IR needs to go. So in terms of interventional radiology, we are still mostly focused on biopsies, drainages, ablation has been started, transarterial therapies, stentings, venoplasties, supportive cares, all have been started in our countries. So we are also taking part in PICC line, pain management, venous accesses. Neurointervention is something that has come up a long way. We are fortunate to have one of the neuro IRs of our country, Dr. Kajan, in our room. So in neuro IR also stroke, embolectomies, aneurysmal coilings, all these services are being done not only in the Kathmandu city, but in Tier 2 cities as well. So what are our challenges and limitations? So I have already talked to you about the geography. The main problem is unavailability of resources because we don't have that many cases, so the bigger companies, they don't have much interest from a business perspective view, but that is changing because now we can see that there's with more and more IR being done and more procedures, the companies have slowly started to show interest. Of course, our GDP is very low, so there is the question of individual funding because everything needs to come out from patient's pocket. So what we do, we invent and we improvise like all IRs do. So this is a case of by my friend where he snared dislodged an old forgotten biliary catheter through a Terumo wire, successfully making into a snare. These are our cath labs, like basic, rudimentary C-arm types. But these are also changing. Now we have full-fledged cath labs in most of the center. So we have constraints. That's why we use the 4 French Cobra to do a TACE without using microcatheters in large feeding tumors. So what are our achievements and progress? So since 2016, when we had the first meeting, coming to 2025-26, we have grown from a single individual IR and Professor Dr. Ram, who's our mentor and the guiding figure, to now a successful 20 to 30 practicing IRs. So these are our initial meetings. Many figureheads and well-known IRs were there. So we have been conducting meetings, we have been inviting colleagues through webinars, through physical, these things. We have been initiating the younger generation to pick up IRs, and that way the mentorships comes into play. I can see Dr. Amar's also in the picture. So these kind of mentorships, especially because India is so close and ISVIR especially so close to us, so we've been getting tons of help from ISVIR and centers from the region. However, for long-term training, we have a difficulty because of the registration issues, the legalities and stuff. But I think with collaboration, we can take care of that. We also need more of like brush-up fellowships for younger IRs who need to have brush up on certain procedural aspects, so that needs to be addressed. Now we are doing our own clinics, thanks to the Global Society. We have been, from the day one, we have had our own admitting privileges. We are working as a clinical consultant, and we have our own department and these things. So we are doing whatever we can. We don't have stereotactic, but we do a 2D biopsies. We are doing staplers instead of breast markers. So innovations are always there. So we use a simple skin stapler instead of a breast marker, just to show you how we innovate. So now these things have changed. We have now dedicated CTs, ultrasound in CT suites, cath labs, and now we are getting more and more job offers from the government, from the private sector. So this is also a good sign to show that the IR is taking place. So with regards to the cross mentorship, I would also like to request that, especially for the junior IR faculties, if any of the countries they are interested, we'd be more than happy to collaborate for any kind of training sessions, and we'll take it further. Thank you very much.
Thank you so much for an inspiring talk, sir. So our next speaker represents CERSI, one of the world's leading organizations driving educational and research in interventional radiology. Please welcome Dr. Daniel Wegg.
Thank you very much. Thank you for the invitation. I was asked to present CERSI educational and scientific resources supporting IR across borders. In 3 minutes, I will try to do my best. The main areas of our organization is education, certification, research, standards, and public relations. And as a representative organization, we invest a lot of resources into providing guidance on clinical practice through the production of relevant documents, and we encourage all our group members to use them. We also are very active in research. We have founded our own research organization to help collect scientific data. We do this in Europe, and meanwhile also in one of the studies we're collecting data from US and European centers, and we hope we will collect data from centers across the world in future. CERSI is, as it was already mentioned by the very nice Korean presentation, not a national society. We are by DNA an international organization with the aim to support the advancement of interventional radiology in Europe and globally. We're communicating regularly with more than 50,000 healthcare professionals worldwide, and we're working with 120 corporate partners in medtech and more also in pharma. And we have an exclusively IR dedicated staff at the CERSI office. We have a global membership. It was already mentioned, CERSI is based on individual and on group membership. You can see here the national and regional societies that are members of CERSI. And this means we have the pleasure to have over 10,000 members from 96 different countries. 85% of our membership is coming through national and regional societies, 15% is coming as individual members. 65% of our members are working in Europe in the geographical sense, and 35% are working in another region. And in 2025, we celebrated to be 40 years young. So I'm not going to present you our membership benefits list. This is on the website and you can read it, and most of you might know it, but I want to focus on some of the resources that we think are supporting IR cross-border. And one is an effort that we did, meanwhile, 16 years ago to define IR within a curriculum. We call it the European curriculum. And build on the curriculum, we also established an academy with 60 courses, self-assessment modules, and the option for students to train according an online platform which is covering the entire curriculum. We also put a lot of effort into maintaining educational volume, both from our congresses, but also when it comes to the CERSI vision that was defined in 2021, and be able to meet, share, and discuss this vision with leaders around the world, define actionable items, and provide access through the CERSI library, which is a very large online platform helping to provide access to almost 16,000 lectures. More and more, this platform is also used by our group member societies, which can upload their slides and presentations and make it available to a very large international audience. We're very active also in conducting webinars. We're doing webinars every second week, more and more also with international faculty. CERSI is publishing journals. One of the most long-standing journals in the field is CVIR. CVIR is the official organ of 23 national IR societies, and the editorial board consists of regional editors from all around the world. And we've recently added 2 journals, CVIR Endovascular, which meanwhile is also an impact factor, and CVIR Oncology, which was added just last year. One of the things that we restarted after the pandemic is the fellowship grant program, which has a yearly funding cycle. It supports international mobility of IRs and is a global outreach program, meaning that every member, regardless of where the member is practicing, can apply for financial funding to attend a minimum of 2 weeks or more in another hospital, and we're providing the financial means. We also, and I would like to say, support financially activities of our group member societies, but not only, also from our sister and brother societies around the world. We are actively participating in APCVIR outreach programs with supporting faculty, as well as with CD, and we're also collaborating with pairs. This is some nice testimonials of young IRs being trained at other hospitals, and I would encourage all of you, being leaders of your societies, to inform your young doctors that these programs exist, and if they are a CERSI member, they can apply. Of course, we're also doing congresses, and we hope that many of you, as you've done in the past, will continue to attend these meetings. We try to make them very accessible. We're running several European school courses every year, almost one course every month. We've added very recently a new conference, which is the European Conference of Image-Guided Pain Management. Then we have 2 congresses that are already there for several years, the European Conference of Interventional Oncology, European Conference on Embryotherapy, and of course our biggest meeting, which is the annual CERSI Congress, which has over 500 faculty from 15 countries and over 7,000 delegates from over 98 countries. Every year takes place in September. As we are a representative organization, we take a lot of time and efforts into building curricula and translating them into different languages, and as a consequence also providing an exam. It was already mentioned by several of the presenters today that the European Board of Interventional Radiology, which will have over 2,000 holders from this year onwards, has become a very international exam and accepted, and is very popular in different regions. We're very happy that over 550 ABA holders are actually practicing outside of Europe. Over 160 ABA holders are actually practicing in India, are members of ISVIR. And the first exam in another language beyond German, Italian, and Spanish will be the Portuguese exam in March 2027. And we've added a few more subspecialty exams, ABIR Endovascular and ABIR-IO, which people can take by documented experience after having taken ABIR. One of our most global programs is probably IASIOS, the International Accreditation System for Interventional Oncology Services, which is not certifying individual expertise, but it is accrediting a service line of interventional oncology in hospitals. It has been a very fast-growing system where IASIOS centers can receive accreditation, and by receiving accreditation also have access to membership services. Comes with different seals. You can see here an institute that applies, immediately gets an enrolled status, and once achieved the accreditation is an accredited center, and then goes further to being a center of excellence. I'm very happy to have one of the Asian Pacific institutes here who have received as the first one the Center of Excellence, which is Singapore. And we're in the process of refining our membership program within IASIOS, which goes towards educational opportunities, benchmarking services, marketing and promotion, as well as networking opportunities. And it is continue to grow. We think we will be over 100 institutes from 20, at that time probably more, but currently we're 91 hospitals from 29 countries, and as I said, in 26 we're expecting to get over 100 centers around the world, which are operating on a similar standard by providing longitudinal interventional oncology care. So as a conclusion, I've tried to give a snapshot or a quick look at our different activities. We think that if IRs are able to receive appropriate training, then they will be able to certify as interventional radiologists. Usually then they also have an interest to participate in research. Research leads to standardization. Standardization is something that we can talk about and do good work in public relations. So we think this is our contribution to supporting IR across borders. Thank you very much.
Thank you so much, sir. So joining us from Brazil, our next speaker representing SOBRISI, our next speaker will speak on Global Interventional Radiology Day and Global Awareness Initiatives. Please welcome Mr. Lucas Moretti Monsignor, and apologize for my pronunciation.
Good afternoon, everyone. It's an honor to be here to represent SOBRISI in this important forum. Can you see my presentation? Yes, yes. In the next minutes, we will talk about the World Interventional Radiology Day and why it matters, and officially introduce you to the campaign identity and the action plan for this year. It's important to say that this day is not only a celebration. This day is an opportunity to use it to find visibility, understood, and accessibility of our specialties for the patients, for the referring physicians, and for the healthcare system. Everybody talked about how important IR is in the many treatments we done, but we have to be seen, we have to be recognized. So this is importance. And why January 16? Because of Charles Darwin, this is everybody knows about. We talked about last year on CIRSE and the global forum that we had in Barcelona. So in 1964, Charles Darwin performed the first percutaneous angioplasty, and he's considered the father of interventional radiology. And what's for this year? It's almost the same idea from 2025 to make a visual identity and make a toolkit with some templates and
Lucas, are you able to hear us? Are you sharing your slides?
Yes, I'm sharing.
Okay, we are not able to see your slides. Yeah, now we can see.
No, I'm sharing. I stop and start again, but I'm sharing.
Yeah, now we can see it.
Oh, sorry, I'll share again.
Yeah.
Yes?
Yeah, now it's visible. Yeah. Keep it like that only. Don't change. Please go ahead.
Okay. So we talked about Charles Darwin, and the difference this year for 2026. It's the same idea for 2025. It's doing an online only celebration, and to use the same visual identity and to share this identity and some examples of social media and some templates so everybody can use at the same time. This idea of make it more globally was done after the last global summit on CIRSE, and we gathered CIRSE, SIR, and SOBRISI to make it a little more globally. But we had only a few months to do it, and also we have the Christmas and New Year to make things harder. But we did it. We create a new visual entity, and we're going to share and show you what are the dates. But at the January 12th, next week, we're going to send invitations for all the national societies. The 13 and 15, we're going to send the material so each society can share with the physicians, so they can use to create their own material, or they can use the templates to get the material with their logos and with their photos. And by January 16, everybody's going to share using the hashtag WorldRDay, so we can make a movement globally. And for the end of January, we're going to keep using some videos and some and the posts we have done to keep at least for January this idea to make it louder the day. These are some templates we're going to send you. One with which physician can use to in their social medias, and some other that are more telling what we do, and also you can use it to make it more personal, because every country has its problems. Some are more developed, others are less, so we cannot, we discussed this to do like a thematic year, but it's not what's going to be this year. And so this is now the call for action. We ask every society to join this this year, this idea, to share to their members, to share their templates, to do some more social posts, and to use this to make some videos, testimonials, and use it through January at least. So let's remember that this day does not belong to Sobrice, does not belong to SIR, belongs to every one of us. And let's use this as an opportunity to make people know what we do, patients, physicians, and healthcare systems. And let's make this year a really global movement. Thank you very much.
Thank you so much, sir. So our final speaker, Dr. Shyam Kumar N. Keshava, President ISVIR, representing Indian Society of Vascular and Interventional Radiology, and will introduce the World Federation of Interventional Radiology and its global vision for future of IR. Please welcome Dr. Shyam Kumar.
Hello everyone, we'll be starting with podium presentations on arterial interventions, part 2. I'm Dr. Shreya. And the jury members with us are Dr. Sabari Sundaravel sir, Dr. Virendra Sheoran sir, Dr. Chandramohan sir, and Dr. Karthikeyan Damodaran sir. And now I'll be inviting our first speaker. Before I invite you people, just make sure that you finish your presentation within 6 minutes. There'll be a single bell, and after that there'll be a 2-minute discussion. And after that there'll be 2 bells, and then you have to finish the discussion as well, okay? First presentee for the day is Dr. Roshan, OP27.
A 32-year-old gentleman came to the trauma bay with hemodynamic instability. His CD showed splenic laceration. So we decided to embolize him. So what do we use? Coils or vascular occlusion devices? Good afternoon, I'm Dr. Roshan Valentine. I'm a fellow in interventional radiology at University of North Carolina. And splenic artery embolization has been the cornerstone of treatment for splenic injuries. Traditionally, there's coils, and later there are a new vascular occlusion device which has been adopted. Hence, we decided to do this multi-institutional retrospective study where we compare the efficacy of coils to this device called the Lobo device, which is FDA approved. It's called the low-profile braided ocular device. In the market, there are multiple embolic options available, including coils, vascular plugs, and liquid agents. However, the primary aim of our study was to evaluate the technical and the clinical efficacy of the Lobo device in proximal splenic artery embolization and to compare it with the coils. Evidence-based, yes, there are just 2 studies where they have evaluated the use of Lobo device. So one is in pulmonary AVM, where they did a case series of 3 patients, and the other one was for splenic artery embolization for 3 patients. Patient selection, so we divided all the patients who underwent embolization with coils or Lobo into 2 groups, and we, based on the inclusion and exclusion criteria, the data collected were the demographics, clinical indications, embolic devices used, fluoroscopy time, and the radiation dose. And any adjunct embolic devices used, including apart from the coils, were also included. A brief overview regarding the device which uses the Lobo vascular occlusion system. It comes in 4 sizes: Lobo 3, 5, 7, and 9. Sizing wise, Lobo 3 for 1.5 to 3 mm vessels, we can use a Lobo 3. Lobo 3 for vessels of 3 to 5 mm, Lobo 5, 5 to 7 mm, Lobo 7, and 7 to 9 mm, Lobo 9. The thing is, you don't have to oversize the Lobo device because the unconstrained length of the device is only 10-20% bigger. Regarding the delivery system, for Lobo 3, you need a 2.8 French microcatheter and above, similar with the Lobo 5 will be 2.9, while the Lobo 7 and Lobo 9 use a 5.5 to 6 French guiding catheters. So what is technical success in this study? Basically, complete angiographic occlusion using the device. Clinical success is cessation of the hemorrhage without reintervention or bleeding within the 30 days. Safety assessment were done based on the SI guidelines, and the statistics analysis was done using the SPS software. The procedural metrics favored the use of Lobo device. So there were a total of 44 patients, of which 22 underwent Lobo devices and 21 under the coil group. And these are different indications which we did the procedure. So among the 20 patients, Lobo 5 was used in 9 patients, Lobo 7 for 12 patients, Lobo 9 for 1 patient. And among the coil cohorts, we had 20 patients using 111 coils, which means brings an average of 4.6 coils per patient. And the different coils which are used were the Nestor, Embol Fibered, Embol Soft, then MRI coils, and other detachable coils. So the adjunct agents which are used mostly in the coil cohort were, because of the recanalization or because of persistent flow, they used gel form onyx or glue or embospheres. So as far as the procedural metrics are concerned, yes, it's favoring Lobo because the fluoroscopy time is lesser for Lobo as well as the radiation dose is lesser. And the p-value for the fluoroscopy time was around 0.01 and for the radiation dose was around 0.04. Though the technical success was equivalent for both, but the clinical success where the patient rebled. We had 2 patients who rebled post-procedure in the coil group, while in the Lobo there was no reintervention or rebleeding within 30 days. Adverse events were minor, few complaining of pain and nausea. Mortality, yes, there was 1 death in each of the group, which is attributable to the polytrauma or unrelated to the procedure. Though there were lower splenic infarction group, lower number of splenic infarction in the Lobo group, but then we can't actually attribute it to the device because it can either be because of the cutoff of the supply to the spleen or because of the vascular insult during the trauma. And it does not statistically significant as well. So basically what this study showed was you just need a single device to deploy, a single device compared to the coils where you had an average of 4.3 coils for blocking the splenic artery proximally. And clinical success, yes, it showed 100% technical and clinical success with no rebleeding or device migrations. However, this study comes with its own limitations. Retrospective study and a smaller cohort size affects the generalizability of the study. And just like I mentioned before, there will be operator variability as well. And the splenic infarction, so we are not can't attribute it to the device or to the vascular insult. Another thing which we didn't evaluate was the cost effect of this device compared to the coils. But when it comes to the procedural efficiency, I think the cost isn't a major concern when the time is an important factor on that. Just case example to this was a patient who came to the splenic to the ER with a splenic trauma, and on celiac angiogram there were multiple small pseudoaneurysms, so we ended up deploying a Lobo 5, And this is basically comparing the artifacts of the coils and the splenic lobe. So for follow-up CTs, we'll have major artifacts if we use coils, which can degrade the quality of the images, while in the use of the lobe device, it's sort of crystal clear. So this is not a competition to the coils, but then it can definitely complement the use of multiple embolic devices for splenic artery embolization. The key advantages are single device deployment, reduced fluoroscopy time, and radiation dose with minimal imaging artifact. Maybe in future, larger prospective trials can be warranted to confirm long-term efficacy and the effectiveness. And this is my team. Thank you all.
Yeah, very good presentation.
Thank you, sir.
Good topic. Just one or two queries.
Yes, sir.
How do we explain lower infection rate in the two groups, and how these two groups were allocated?
It was not statistically significant. So the incidence of splenic abscesses were almost the same. So the infection rate is also would have been same. I'm not sure if that was mentioned in the slide. Infarction, yeah. So what the study shows, the more distal embolization you do, that is the one which causes infarctions. And if it is more particles like say gel form or embospheres, those are the ones which goes into the splenic parenchyma and the venules and the arterioles. Those are the ones which causes splenic infarction. But if you have the proximal embolization, we'll have all the collaterals which feeds up the splenic parenchyma, and those won't cause splenic infarctions.
How did you allocate these groups? Which group will have coils and which group will?
So this is a retrospective study. So we didn't.
But what was the criteria when you actually allocated these two groups?
So basically, does the procedure the intervention radiologist's ease of use. So because
ease of use.
Yeah, which is he is comfortable, which is they chose like they have to use a coil or a lobo, and because if the patient is unstable and you have just the time to deploy one device, that's when they use lobo. And not right now, if it is proximal splenic artery embolization, we have shifted from coils to lobo.
No, why I'm asking you this question? Did the clinical severity had some
Nothing.
implication on the decision making?
Nothing on that, sir.
Why? So there was rebleed more in the coil group in spite of using everything, right?
Yes.
So, I mean, do you think that at current where this device is not available, so everyone is like under-treating it? Like 33% rebleed was what you reported. So maybe
Yes.
the operator, whoever did not do a proper job, because coils are here for last 25, 30 years.
Yes.
And if it bleeds like 33%, we'll lose a lot of patients.
Yes, sir. I mean, can be because of probably the secondary to DIC after massive transfusion. It may one of those reasons which could have caused recanalization, sir.
Thank you.
Thank you.
Thank you. Our next presenter is Dr. John V. Alexander, OP34.
Good afternoon, respected chairpersons and colleagues. So I'll be talking about radial first approach for transfemoral versus transfemoral access in visceral and bronchial embolizations. So we are looking at the ergonomic and dosimetry comparisons of the two. So coming to the background, we can transradial access has been the norm in cardiology for almost 20 years. Now there is growing adoption in IR and neuro-IR. They have been increasingly done by transradial access. And visceral interventions have also been coming up, and transradial access is increasingly being used for the same. Now the problem with the different access is we have to just look at the cumulative radiation dose and the strain and fatigue that it will cause the primary operator. So this was the aim of our study. So study design, we did a prospective non-randomized comparative study. So our objective was to compare the technical success, complication rate, and radiation dose. In the inclusion criteria, we added any patients with age more than 18 years, which was indicated for visceral bronchial arterial angiography and interventions. And we excluded any patient who was unstable emergency, with, patients who were on shock and all. And exclusion criteria directly related to the radial artery, it was Barbeau waveform D, radial artery diameter 1.5, less than 1.5 mm, or if there is a only functional limb or injured limb, and any contraindications for DSA. So the endpoints, we checked the technical success versus the crossover, access site complications, ambulation time, patient satisfaction. And for the radiation exposure, we looked at the DAP and cumulative air karma. The personal dosimeters were not calculated. Then operator ergonomics was calculated using Borg CR10 perceived exertion scale, which is a validated scale. More of an ordinal scale where you can actually ask the operator after the procedure how much exertion he is feeling. So it is rated on 0, 1, 2, 3, 4, 5, 7, and 10. And more than 4 is considered as significant exertion. So coming to the setup, we did both distal and proximal radial access, and both right and left were done. The choice was completely operator dependent, and this was a setup for the left radial approach, which was our majority of cases. We preferred left because of the ergonomics, and it has been told in Yamada's study that a configuration in this way with a radiation screen shield between the operator and the patient will reduce the radiation dose almost 3 times in comparison to the transfemoral access. And the procedure variables we looked at were the dose area product, cumulative air karma, and the fluoroscopy time and total procedure duration. So these are some of the diagnostic runs, the uterine, renal embolizations, bronchial, and hepatic. Using different catheters, this we used an MG2, this was also MG2. Bronchial we used a SIM, and for hepatic MG1 was used. So if you look at the results, you can see that we did a wide spectrum of diseases. The majority were renal, bronchial, hepatic, and uterine. Both the groups, there was some conformity, but majority were renal and bronchial. Coming to the technical success and outcomes, we did 31 left radial, of which 8 were distal radial and 11 right transradial. Of the transradial, 41 were successful. 1 we had to cross over because the cannulation of the artery was not happening to the transradial route because it was not, the catheter was not taking the torque. And all TFA routes were successful. And the procedure duration, there was no significant change. The fluoroscopy time was also not significant. Our ambulation time, was already discussed in multiple studies, it was less. And coming to the operator ergonomics, you can see that for transradial access, it was decreased significantly in comparison to transfemoral access. But one of the confounding factor was that this was actually the cases were done on the basis of operator preference. So a complex case, if a complex case was anticipated, naturally there was a tilt towards the transfemoral access. That might be a confounding factor. Apart from that, the neutral arm and shoulder posture in the left radial axis would have contributed significantly. Then coming to the radiation exposure parameters, in the initial stages, the initial cases, DAP and air karma were actually higher for TRA. So, but with the learning curve, with the experience, it actually came down. So this was actually significant, but this was majorly because of the initial cases where the formation of Sims curve and the torquing of the catheter was a challenge in the beginning. But after that, the rest of the cases, it was mainly workflow dependent. Depending on the complexity of case, it actually increased. So we did a adjusted multivariable analysis where we considered the procedure complexity, and that came out that it was not significant. So coming to the exercise safety, we had TFA 4 minor complications, and same with TRA. In one case, there was minor hematoma. Other than that, there were no other complications. Radial artery occlusion was not there. No pseudoaneurysm or bleeds were there. The limitation is a single center study, and the main limitation is a heterogeneous procedure mix. There was no matching, and the access route was actually selected by the operator. We look at the anatomy, and if we feel like it is acute angulation, difficult to approach from ephemeral, we will go for radial. And in some of the cases, we'll just prefer it so that the table turnover time is also less if it is accessible from both the sides. So to conclude, both transradial and transfemoral are good, and they are equally effective. But transradial has a significant improvement when you compare the operator ergonomics. So this should be added to the armamentarium of the interventionist. Thank you.
Hi, thanks for the good presentation. Did you look at the procedure duration?
Yeah, the procedure duration, the mean was almost 78. It was almost the same. Yes, sir. So some of the hepatic cannulations were difficult, but at the same time, bronchial, which was done in TRA, we had to cannulate multiple arteries, so it actually equated that.
No, I just wanted to know,
yes, sir.
how did you evaluate the comfort of the operator inside ergonomic scale?
After the procedure, both the interventionists who did were using the skirt and waist type of lead apron. So after the procedure, once the procedure was over, subjectively we'll just ask him on a scale of 0, 1, 2, 3, 4.
That scale I understand.
Yeah.
What I'm saying is, what is the challenge with transfemoral vis-a-vis radial?
I mean, it's a good study, nothing against that.
Yes,
but
sir.
what we, sir, mean is, if you see the first slide, you're showing your cath lab, and where
Yeah.
you're puncturing, look at your screen.
Yes,
You
sir.
have to do like this. It's more cumbersome.
We are actually staying here, sir.
No,
And the screen is here.
I still agree. Uncomfortable.
Okay.
Believe us, we are working for last 20 years.
Yeah, from transfemoral,
it's
when you
not-
convert it, yeah, it
Number,
is.
One quick question.
Yes, sir.
Have you used any closure device for your femoral? It was a manual compression. Any
Yeah.
closure devices for transfemoral access?
Yeah, we have used multiple times, but there was a mix actually.
So I think you need a proper study
Proper
where
study,
you can
yeah.
compare apple to apple,
Yeah.
like in bronchial artery. So this is just a mix.
This was
Good
a mix.
initiative. Thank
Yeah.
you.
Is it the fluoroscopy and procedure time is same for procedures like bronchial artery embolization by routine? You didn't compare. It's an overall procedure.
Yeah, it is overall. We are actually, it's an ongoing study. We are actually taking out the data, and this was the preliminary data that we just compiled, sir. Thank you.
Dr. Abhijit Preetha Jaikumar, OP35.
Good afternoon. I'll be sharing a single center experience regarding the patency with interwoven internal stents and the factors affecting the long-term patency. So, as we know that SFA is a very hostile environment because it experiences torsion, compression, and elongation during the limb movement. And because of those issues, the traditional stents usually can get fatigue and fracture over time, and especially that is more prominent in the adductor canal. To overcome that, the interwoven stents has been developed, and because it is having a it is designed in such a way that it is having a high radial strength with flexibility, and it is mimicking the biomechanism of the SFA. But the evidence in very long calcified SFA lesion, especially in Indian patients, is limited. So we have evaluated the long-term patency and the predictors in stenting for complex SFA disease. So our study objective was, primary objective was the evaluate the primary patency and the technical success. The secondary objectives were to assess the clinical improvement and identify the clinical factors influencing the long-term patency. So ours was a retrospective single-center study with 66 consecutive patients. The inclusion criteria was that we included those patients who were in Rutherford 4 to 6, and Rutherford 3 patients if there was severe or disabling claudication, and or those patients who were refractory to optimal medical therapy. We excluded those patients who were Rutherford 0 to 2 and those patients who were presenting with acute limb ischemia. So the baseline demographics, most of the patients were male patients, and majority of the patients were either former or current smoker, and significant comorbidity burden was there in these patients with hypertension, diabetes, and CAD. Regarding the lesion characteristics, 2/3 of our cases were having occlusion or CTO, and regarding the calcification grading, it was majority of the cases were moderate to severe calcified, and the lesion average lesion length was around 164 mm. Now the procedural technique we did was that we most of the cases we took antegrade or a contralateral crossover, with few of the cases requiring a pedal access for CTO crossing. We emphasized the aggressive pre-dilation to achieve nominal deployment to minimize under-expansion or malapposition. And we did a 1:1 sizing to reference vessel diameter to minimize the chronic outward force. Regarding the results, the 6-month patency was around 89.1%, and 12-month patency around 78.3%, and 63.4 at 24 months, and 54.3 at 36 months. So in a long calcified occlusive cases with 78.3% primary patency at 12 months was quite good outcome. Then we also compared the primary patency with SFA and with the SFA plus PA lesions. Again, numerically it has shown that SFA only lesions has higher patency at all time points. However, statistically it was not significant, possibly due to the less number of sample size in SFA plus PA lesions. Regarding the clinical improvement, we are looking at we see that majority of our cases were Rutherford 5 initially, and in the post procedure these cases were shifted markedly towards the Rutherford 0 to 3 category, suggesting significant clinical improvement. Regarding target lesion revascularization, TLR events were rare. Only 6 cases occurred, and mostly these occurred within the first year. The other interesting thing we found was that all the lesions, all the cases which had a TLR had a very long lesions, and most of the cases had poor runoff. Now then we did a univariate analysis for the prediction of patency loss. It was found that diabetes as well as the Rutherford class as a significant predictor. However, as we usually expect, CKD calcification or lesion length has not shown any significance. Poor runoff has shown borderline significance. And we did a Kaplan-Meier survival curve for the patency in diabetes patients, and it showed that patients with diabetic showed lower primary patency over follow-up. Again, clinically this suggests that we have to go for aggressive risk factor optimization, especially in those patients with diabetes. And when we did a multivariable Cox regression analysis, diabetes mellitus remained an independent predictor of patency loss with a hazard ratio of 2.97. Other covariates were not significant in our model. And so basically our cohort was a high risk anatomy when we are comparing with other trials like SUPERB trial, where the mean lesion length was around 8 cm, but in our case the lesion was ranging up to 16.4 cm and above. And also most of our cases were CTO dominant with severe calcification, poor runoff. So with these high complex anatomy, we had a relatively good, around 78.3% primary patency at 12 months. And also in those cases where imaging has been done, no fractures were detected. So the clinical implication is that we should always opt for tibial optimization, along with we should also continue best medical therapy with short course DAPT. Limitations of our study was it was a retrospective single center design with moderate sample size, and future for next step will be a prospective multi-center data set for long segment calcified diseases. And the message to remember is that interwoven nitinol stents demonstrated a durable patency in complex long segment SFA disease, and diabetes was associated with reduced patency when we have to prioritize aggressive risk factor management. Thank you.
In your study, have you mentioned like the supera was elongated in how many percentage and compressed in how much percentage? And accurate deployment.
We tried to have accurate in most of our cases. We tried.
It's not possible. Nobody on earth can do. So that is very important factor. If you see on the super or initial trials, that your patency decreases with elongation and compression. So ideal placement. So that is very important when you study this stent, because you cannot, because your vessel cannot be prepared adequately. There are calcium, there will be a narrowing, so there will be an elongation. So that is one important factor. Thank you.
Our next presenter is Dr. Siva Chandra Sivaji. OP36.
Good afternoon, and I will be presenting on determinants of success in endovascular treatment of Indian peripheral artery disease patients. So peripheral artery disease, as we all know, it will have diverse anatomical patterns and comorbidities and outcomes in Indian patients. And global burden is around 200 million people. And endovascular therapy has become the primary treatment for CLTI, and prognosis post-intervention is influenced by multiple factors like patient-specific factors. So requires a careful stratification and case selection. So the objective and study design was that we have to identify specific variables contributing to variations in the endovascular intervention outcomes. And the study was prospective study, and participants were 131 and 132 limbs were underwent endovascular intervention. And data analysis was stratified into BTK, FEMPOP, and ioto-iliac and non-intervention subgroups. And technical success was where we were able to successfully recanalize the target vessel, and clinical success where there is a wound healing in 6 months follow-up time. So our patient group had like 44 patients for BTK, and ioto-iliac 38 patients, and 43 were a femoropopliteal subgroup. On non-intervention were around 7 people. Because of Berger disease, or there is no distal target vessel to revascularize. So those patients were put under the non-intervention group. So coming to the demographics, as we can see that the BTK had a older age group compared to the ioto-iliac disease group, and sex male has male is 85%, around 85% of people are males, and diabetes we can say it's common in the BTK group, and hypertension was equally distributed, and smoking was as common in ioto-iliac disease group. And coronary artery disease was more in the ioto-iliac disease group. So BTK group had the oldest mean age and the highest diabetes prevalence, and ioto-iliac group had the youngest mean age with the highest smoking prevalence. And there is a strong male predominance across all the groups. And vascular access strategies for ioto-iliac we favor the bilateral access, and for femoropopliteal group we used a balanced approach of contralateral and ipsilateral approach. And in this subset population where we did pedal access for 11 patients, and PTA we did for 10 cases, and ATA we did for 1 case. And BTK intervention mostly we did antegrade access, and antegrade SFA puncture we did around 71 out of the 94 patients. In ioto-iliac disease group, we further classified the disease like if type 1 common iliac artery where the lesion does not involve the internal iliac ostium. In type 2, the lesion includes the internal iliac ostium. So this is a distribution where we can see the occlusion is the predominant one, and external iliac also the occlusion is predominant one. In common iliac, the internal iliac ostium was most commonly involved. And angiographic severity for FEMPOP and BTK disease group, where we classified based on the class staging, and highest prevalence of severe stage 3 and 4 disease in the BTK and combined BTK plus FEMPOP group. And technical success we were able to achieve in 96% people, and technical failure were there in 2 patients in the BTK group and 2 in the FEMPOP group. And FEMPOP intervention as such, 2 we failed because there was arterial perforation where there is a in the popliteal artery we were not able to cross. Another case where we are unable to cross, and there was no retrograde access also. So post-plasty, the patient, there was no complication in 43 people, and complications happened in 11 people like dissection and recoil and instant thrombosis 1 patient had. And it was managed with suprastents, and few recoil was managed with balloon dilatation. And for BTK interventions, we tried to cross and reopen as much as possible, and we were able to do it for one infrapopliteal artery in 19 patients, and 2 for 14 patients, and 3 for and 3 infrapopliteal arteries were able to successfully, and none was successful in 2 groups. And coming to the clinical success, in BTK, we failed in 2 cases, and there was clinical failure for 1 patient and clinical success for another patient. And clinical success was around 33 out of the 40 patients. And for FEMPOP group, clinical success was in 2 patients where we couldn't do it, even though patient revascularized. And For FEMPOP, where we revasculated, it was 36 out of 39. And iliac, almost all patients were successful. And no intervention group, it was like 4 out of the 7 was successful. So coming to the lab parameters, which we try to correlate with the clinical success, we can see that this is Pearson correlation coefficient, and where we can see that the elevated inflammatory markers and renal dysfunction, poor glycemic control was strongly associated with the clinical failure, particularly in the BTK and iliac interventions. Conversely, the hematologic and lipid parameters showed minimal predictive value in this cohort. And this is the glycemic index, where we can see that the success had a less fasting blood sugar and a postprandial blood sugar, and failure patients had a higher one. And this is the box and mixer plot, where we can see the smokers and along associated with PAC years had a worse outcome. However, in our study, we found that the patient, when he had diabetes, contrary to belief that he had successful outcome. And CKD disease and CAD disease and severe disease had a negative outcome. And one proximal recanalization had better outcome compared to the distal revascularization. So this is a sample case where the left common iliac artery was opened and kissing stents were done. And this is femoral popliteal artery was opened, and patient had wound healing. So coming to the summary, the key predictors of clinical failure was C-reactive protein, ESR, and creatinine, and poor glycemic control also had. Comorbidity, smoking, and chronic kidney disease show the strongest negative impact on the odds of achieving clinical success. Thank you.
So you have done different zones of interventions,
yes,
like iliac, SFA. So how do you define your technical success? Do you compare the technical success with the clinical success in the different zones of interventions?
Technical success and versus clinical.
Clinical success. Clinical success is like
Wound healing. Wound healing, sir. Technical
so
success.
How do you define your clinical success at the end of the procedure, or in follow-up?
At follow-up, if the wound is healing, we will classify it as clinical success. If wound is not healed, then.
So there is no.
So we don't compare the technical success, right? It's only clinical.
It's only a clinical success.
In the sense, technical success, if we failed, I can't.
Fail means what?
Failed where we couldn't cross the cross the lesion, or couldn't do plastic.
Our next presentee is Dr. Arya J.S., OP37.
Good afternoon, everybody. So today I'll be presenting my paper on the topic midterm results of endovascular management of mycotic aortic aneurysms, which was done in our institute. So mycotic aortic aneurysm, it is actually difficult to diagnose. The main diagnostic criteria of this condition include, whenever a patient comes to us with an aortic aneurysm, we should be looking at the 3 following criteria. First one is a clinical criteria, then laboratory criteria, as well as imaging criteria. Any 2 of the following is present in that case, we'll classify that patient as a mycotic aortic aneurysm case. So after diagnosis, then comes the management part, which is actually challenging. The gold standard of treatment available for this condition is surgical repair. However, many of our patients were surgically unfit, and we were not able to do surgical repair in those cases. And even if we are doing a surgical repair, this may be associated with high mortality and morbidity in such patients. So here comes the need for an alternative treatment option, which can be endovascular treatment. However, only limited literature has been available till now for that. Now, ours were a single institutional retrospective study with 23 patients as the sample size, and the inclusion criteria were the patients who have presented with a clinical diagnosis of mycotic aortic aneurysm in the specified time period and who were not suitable for surgical repair and had underwent a TEVAR. The exclusion criteria included those patients with suspicion of inflammatory aortic aneurysm and those patients who had inadequate clinical or imaging or follow-up data. So the primary objectives of my study were to assess the technical success and perioperative mortality, then to assess the midterm to long-term mortality. The secondary objective was to look for the occurrences of reintervention. So now moving on to the results part, first about the demographics and baseline aortic aneurysm characteristics. Of the 23 patients, majority of them were males and the rest were females with a median follow-up duration of approximately 36 months. If you are looking at the risk factors, most of my patients were having hypertension as the risk factor, with 6 of the patients had concomitant pulmonary infection. All the patients had raised WBC count and ESR values. Now, if you are looking at the aortic aneurysm morphology, most of the patients had a saccular aortic aneurysm with rest having either fusi-saccular or fusiform aneurysm with lobulated margins. Now, moving on to the clinical aspects, most of my patients had chest pain as the clinical symptom, and if you are looking at the microbiological aspect, only 10 patients had underwent blood culture, of which only in 1 patient we were able to isolate an organism, which was Acinetobacter. Now, about the procedure and post-procedure details, 12 of our patients underwent TEVAR and 11 underwent hybrid TEVAR. In reintervention, we had to do reintervention in 2 cases who had already underwent TEVAR and 2 in hybrid TEVAR group. Now, if you are looking at the endoleak part, 9 out of 23 cases developed post-procedure endoleak. Now, if you are looking at the Kaplan-Meier analysis of endoleak, we can see that during the first year, there is actually a similar survival probability in patients who are having endoleak and those who are not having endoleak. However, as the time period moves on, we can see that after about 2 years, there is a drastic fall in the survival probability in patients who are having endoleak. Now, rest of the results. Technical success were seen in all our cases, and in-hospital mortality was seen in 1 of our cases. And if you are looking at the overall survival analysis by Kaplan-Meier curve, we can see that most of the mortality has occurred within the first 18 months of procedure. And if you are seeing at the survival probability, we can see that during the first 3 months, survival probability was actually better. It was approximately 95%. Thereafter, there comes the drastic fall in survival, and at about 18 to 24 months, there is a drastic fall in survival probability. Univariate analysis of factor predictive of mortality was done, but there was nothing statistically significant. It is mainly due to low sample size. So now moving on to the discussion part. Endovascular repair of mycotic aortic aneurysm is a safe procedure with good technical success, and 30-day mortality is very low, which was approximately 4.3% in our cohort, and 2-year survival probability was approximately 56%, which was actually similar to previously published data. And majority of mortality, if we are seeing this, occurred between the 3-month to 18-month period. So if we are planning to do a surgical repair to these patients, it will be better to do that within 3 months after TEVAR. Now, the strengths of my studies include, this is a rare disease cohort, which is one of the largest cohort of TEVAR in mycotic aortic aneurysm in South Asia with a real-world clinical relevance, and it is having a comprehensive midterm evaluation. Now, the limitations include, this is a single-center study with limited sample size. It is a non-randomized retrospective study design with a lack of multivariate analysis in view of limited occurrence of events. Now about the unmet need, it is actually about the need for an antibiotic impregnated graft. Here I'm showing the case which was done in our institute where the patient had 2 mycotic aneurysms, one in the distal aortic arch, another in the descending thoracic aorta. What we did was we have injected gentamicin into the sheath of the graft before deployment, and after that we have taken follow-up CTs which clearly shows exclusion of the mycotic aortic aneurysms. So now to conclude, TEVAR is a safe and effective procedure for mycotic aortic aneurysm. The immediate peri-procedure mortality rate is very low. However, there is need for antibiotic impregnated grafts in the future. Thank you.
So why do you think there was a high endoleak rate? You had like almost 9 out of 23 cases.
Sir, this is actually an infected aortic aneurysm. So even if we are putting a TVAR stent, the whole infective process will be still there. This may result in increase in size of the aneurysm, which may lead to occurrence of endoleaks.
So you tried to cover the normal segment,
we usually do like that. Approximately 2 centimeter of landing zone will be provided for all the cases, but still this infective process, this will keep on increasing, and this may result in formation of new endoleaks, sir.
Surprisingly, up to 2 years, they didn't have difference in survival.
We'll
Secondary intervention or?
almost some, in this cohort, actually 4 patients had to undergo reintervention, sir. Some were having endoleaks and we had to do intervention, and some were having a periaortic graft collection and all. We had to aspirate it with CT guidance. Then one patient actually had increase in size of the aneurysm where we had to put another TVAR stent, sir.
Yeah, it's quite common, but you didn't mention about knee intervention.
Yes, sir.
So what's the common presentation of thoracic aneurysms apart from this?
Sir, usually patient may be presenting with hoarseness of voice if it is aortic arch aneurysm. Otherwise, may be presenting incidentally also.
Mostly it's incidental.
Incident.
In your study, it was chest pain.
Yes, sir.
It's not very usual, but I don't know. We do a lot of TVARs, but patient doesn't come with I'm having a chest pain. It's unusual.
So in your institute, how will you decide the patients? Which patients will go for endovascular repair in terms of mycotic aneurysms? In terms of mycotic aneurysm, which patients will go for endovascular? Which patients go for?
Sir, for mycotic aneurysm, best treatment option available is always surgical, sir. However, most of our patients will be old age patients, and they'll be actually coming with some features of infection maybe. So they might not be fit for a surgical procedure many a time, sir. So those patients will be taking up for TVAR, sir.
In the case you've shown,
Yes.
I think there is a debranching done, right?
What, sir?
Yeah, there is a hybrid this case, yes. So
Yes, sir.
Debranching done and did the TVAR.
Yes, sir.
And then you did the TVAR. So if the patient is fit to go debranching, so why the surgeons did not operate for this patient?
Sir,
Considering it is a mycotic aneurysm.
debranching, actually, they'll be usually putting a neck incision, and it is comparing to the open aortic repair, it will be less morbid. It will be causing less morbidity and mortality, sir.
Good, better.
Thank you, sir.
Our next presenter is Dr. Saranya Narayanaswamy, OP38.
Good evening all. Myself Dr. Saranya from Sri Chitra. Today I am going to present my paper, Mid to Long-Term Results of Hybrid Aortic Arch Repair, a Single Institute Experience. So we all know that the gold standard treatment of aortic arch aneurysms should be an open surgical repair. The problem with open surgical repair is most of the patients will be high risk for surgery, that is one thing, and long ICU stay will be needed, and early mortality, that is 30-day mortality, is also quite high, approximately 10 to 15% of the cases. So there is a second alternative option available is total endovascular repair, where we have to do the fenestrator or chimney technique for the arch branches and then do the TVAR for the aortic arch segment. But here also it is not practically possible in all the patients because it is more cost compared to the other surgical procedure, and it needs more technically challenging also, and it needs expertise to do the procedure. So the procedure which will come in between the two, the middle ground, is the hybrid aortic arch repairs, where the vascular surgeon will do the surgical debranching. The debranching, they will do either extra anatomic, all three the aortic branches will be, they do the debranching anastomosis ascending aorta, if it is a zone 0 debranching, or if it is zone 1 or 2, depending upon that, they will do carotid bypass or carotid and subclavian bypass. So my study aim is to study the mid to long-term outcome of the hybrid aortic arch repair, only for the degenerative aortic arch aneurysm, and also to see the survival analysis and freedom from endoleak and freedom from reintervention. So it's a retrospective study. It is between 2010 and to 2024. Totally 173 TVAR done in our institute. Among that, only degenerative aortic arch aneurysm with the proximal landing zone coming to zone 0 to 2, who have undergone surgical debranching only included. Rest of the arch aneurysm cases has been rejected. So the final cohort was coming around 57 patients. So we followed up for a period of approximately 5.6 years, and we did periodical CT angiography depending upon the guidelines at 1, 6, and 12 months, and then year after. So after collecting the data, the statistical analyses were done using SPSS software, and we used Kaplan-Meier analysis for the survival and logistic regression analysis to identify the risk factors mainly associated with mortality and also the endoleak. So in our cohort, most of the patients were male, and most of them were hypertensive, and they had a smoking history also. So 26 patients underwent zone 0 debranching, that is the first image schematic diagram, and 23 patients underwent zone 1 debranching, and 8 patients underwent zone 2 debranching. And morphology of the aneurysm, 40% were fusiform and 60% of the aneurysm were saccular. And among 47, most of the stents we are using is Medtronic Valiant, and 8 patients we used Cook Zenith, and for 2 patients we used Ancora LifeTech. So now after the procedures in the outcome, it is from this table we can see that there is a both reduction in the length of the aneurysm and also in the diameter of the aneurysm post this hybrid aortic arch repair. So it denotes there is a early and a durable aneurysm shrinkage is possible with this procedure, similar to the total endovascular repair or surgical repair. So early outcome, here we are having excellent 30-day safety after hybrid aortic arch repair. The mortality was actually 0, and most of the patients were discharged within 2 weeks. 88% has been discharged within 2 weeks. And most of the complications, severe complications were 4 developed a stroke. Among the 4 patients, 3 had a permanent weakness, power of around 2/5 and 3/5. And 2 patients developed sepsis, and 1 developed the transient spinal cord ischemia that got resolved on its own, and 5 patients developed transient acute kidney injury, but they didn't need any dialysis. Then it comes the long-term outcome. We can see in the first Kaplan-Meier chart, the survival was on the end of 1 year, it was 92.6%, and in the end of 3 years, it's 82%, and at the end of 5 years, it was 73%. In the whole period, there were 17 deaths happened among 57 patients. Only 2 deaths happened in the first year, but it is not aorta-related death. 1 patient died, he developed a stroke, and then because of the prolonged hospital stay, he developed UTI, then sepsis, and then he died. Second patient developed MI because he already had a CAD. And then compared to the elective and emergency case, so mortality was, number-wise, it looks like the mortality was high in emergency, but in the log rank score, it is coming less. That is not statistically significant between the group. And in the long-term follow-up, the death was only 2 cases is aorta-related death. Most common cause of death in these old age people is myocardial infarction in my study, around 4 patients. Rest of the death because of the other causes. So we did the univariate analysis to determine what is the risk factor for the mortality. And from this forest plot, we can see that only the endoleak confidence interval is not crossing that 0 line. So endoleak is the only factor which is determining the risk of mortality. So coming to endoleak, 2 patients had a 1A endoleak. So both underwent a proximal balloon angioplasty and it got resolved. And 5 patients had a type 2 endoleak. Among that, only 1 patient, there is a continuous sac expansion was there in the follow-up CT. So he underwent procedure and then re-intervention. And then 1 patient had a type 3 endoleak, but unfortunately he died of contained rupture before the scheduled procedure. So total re-intervention happened was 3 patients. And then freedom from endoleak at the end of 12 months is 91%, at the end of 24 months is 85%. So next univariate analysis to identify what is the risk factor for endoleak, and it is as predictable, the graft diameter, whoever had a lesser oversizing of the graft, they had a more occurrence of endoleak. So graft diameter is the only thing that is favoring towards the risk factors contributing to endoleak. So my conclusion is that hybrid arch repair is safe and effective, is a middle ground between the open surgical repair and total endovascular repair. Endoleak is the only significant predictor of late mortality with the odds ratio of about 10, but it is, most of the cases, it is manageable only. So my strength is it is a large single center, homogeneous cohort is there, but the limitation is that it is not a RCT. Next in future, we have to compare with the open surgical repair and hybrid repair and with the total endovascular repair. Thank you.
So you have 30 days mortality.
Yes, sir.
So why there is a significant increased mortality in emergency group compared to the elective group after 30 days?
after 1 year.
The overall mortality is more in a
Emergency, but it was not statistically significant, sir, because compared to the elective group, emergency cohort was very less only. So that's why number-wise it looks more, but statistically it was not significant.
And what is your institutional protocol in terms of debranching and doing EVAR? You do it in the same day or you do it in a
Sir, first the patient will go for debranching. If they are well fit for the anesthesia to continue, general anesthesia to continue, we'll shift immediately from the lab to cath lab and we'll start with hybrid procedure. But in few cases, patient will go for the CS ICU. They have to stabilize the patient. Then only if fit, will come mostly second day only.
Here is Dr. Vishwas P, OP 39.
Good afternoon, everyone. My topic is retrospective observation analysis of a single-cent study of acute non-varicose uncontrolled GI bleeding, gastrovisceral and abdominal visceral bleeding, and emphasis on various techniques and approaches in complex cases. Active uncontrolled non-varicose bleeding, which is resistant to medical management, is usually an emergency condition, usually a common emergency condition. In such emergencies, tackling the hemodynamic derangements, metabolic alterations, and blood loss, and localizing the culprit vessel is of paramount importance. Approaches in the pediatric cases can be a big concern, and we have to tackle those cases. Aims and objectives of my study. This study primarily intended to emphasize on the tips and tricks in diagnosing GI and abdominal vessel bleeding vessels, and opine regarding alternate pathways, and to evaluate the safety and efficacy of DSA followed by embolization in same setting for acute GI and abdominal vessel arterial bleed. Study emphasis on the collateral pathways as endovascular backdoor or retrograde access via gastroduodenal pancreatic trunk in difficult failed front door accesses. The study also aims at feasibility and outcome of intervention management. It was a retrospective observational review study conducted from March 22 to March 25. A total of 102 patients who went either CECT or a digital subtraction angiography as the first sitting, and they are usually presented with an active uncontrolled gastrointestinal bleeding, which is non-varicose bleeding. All patients either underwent a triple phase CT or UJ endoscopy, but some of the patients had to be taken as a direct DSA setup because they were hemodynamically unstable. The variables which were used for assessing the study were technical success, clinical, and rebleeding or for 30-day mortality outcomes were assessed. Various techniques and maneuvers were used for diagnosing the aneurysms or the bleeding vessel, like pharmacological provocative tests during angiography and cone beam CT. Definitions: technical success is complete non-opacification of the lesion or an immediate post-embolization check angiogram. Clinical success is improvement in hemodynamic status and cessation of drop in hemoglobin levels and complete cessation of bleed. Endpoint for embolization is reflux of contrast into the feeder vessel. Result, there was technical success achieved in 100% of the cases without major mortality complications or bowel ischemia. Overall clinical success was 88.2% with 11.8 30-day mortality. 3 patients had repeat angiography for initial negative angiogram, while 2 patients underwent repeat embolization after rebleeding. The documented prevalence rate of bleeding is 9.8%. Prevalence was more in males, 86% than females. The patient cohort spans a wide range from pediatric to geriatric. Average age was 42.3. Then melena was the major presenting symptom, was 63%, followed by hematemesis. Then usually pancreatitis was the underlying cause in almost 2/3 of the cases, making it the most critical etiological factor. GDA and splenic artery were the most commonly involved artery, accounting for 70% of the cases. And most of the cases were embolized using coiling and combined with a liquid embolic agent. Then, as I had mentioned earlier, the male gender-based, male were more than female, 86% versus 13%. Median age was 41.5 years. Then clinical presentation, melanoma had 63% of the patients presented with melanoma, and hematemesis in 22% of the patients. Arteries involved was majority gastrointestinal artery, 35%, and then the sphenic artery, 34%. Outcomes and follow-up. 49% of the patients are asymptomatic till date or the last follow-up. Then 12% of the patients died after procedure within 30 days, either because of either due to other comorbidities or due to the bleeding or rebleeding. Then 16% had lost to follow-up after being asymptomatic for a period. 10% of them had a recurrence of bleeding. Then 9% of them asymptomatic for a period, then they died, which were unrelated due to unrelated causes. We had a protocol of using a provocative test in case of there is minimal extravasation or if there is no feeder vessel, if there is no bleeder vessel seen. The provocation was using heparin, dose of 2,000 to 6,000 international units, or sometimes use TPA thrombolytics. Altiplase was used, average dose of 5 milligrams. And then in case of mesenteric vessel spasm and vasodilator was used, most commonly was used was an NTG, intraarterial dose. Average dose of 50 to 200 microgram. And sometimes multiple aneurysms were seen in pancreatorenal arteries, which were missed initially. So my advice was that we have to check for multiplicity of these aneurysms, even after the first, even after the visible aneurysm which were coiled. In case of pediatric cases, dedicated hardware required. Then the left gastric artery pseudoaneurysms, which were difficult to cannulate because of their acute turn, upward turn, we had to do percutaneous access into the aneurysm and embolize the aneurysm. Arc of Buehler pseudoaneurysms and malcompression also had a very tortuous course, and we couldn't navigate the catheter distally across the aneurysm, which also had to be done by a direct puncture ultrasound gas unit. In sphenic artery aneurysm, our protocol of institutional protocol was either to do destruction versus reconstruction approach. Distal sphenic artery, main sphenic artery aneurysms, we preferred a reconstruction over destruction, whereas proximal we chose destruction versus reconstruction because of good collateral supply if it can to prevent a sphenic artery infarcts. In case of hepatic artery fusiform aneurysms, either due to trauma or post-operative, we chose to preserve the artery to prevent biliary complications. And in case of tumoral bleed, usually tumoral bleed were bowel related. So we used the microcoils to embolize the feeding bleeder vessel, because using of particle matter can cause necrosis of the bowel, and patient had to undergo resection, which was observed in our study. So we preferred microcoils to prevent to reduce the bleeding risk. And cystic artery pseudoaneurysms, which was seen due to trauma or pancreatitis. Here we had observed that the liquid embolic agent had a higher morbidity than coils. So coils were safer than the liquid embolic agents. Some of the cases of rectal angiodysplasia were also done where microcoils were preferred over the particulate matter.
Nice presentation. So next time, try more pictures.
It's there, sir.
Okay?
Yes, sorry.
Practice well in 6 minutes.
Yes, sorry.
Our next presenter, last for the session, is Dr. Vipin.
Good afternoon, everybody. So I'll be discussing about evaluating the role of TACE in sub-3 centimetric HCC lesions, which is an observational study. So a brief introduction, as we all know that HCC is a leading cause of cancer-related deaths worldwide. and INASL, that is Indian National Association of Study of Liver, which suggests the treatment guidelines, and it says that very early stage and early stage lesions should be treated with either transplantation, resection, or ablation, as the same can be seen in this chart. And the intermediate size larger lesions should be treated with TACE. So in early stage HCCs, the patients who do not fit in the do not fit for the resection and transplant criteria, ablation is recommended for those patients. And for those patients who are selected for ablation, still we have clinical challenges, like in the form of if the lesion is exophytic, or the lesion is located centrally, or if it is near vital structures. Then in such scenarios, super selective TACE may be considered. So aim of the study was to assess the safety and efficacy of conventional TACE in sub 3 centimetric HCC lesions. Our objectives were to assess the response rates and local recurrence following TACE, and also potential role of TACE as a treatment option. Inclusion criteria included all the patients of HCC who are undergoing TACE. The lesion size should be less than or equal to 3 centimeter, where the ablation could be difficult. And the lesions should be newly diagnosed lesions. And exclusion criteria included if the lesions are multiple, that is more than 3, and previously treated lesions were excluded, and if the size is more than 3, that lesions also excluded. So this was a retrospective single center observation study done over a period of 12 months. And a total of 143 TACE procedures were done in HCC patient. Out of them, 36 patients had less than or equal to 3 centimeter lesions. And a super selective TACE was done for these patients. Like we did it through right femoral access. After that, common hepatic angio-CT was done, and then the tumor was identified, and 1.9 French microcatheter was used to target the reach the target artery. And finally, the embolic agent in the form of doxorubicin, along with lipidol emulsion, is injected in these patients. So post-procedural follow-up was done using either contrast-enhanced MRI or CT after 4 to 6 weeks, and Lyred's criteria was used to assess the tumor viability. So these graphs are showing a few of the demographic findings. Like here we can see that more than 50% patients fall under the age group of 50 to 70 years of age. Most of the patients were males. And if you talk about the etiology, the majority of the patient, 72% patient had a history of chronic hepatitis C, and remaining 28% patient had hepatitis B, MESL, ethanol, or NASH-related HCC. This chart shows that our 64% of the patient did not have any prior history of any treatment, and 36% patient had prior history of treatment, but with a new lesion. Here we see that around 50% of the patient had lesions located in segment 7 or 8, high up in location, and around 14% patient had lesions in caudate lobe. So this is the flow chart showing exactly what has been explained, and we did technical success of 100% in all the 36 patients, where we find out in the follow-up scans that 77.8% patient had non-viable lesion after the TACE, and equivocal response was seen in 11%, and viable lesions were in 11% of the patient. So objective response of 88.9% was achieved as per this study. So we also came across few complications in the form of post-embolation syndrome, which attributed to 16% patients, and a transient elevation of liver enzyme was seen in 41% of the patient. One patient also reported puncture site wound. However, there was no evidence of any pseudaneurysm. So this is one example of a 75-year-old patient of HCC. This is a pre-TACE scan where we can see a artery hyperenhancing lesion seen in caudate lobe. Post-TACE after 6 weeks, we can see there is good lipidol uptake and no residual enhancement of the washout seen in this scan. Another example of 65-year-old male of HCC. This is a pre-TACE scan which shows that arterial phase hyperenhancing lesion. After 6 weeks, this scan was done, and then here we can see it still shows enhancement on arterial phase and a washout on the portal venous phase. So this was the example of one of the lesions which were viable after the TACE. So to discuss, our study demonstrated that super selective TACE can achieve effective local tumoral control in small lesions of HCC. We also compared our study with a few of other studies, like a study done in 2022, where the response was assessed after 1 month, and which showed that complete response was seen in 55% of the patient and partial response was seen in 20% of the patient. Another study was done in 2024, where 67 patients were assessed, and 67% patients showed of complete response, and around 30% patients showed partial response. This study was also compared with the microwave ablation study, which was done in 2025, where it showed that 78% patients showed complete response, and 22% patients showed residual disease. So by this data, we can see that our study also showed the comparative results with these studies. Also, we can infer with these findings that super selective catheterization likely contributed to high rates of devascularization, reduced non-target embolization, and favorable safety outcomes. As we use the Lyrates criteria, it also showed that also proven to be a reliable marker of treatment response. We also had few limitations, like our study was a retrospective and single center study, also had a small sample size. Also, as we only included follow-up from 4 to 6 weeks, so long-term survival and recurrence could not be assessed. And also, we didn't have any comparator arm like to compare other treatment techniques for this. So to conclude, the super selective TACE is a safe and effective treatment for HCC having lesions less than 3 centimeter, especially in the lesions where the lesions are located higher up in the location, and also for selecting the treatment treatment options for these HCC lesions, we should look into the tumor location, vascular anatomy, liver function, along with the size of the lesion. So to take home point is TACE should be viewed not only as a palliative tool, but as a potential definitive therapy in selected small HCCs. Thank you. Thanks.
Thank you all for attending the session. Thank you, jury. Thank you, everyone.
Interventional radiology, what every IR should know. So I welcome Dr. Suyansh Kulkarni, who is the chairperson for this talk. And may I invite Dr. Shrikant Murthy.
So thanks, and probably it is surprising to have so much of audience for a radiation safety workshop, but it is probably because of the industrial symposium that probably we have it. But good that this is a very important topic for all of us, because all of us spend the whole career in radiation, and that is something which is an invisible harm that is occurring to all of us, but we do not realize it unless it manifests at some particular disease. And not to mention individually, but there are many interventional radiologists who have developed malignancies of various types because of radiation exposure. So when we are using this modality day in and day out, and we are all going to spend whole of our career in this modality, it is very important that we are sensitized about the taking care of ourselves as well as our colleagues. Patient we are all committed to, but apart from that, what kind of exposure we are getting, that we should be. So overall, we should be developing a radiation safety culture in our department and in our day-to-day practice of radiology. And for to discuss this very important topic, we have got a very eminent faculty. He is Professor Shrikant Murthy, who is professor at Amruta Institute, and he is very passionate about the radiation safety culture, and he will be enlightening us about how to take care of ourselves when we are spending our hours in the radiation field. And along with that, I will also request some senior faculty like Sanjeev sir, then Hirdesh Sahani sir, Sanjay Sharma sir, to give your inputs, because we know that some of our colleagues who have got this radiation exposure and they are suffering with life-threatening diseases. So I will request Dr. Shrikant Murthy to deliberate his lecture. Thank you very much.
Thanks, Suyash. Good evening, everybody. This talk was supposed to be preceded by a presentation by an AERB official, and that didn't happen because he became unwell. So I sort of little bit extended my talk just to fill in a few minutes. The idea of this particular presentation was to focus on the second most important person in the whole picture of radiation inside the lab. The first is, of course, the patient. The other is, of course, the interventionalist and his team. So anyway, I will speak a little bit. That extra little bit is about the patient. That is itself a very large topic, so, but I want to just touch upon it because more dose for patient is also equal to more dose to the operator. Now there are two cath lab metrics. That means when you see the dose report in a cath lab, you will have two different metrics. Now in the CT scan, the dose metric is only what is known as a DLP, the dose length product. There's only a single dose. But here you have two metrics. One is a metric for the deterministic effect. That means that which basically translates into the skin dose and getting dermatitis and ulcer and all that. So that in physics it is called as air karma, that is cumulative air karma, which is expressed as milligray. Right. Now the second metric that is there in the cath lab dose report is the one that takes account of the total dose that has been given to the patient. That means it not just a skin dose, but also it takes into account the collimation used, so that it is a dose area product. So for simply, it's many times called DAP, but sometimes also called CAP now, but easy thing to remember is DAP. That's what uniformly used. So if you see any company's dose report, other than Siemens, of course, Siemens is very complicated, but the Philips and GE would give it as a DAP. DAP is a stochastic effect. That means the total dose given to the patient. But of the two, what is critically important is the skin dose. Because the total dose given to the patient and the patient coming back with a cancer will happen many decades later. You are not going to be their patient also, maybe somewhere else. We don't have a problem with that. I mean, problem in the sense, practical problem. But dermatitis, patient is going to come back after 2-3 weeks. So that is the determining factor here. So this is very important to understand this. Now, I just wanted to tell you a little bit about, this is where I added a little bit, this is about the cath lab geometry, just to give you a very basic idea of why and how the dose is calculated, okay? Now this is a typical geometry. You can see that C-arm with the cross-section of the patient on the gantry, and the tube is below and the detector is above. Now that plane is the isocenter. Every cath lab has an isocenter, the machine has an isocenter, and we are supposed to place the patient on the isocenter. So the center of the body is at the isocenter, okay? Simple. That is the anteroposterior dimension of the patient. How much is it? Now, a CT phantom, when you do a CT abdomen, the assumption is that the diameter of the body is 32 centimeters. But that is a rough figure. For a cath lab purpose, it's taken as 30 centimeters. So, what happens? This particular point where I put a star, that is the place where the patient, skin of the posterior aspect of the patient will come. So from the isocenter, that point where the patient's skin will come is naturally how much? 15 centimeters, half of 30 centimeters. So this is what is known as the interventional reference point, IRP. Sometimes it's called simply reference point, RP, in many those things. Now what happens is the machine calculates how much is the air karma or the energy deposited in air 15 centimeters below the isocenter towards the tube. That is what is calculated. Very important point you have to understand is machine does not know where the patient's skin is. So that is a point that you need to remember. Machine will automate, just imagine that point in space, in air, and will give you a value. So air Kerma display is in milligray. So you will have 1000 milligray, 2000 milligray. So the critical number to remember here is 5000 milligray, because at 5000 milligray or 5 gray, we cross the threshold of permanent skin damage. So the threshold or the is actually defined in ICRP as 1% incidence. This is a very important slide I wanted to explain to you. Now, this particular point, in all the 3 configurations of the tube and the detector, is the reference point. Now, in the very first configuration, you will see that the skin of the patient is above the Oh, this is not coming in the white background. No problem. See, it is coming here, below the patient. This is actually a very good situation. That means you raise the table and take the patient's skin away from the reference point towards the detector. Now what happens here is the machine will just give you the value at the reference point. But patient's skin is above the reference point in this situation, so the value that the patient's skin is getting will be less than what is displayed in the machine. This is one thing we have to remember. So even if you are hit 5000, you may actually be much less if your positioning is like this. But look at the second configuration. There, the reference point and the patient's skin is matching. So you will have the value that you're getting and what you're getting with the patient's skin will be more or less the same. But most important thing is, when you have a lateral configuration like that, what is happening? The reference point is inside the patient. And the patient's skin is very close to the detector. So rather, to the tube. So what happens is, you will get a reference value of 3000 or 4000, you will think you are under 5000. But actually you would have crossed it because your patient's skin is much closer to the tube. So this is very important to remember. This is just not a very intelligent metric. Okay, the machine just gives you the reference point data, but you know, or you should know where the patient's skin is. So complex angulations, you have to be very careful. This is just to give you one small point actually. The biggest attenuator of the X-ray beam as far as the operator is concerned is the patient himself or herself. So under couch tube, you have actually a significant attenuation of the X-ray beam. And the lower the tube, the gantry is, and closer it is to the tube, more will be the scatter. So lifting the table is good for the patient's skin rather, and lifting the table is also good for the operator. One important thing you guys have to remember is, with just a 10-degree tilt there, your dose will go up 2 times. Your scatter to the operators goes 2 times. A 30-degree tilt, which 30-degree tilt is very common in our situation, would actually become 5 times dose to the. Of course, that happens classically in a LAO situation, where the tube comes towards the operator side and the detector goes to the other side. So LAO projections in a classical situation where you are standing on the right-hand side of the patient is very tricky. You need to minimize this, at least be aware of it. Very important question, what is actually the correct patient or table height in a cath lab? Now, this is the same image. That is something called SID, source image distance. The source image distance is also displayed in some of the dose reports. Okay. Now, a source image, this is very simple. This machine is using an automatic exposure control. So the distance increases, SID increases, the machine automatically will give more dose. So that blue line is the source to skin distance, which I have already spoken about. If it should be something as far away, that is more the SID, less will be the patient dose. Agreed? Now I will talk about how raising the table, what happens. When you raise the table, what happens? You need to sometimes raise the tube also, or rather the detector also above, right? Because there is otherwise, how will you raise the table? There's no space there. You have to raise the table, you have to raise. So when you raise the table to actually relieve the patient's skin dose, you're also automatically increasing the SID and increasing the dose in another way. So there is a trade-off there. You understood? When you raise the table, you need to also raise the tube, rather the detector. So the SID increases, though these two things play against each other. But doing that, it is good for the patient because the skin dose is less because it is going up, and because the maximum scatter is when the table is close to the tube. So for the operator also, it's good that you raise it. So ultimately, exactly where you keep it would be a matter of your convenience to some extent, because suppose you are a tall operator, it's very good. You can raise the table and operate. But suppose you are a tall operator with a short assistant, you will have to keep it somewhere in between. So this is basically, it's something like this, you know, you will have this kind of a dilemma, right? So it is important to remember this.
Shrikant, just to interrupt, if you can go back to that slide. I will request my students to note this, because this is something very commonly asked in your DM and DNB exams. And the rest of the knowledge is very good, but when it comes to radiation protection, and if we ask, if we get the table up, whether the radiation will increase or decrease, the students are, so those who are exam going, please note that these are certain important diagrams and there are certain important questions that will come to your exam.
Okay. The other thing I didn't mention is lowering the detector finally. So you reach a good stable top. You should not leave too much of a gap on top also. So you have to lower the detector to a reasonable extent close to the patient's skin anteriorly also, because you can also get scatter from there if you leave a large gap there. Okay. Very important question. Now I want to get out of that and talk about the operator. Okay. So what do we have in terms of numbers? All these numbers we spoke about regarding stochastic effect, air karma for the skin and all that is for patient, not for the operator. So now for the operator, we just have this badge. That's all we have, okay. So fundamental question, where do we wear this badge? Okay, now answer is on the left side of the chest under the apron, okay. You're passed, boss. Because I have had so many of my MD students passing simply because the rest of the theory and practical is useless, but you know, they finally answer this question in the Viva and you pass them, okay. Now, problem is when we actually work in the cath lab, we are all the time talking about SIR guidelines, you know, European guidelines and so many other Japanese or Hong Kong or whatever it is. But are we on the same page of those people as far as this is concerned? Actually, no. If you were to answer this question like this in the American board exam, you have failed. What the ICRP recommends is actually, we wear two badges. One badge should be over the apron, outside the apron at collar level, left side, and the other should be under the apron, either on the chest or the waist. Okay. Now, this is an ideal thing. This recommendation has been there since the year 2000 actually. So it is not something new. And, but many countries have obviously a problem with this kind of a two badge thing. It's a very expensive business. And plus, if you're wearing one outside and one inside, you should make sure that tomorrow you wear one like that today, tomorrow also the same badge should be worn outside and this other badge. If you start interchanging it, then the whole purpose is defeated. And as such, compliance with wearing badges is a problem worldwide. That ICRP totally agrees on that. So many countries don't use two badges, okay? So in Europe, for example, some countries use only one badge, they may wear it inside, some countries wear it outside. So just like in India, there are countries, advanced countries also, where the one badge is worn inside. But what does the NCRP, which is the American version of the ARB, say? It's a very influential body. It says, single dosimeter under the apron is unacceptable. So basically we are doing something which is really not acceptable at the usual international standards. If you are wearing only one badge, it should be worn outside the apron at collar level. This is basically what the thing is. Why is this an important issue? Why are we talking about this small thing? I think that is the topic of that is the topic I am actually talking about over the next few slides. And this is very important for us. Okay, the radiation badge. I just want you guys to just, allow me to speak a few words of this radiation badge. Just give you an introduction about maybe certain things that you are not very familiar with. So, what is it that the radiation badge is measuring? I mean, what is this quantity? We know there is something called a millisievert, but what is it actually? What does it represent? So, just to give you an intro, there are several quantities. One is known as a physical quantity, which is the absorbed dose, gray. Okay, this is something that we can supposed to actually be able to measure it physically in a lab or something like that. Okay, now there is something called protection quantity, which is the sievert. This also and there is something called equivalent dose, where we are just multiplying the absorbed dose with the radiation weighting factor. And effective dose is where we are averaging this dose over the whole body with all the tissue weighting factors and all that stuff. Okay, so they all have different notations. You see, physical quantity is D, absorbed dose, equivalent dose is H alphabet, and the effective dose is E. Okay, what is this that comes out of this badge? Is any one of them? What is it? That is something else. It is called operational quantity. Now, it is basically an on-the-go convenience thing. Okay, we can't be wearing big meters on our body. So this is just a small thing that's worn, and it is an approximation, a very rough thing, so we get to know that, okay, we are not exceeding certain limits that they have set. That is the basic issue here. Okay, so it's a very simple thing, and it goes by this term, personal dose equivalent. And this general knowledge, you can treat it as general knowledge. And it is denoted as HP10 within a bracket. What is this H? H is basically, it is an equivalent dose, okay? And P personal, that is what it is, HP. 10 is 10 millimeters. That means the lithium fluoride in the TLD badge is calibrated to reflect the dose as if you have got it from within 10 millimeters deep in the tissue from the place that it is placed. Okay, so it is, so that value is what is known as operational dose. Okay, you have to give me extra time. Okay. So that is called operational dose. Now, what is done is, this is sort of multiplied by a factor to basically give you the effective dose. So an estimated effective. So this is what is finally given to you as you should get less than 20 millisieverts a year. It is an approximation from an approximation. We can call it like that. Now, we can also take the dose that is we get from it directly, which is like, suppose you're wearing that badge, let's say, over your thyroid. So it is directly gives you the estimate of the dose to the. So it is an equivalent dose, organ equivalent dose also. So that also is possible, right? So there are two things that can be derived from the badge. Okay, now suppose you wear it on the wrist. You've seen these badges is rare on the wrist. That is a completely different thing, which will be called HP within bracket. It will be 0.07. That means just 0.07 millimeters, so reflecting the skin. So 10 mm, that means inside the body. So that's the difference actually. Okay. Now I'll give you this is a chart of the Amrita, give the badge for servicing, right? I mean for monitoring, and they give you this quarterly reports. So you can see the problem here is that this is a classic thing, it contains cardiologists, radiologists, and you can see only one person seems to have got any number at all in that particular quarter. Okay. That guy is our cardiologist who does electrophysiology. Also a cardiologist who religiously wears the badge. So he's got about 0.27 millisievert. So now, assuming you take it as 0.3, in a year his 0.3 into 4 quarters, 1.2 millisieverts is getting in a year. So our, at 20 millisievert, he is very safe, no problem at all. Now, let us assume he's actually doing only 2 cath lab days in a week. Now, suppose he doubles it, and this is actually this is an estimation. Suppose he was instead of wearing it inside, he wears it outside. Usually 10 times that dose will be recorded. So, with this 1.2 millisievert is actually 12 millisieverts on the outside. And there are parts of his body like the neck, the face and all that, which is not protected, right? So 12 millisievert. Now suppose he were to double the work, instead of 2 days a week, he works 4 days a week, he will cross 20 millisievert. And what is the recommendation annual equivalent dose limit to the eye? It is 20 millisievert. So a cardiologist who just works 4 days a week in a cath lab, which is nothing. I mean, we have so many interventional fellows who are operating 5 days, 6 days in a cath lab. You don't have to do anything extra, anything unusual, but you can easily hit your or go beyond your annual effective eye dose. So this is one thing we have to keep in mind. This is something that, it's like the eye dose has now become the operational constraint. This is just to show you the way the eye gets irradiated from the lab. You are watching the monitor there, the radiation is coming from your left-hand side, it's coming obliquely like that from anterior aspect of the patient, and is hitting your face in this angle actually, from below. This is very important in terms of protection. Now just to give you a background of the eye dose protection thing, interestingly, Ziv Haskell, who is a very famous, well-known person in ISVR circles, who is from New York, he's a pioneer in intervention in the liver, tips and all that. He did a study in RSNA, just caught some random interventional fellows, did an eye checkup, and found that significant number of them are having posterior subcapsular opacities. He just put it in the RSNA news, that's all. This is not a big journal. But I can tell you this is highly cited, not journal, but magazine. Even in big journals, you can find this cited actually. Because it created such a big, impact. Interestingly, the ICRP publication 2007 put an annual equivalent dose eye should not exceed 150 millisievert. That is what they recommended. But as a result of this Ziv Haskell study, the International Atomic Energy Agency sponsored a very large international study on interventional cardiologists. They again caught hold of interventional people in big international conferences worldwide, and actually found out that 40% of them, of the cardiologists, the primary interventional people, were having subcapsular opacities. That is the senior people. And 20% of the techs and nurses who are senior. This is actually 5 times, 6 times more than what you expect in the same age group in control people. With the result, in 2012, ICRP came out with another rapid revise of their saying, bringing down the dose from 150 millisievert to just 20 millisievert. So I explained to you now how, without doing anything crazy, just working in the cath lab for 3-4 days, maybe 4 days a week, can actually make you cross the 20 millisievert dose to the eye. Because that part is many times not protected. You're not even aware of it, okay? By the age of 40 or something, you are likely to have, some kind of cataract. So, geometry of the scattered radiation to the head. I mean, I showed you how the radiation goes. Now, if you look at it, which would be a good place to measure this actually? Obviously, you can't place our badge on the eye actually. So, if you look at it, putting it there right on the beam would be a good idea. Where is that? That is the collar. That is above the apron actually. So, wearing it on the left side on the collar outside the apron actually is a way of surrogate. You can get an idea of how much the lens dose is also. So I'm saying the same thing with Joki is telling actually. I'm saying we should take out the badge and wear it outside actually. In India, we should take out this. Because what has actually happened is AERB guidelines are old. they are actually guidelines which predate the 2007, 2000, that original ICRP recommendation. They have not revised after the recommendations have changed. And this danger that is there for our young interventional people, this fact that they can easily cross the eye dose limit, and the fact that eye lens is actually got a threshold of opacities which is actually not very high, is something that has not been factored in. I think it's very important that some policy change is done in this regard, and you guys should be aware of it. Why should the badge be worn outside, actually? First of all, a very interesting thing, the ICRP, if you were to go through the publication, they themselves tell this. See, you and your colleague will be doing a procedure. Maybe you're doing a TIPS or aortic EVAR or something like that. And you may end up with two different values because the other guy is wearing an apron with a different shielding thickness. If I am wearing an apron with a 0.5 lead and you are wearing an apron with 0.25, the same procedure, two different people will have different reading. And even when you're comparing with your colleague, let's say with another hospital for this sort of a thing, if that guy is wearing a better quality apron or something like that, he may get a different value. The only way you can eliminate differences due to shielding is to actually wear it outside. This is a very basic thing. The other thing is, it does not account for the 10 times radiation that you're getting. See, you're getting 0.2 millisievert, 0.1 or something in a quarter. That looks like it's cool, man. What's the problem? Your 20 millisievert is what your whole body effective dose is recommendation. You're not thinking about the eye at all. But you're getting 10 times more in unprotected areas. So what is happening is when you get a dose report like that saying 0.1, 0, you're cool, yeah. You don't realize it is 10 times more. The other thing is, it's a very good surrogate for the eye dose. This is why I was demonstrating it. And the most important thing that zeros do not convey any information. So if there's no information, there's no awareness, no self-concern, and you are not concerned about yourself, why should you be concerned about the patient actually? It's natural. Then the other thing is a nice round number if you get each quarter. No? You get some 3 millisieverts or something and in a quarter or in a year. It is something that you will definitely sit up and take note. All of you. So maybe your colleague is getting 10, you are getting 3. That guy will be worried. But if you're getting 0, 0.1, 0.2 at the end of you're very cool. Makes no sense, no? So what are the eye protection measures? This is all, I just have 2 more slides, that's it. So the ceiling mounted transparent acrylic shield. So I think as a radiologist, this is something even very late in my career only I realized, the cardiologists always use it here. We don't use it. If you put that and use it properly, you can have a dose reduction factor of nearly 2 to 10, depending on the geometry. Sometimes it is a very clean, let's say, something like a cerebral work, and you're sitting in the femoral level. This acrylic shield can nicely protect you, but maybe some other areas which you are doing may not totally protect you. But so there is a variation between about 2 to 10 dose reduction. Lead glasses, okay, everybody wears lead glasses, but the most important thing about lead glasses is that the design is very important. The wrap-around type lead glasses is very important, and the coverage on your lateral aspect, hand bottom, is very important. This part should be nicely fitting. The fitting is sometimes more important than talking about lead equivalent and things like that. So this is something you have to keep in mind. And the area, it should be of sufficient size. The number that is given is around 30 square centimeters per glass. So around 27 is mentioned, but 30 is a good number to remember. The wraparound design I mentioned. So the lead glasses, okay, lead glasses you have to use, but you have to use the right one. Chuma putting a lead glass over your regular specs and all, you will leave a lot of gap here, is completely useless. Another thing I want to point out in these things, everybody is giving off a cap to, that's given free in our kit now. It's actually useless according to the ICRP, because unless you stand like this to the radiation, which nobody does, it's no point. It doesn't come from there. The head actually gets scattered from the thorax and the neck, and the radiation goes up like that. So putting a cap here is actually no use. Some people even argue that it will increase the scatter inside and you get more dose to the eye actually. But the fact that it is not of much use is actually known in studies. So I would say, yeah, you wear it if it looks good, nice design and all that. Another thing is that is coming up in a big way is lead-free lead-free drapes. So a lot of companies are now, they are selling this. This is basically usually some tungsten antimony kind of compound, and it's got a low lead equivalent, but putting the drapes on the patient in a way in which, from the way you are standing, that the radiation doesn't come into your eyes or your face, that is very, very useful actually. So it can have a dose reduction factor, a very high dose reduction factor. I mean, 5 to 25 is what is recommended, depending on how everything is arranged. Okay. Now, one point I wanted to give is actually, it is not very cheap. I mean, you have to also tell the people. But the ICRP document, which talks about this cath lab radiation, which is fairly recent one, 2018 one, they also, there's one line which is very interesting. They say, you can repurpose lead aprons, which you are throwing, no? You take out the piece, cut out the pieces which are not cracked, and use it as a, this thing, lead wrap. You can just place it on the body actually, under the sheet or whatever it is. So that also has equally good effect. So you can do a jugaad there, it's worth it. And summary, so basically what I wanted to, tell here is that, of course, patient dose and our dose are of course linked, okay, no doubt about it. More dose for patient, more dose for the operator, 100%. But patient has two parameters that are cleanly recorded and displayed, and it looks very scientific. One is the air karma, which is actually the dose to the posterior aspect of the patient's, the skin there, the skin of the back, and the other is the total dose to the patient, which is a DAP. Okay, so but the critical thing there is what is a skin dose, because that's what is going to get the patient back in a few weeks. Okay, you have to be very careful. Similarly, in the doctor or in the interventionalist, there are two things. One is, of course, the effective dose to the body, which is what may produce cancer, this, that, and all. But that is like a stochastic effect. But that is actually, you are well within safe limits because you are nicely shielded. What you're not shielded is actually the face and the neck region. And you have no idea how much you're getting because your badge is not, reflecting it. And today, in the recent revision of the dosage thing, I have demonstrated to you how ordinary work in the cath lab can take you over and above the annual dose limit for the eye. So it is necessary that we wear the badge ultimately in a place where this can be recorded. And I am hoping that, obviously we can't wear it from tomorrow onwards because that's against the rules, you can't do that. So we need a policy change, and I think that's very essential. That's a point I want to make here. And AERB should seriously consider a policy change. So ultimately wearing the TLD badge outside the apron and also becoming more aware of all these things and wearing your TLD badge regularly. Yours truly, myself also, not very strict in wearing the badges all the time. Sometimes I walk into the lab and don't wear it. But we shouldn't do that. We should be religious about it. This is not a joke, And the other thing is protection. Yeah. So eye protection, you guys be very serious. Do it scientifically. Do your good product. If your management is not giving you one, it's worth buying one. Keep a nice, which fits you very well. Fitting is very important. That's very important. Thank you very much. Right. Bye.
Thank you, Shrikant. Very nice lecture. And because of the constraints of time, we will not have many. But I will like to request Dr. Sanjeev Sharma to give his experience about this thing, because he has seen many radiologists who have worked how to develop a radiation safety culture.
Shrikant has actually covered it very nicely. There's not much that I can add. I can just was taken up by the monitoring of some conferences in Europe for the cardiologists to assess. Then there was a brief report which was very alarming, in fact. So this was in the Asia Pacific Congress of Cardiology. It happened in Malaysia, in Kuala Lumpur, and there they just, in an ad hoc manner, picked up the participants and checked their eyes. And 39% of them had major posterior capsule cataract changes. And these were incidental, but the number is very striking. So what I'm trying to drive home is that most of us would be getting exposed to all this radiation, and just an anecdotal actually observation. I don't want to scare you, but the fact of the matter is I was very scared, honestly, because the number of colleagues whom I have lost to malignancies of some or the other kind is more than coincidental. So you know, in the last 10 years of my active career in IR, I started spacing out procedures. Some important steps that you can take. One, you know, this fancy for doing multi-angulated views is bad policy. Try and do as much work as you can in frontal. Go to oblique only if it is absolutely necessary, and if you have to, go in RAO and not in LAO as far as possible. And when you do that, cone and time the exposures, give as little fluoro time as possible. And something which I observe wherever I go is that you keep standing there when the acquisition is happening. Please move out to the control room. You are not needed there. These are all calibrated to acquire automatically. Maximum exposure comes when it is exposing, and that is the time that you can avoid by going out. So frontal collimation reduce the time inside the lab. This will go a long way in reducing your exposures. Please, for God's sake, wear a thyroid shield and wear well-fitting eye protection. And you know, that screen that you see in the cath labs is not a decoration piece for hanging against the wall. Use it. And actually, you know, in my lab, there is always another lead which is hanging down from the tabletop to the bottom. Don't waste money on it. Take out the old used aprons which you are throwing away, cut them and convert them into a curtain. And that becomes a curtain that reduces scatter, leaking radiation also from the tube, and can cut down the radiation dose substantially. If you can, if your management can invest in that zero gravity protection which is now widely available, and most labs have it. That was perhaps the best investment that we made in our cath lab. So that way the ergonomic challenges go away. Sanjeev, if you see him here, I'm sure he will be conversing somewhere here or there. But this man is incapacitated because of persistent backache, because of wearing those lead aprons all the time in the lab. So much so now, his lab time has reduced substantially by over 80% because of the backache. And actually there was a very nice article. So those of you who read SIR News, there was a very big article on ergonomic injuries to the interventional radiologists in cath lab. That was very striking. So many of us have ergonomic injuries, starting with the back, because of constant wearing of lead aprons. And related to what Srikanth was telling was, we do the procedure very diligently. We come out, throw the lead apron, and walk out. And they keep lying in that crumpled state and keep developing micro tears. Please hang them because it's for your own good. When you hang them, you make sure they don't develop micro fractures, and they don't develop micro fractures. You have good protection. And lastly, the lead aprons that we wear. I want to wear an ultra light lead apron. That ultra light lead apron is actually cooking you up with radiation. Try and understand this. I am not saying that you wear a very heavy apron. Wear a modern design, but appropriate amount of lead apron. Don't go for these fancy ultra light aprons which cardiologists tend to use. That's it. Thank you.
Thanks, Dr. Srikanth and Sanju sir for their inputs. Thanks.
For want of time, we'll be conducting the live workshop, live sessions for our PAE from 4:30 to 5:30. And from 5:30 onwards, we'll have optimizing navigation through shaping of the microcatheter and wire by Asahi Masters Parkway, sir. So please assemble by 5:30 to learn optimizing navigation through shaping of the microcatheter and wire. Thank you.
section on prostate artery embolization, streaming live from US. It's my pleasure to invite Dr. Sandeep Bagla, a board-certified vascular and interventional radiologist. He has served as principal investigator on numerous clinical trials and has authored multiple peer-reviewed publications in the field. Dr. Bagla will now begin his PAE live workshop. Over to you, sir. So, for the surprise to everyone, including me, he's here in person. Welcome, Dr. Sandeep Bagla.
Thank you, everybody. We'll get started in about 2 minutes, if that's okay. Right on time, maybe 5 minutes. At 4:30 our time, we are going to have 4 live embolization cases happening at the same time. So we will go from room to room to room of different embolization cases. So 3 PAEs in patients who've not had a PAE, and 1 patient who's a complicated patient who had to come back for a PAE. So you'll get to see a number of different things. So if it's okay, we'll start right on time at 4:30. Yes. And myself and Dr. Puidappa, Alex Puidappa, who's our Chief Medical Officer, will both be up here and we'll sort of field questions and things at the same time. Okay? Sound good? You guys are ahead of schedule. Okay, so before we get started, when we're doing these live cases, anyone have questions first? And you're welcome to ask at any time. If anybody has a question about device usage, clinical applications, interpreting anatomy, don't have any problem, just raise your hand and say, you know, Sunny, Sandeep, call me either one, or Alex, who will have a microphone too. And we'll stop them. These guys are used to doing cases live while we'll interrupt them and you'll be able to hear them as well. Hey, John, can you hear us there in Michigan? So the question was, do we do everything femoral or radial? So overall, we prefer to do everything femoral. I would say like in everything's different, like practice by practice, right? So for us in our practice, just to give you an idea, we have 38 interventional radiology centers in our practice around the United States. We have 45 to 49 interventional radiologists. So everybody's a little bit different, but I would say as far as femoral versus radial, the reason why we're doing femoral is most of our patients get a closure device, either Kelt, Angioseal, ProGlide, and so they leave anyways in an hour or 90 minutes. And we tend to avoid radial just because the older patients, the older men, even though catheters reach, we tend to avoid it just because of stroke risk. And there's the occasional case where you have tortuosity, where even when you're going radial, it's difficult. The other challenge too is when you're in these situations, it's if something goes wrong, it's easier to fix femoral than it is radial, especially if you have coincidental vascular disease or whatnot. Does your mic work?
Yep, mic works.
John, can you hear us okay?
He's just logging back in. His mic
Okay.
isn't working.
And Rob, can you hear us okay? We want to make sure we can hear you. Rob, why don't you say something there? Just, okay. He's speaking. We just need their microphone to play here. It's great. So the question is, what's the smallest volume and the largest volume of prostate that we do? So interestingly, the largest volume is somewhere around 800 cc's. I will say that if you asked me this question maybe 4 or 5 years ago, we generally felt there was no upper limit. And I don't believe there's an upper limit for size to do an embolization. I will say that in our practice, we've seen, and to give you an idea of like incidence, it's rare. We've seen 3 or 4 cases of patients who have acute renal failure after large volume embolization, like you might see in a hyperuricemic patient for a liver embolization with big mass. And these are patients who've had prostate sizes that are over 400 or 500 grams. So what we've done as a practice is across our practice, our mantra is that if somebody has a mega prostate, that they should, in that situation, you shouldn't utilize more than 1 vial of beads and maybe gel foam or something afterwards, and utilizing a larger volume, treating a larger volume, but avoiding such microscopic ischemia. That would be the only caveat from the large volume size, is just be careful with the degree of embolic. From the small volume size, we've done prostates down to 25 grams. Why does that work? The reason it works is because, as you know, PAE has both an obstructive component that works and also a irritative component. So a lot of prostate embolization works in the sense that you are reducing the amount of alpha receptor overactivity at the bladder, neck, and periurethral zone. So even in treating small prostates in men with irritative symptoms, they still get very good improvement. We still counsel them that when you have a small gland volume, which is less than 50 cc's, and BPH-related symptoms, which are, say, irritative or obstructive, in that situation, we still find that PAE works. However, we do counsel the patients that their other social factors also influence their BPH symptoms. So they might have, they might drink 4 cups of coffee a day. They might eat a lot of spicy food. They might take their diuretics in the evening. They might be diabetic patients who spill glucose into the urine. So these are other medical or social related things that cause their BPH symptoms, but small gland patients can still do very well. I personally find smaller gland patients easier to do. And the reason I say that is because the vessels are often straight. Everyone's done fibroid embolization for many years. Well, everyone knows as the fibroids grow, the uterus and the uterine arteries become very tortuous, especially the angle of the origin. Well, when you have small gland prostates, the artery is almost always straight towards the gland, and we might see a straight today. So,
We got Rob and Georgia going right
Rob, can you hear us okay?
Yeah, can you hear us?
We can hear you live from Atlanta. So nice. Okay, Rob, we're going to ask you some questions. We have a room full of people here. No pressure on you. So tell us, it looks like you went femoral for your embolization, and what catheter did you use to get over here?
Yeah, I went femoral, and I used the C2 and I did some guide wire to get over quite nicely for him. So, just have it down there right now. Look for the internal.
So you're using a C2 catheter or Cobra. Why do you like that catheter, and what other catheters do you typically use in PAE?
I like the catheter. I mean, if you can get over the arch, it's usually the pass, as long as it's not too steep. If it's too steep, then I'll switch to the HK2 or the sauce.
just to kind of help get down. Goes back to C2 where you just have to go ahead.
Okay, so C2, keep going, by the way. So C2 up and over because easy to get up and over. Is there an advantage you look for in the base catheter? Because some people use RUC catheters, MPAs. Is there something about the tip that you like, or from going left to right, or what? How do you typically, how do you typically pick in terms of your base catheter?
The C2 just has a nice angle, it feels secure. I mean, this catheter in particular is nice because we can pump the Waltman with it after to make expedite going to the other side also.
Okay, so you like it because you could use it on that side, but then use it in a Waltman loop on the right side. So it has the advantage of being able to use on the left and the right. The SAS catheter, obviously most of you know use the SAS catheter just in difficult aortic bifurcations. So just real quick while you're operating to tell everyone here, Alex, why don't you tell them about this technology? So this is not in a fixed unit so far. It's not.
Yeah, so this is a C-arm. This is a Philips Zenician 70. Yep. It looks like he's getting in the hypo right now, or the internal iliac now. But what he's operating in now is basically a blank roadmap. So he steps on live fluoro, turns that into a roadmap, and you can see the contours or the contrast of the wire in the catheter really well without increasing the dose.
So sometimes we do this a lot. It's like what we call like a high-level trick. Roadmap an image without contrast. Why is that good? Because you can see things without ever even injecting contrast. You know the wire is going down the external, and now you can kind of use it. And in a lot of these older men, even though they may not have renal insufficiency, why give the contrast if you don't need to? And you'll see with this mobile angiography unit, we can get very good imaging. And I know in India, as Alex and I have been all around India and seen different labs and done a lot of trainings in India, and it's no different in America when it comes to hospitals typically have very expensive fixed units as there's an increase in private outpatient-based situations, or hospitals that want to go into the community. Can a mobile unit work? And the truth is a mobile unit can work really well. Rob, I know you're going to do this run here. As you're doing the run, I'm going to have Alex take them through your positioning of the run. You do the run, and then we'll come back to you.
Right, so right now you can see his base catheter is at about 12 o'clock. And the operative foramen is around 6 o'clock. 6 o'clock. And he's, what degree oblique are you, LAO? Probably about 30, 35 degrees oblique. Rob? So if you open it up to about 30 to 35 degrees oblique, it will open up that pelvic vasculature. So right now the base catheter is in the hypogastric or internal iliac artery, which is then going to branch into two branches, a posterior division and an anterior division. The prostatic almost always comes off the anterior division.
Yes.
So everything screened right is going to be posterior, everything screened left is going to be anterior. So the big vessel going screen right first is going to be your superior gluteal. Yeah. And then the first branch off of that anterior division there is going to be where the umbilical and the
Hey,
bladder.
Rob, play that run again for us. There you go. Yeah, go a little forward on it. All right, and then pause it right. Keep going. Keep going. Keep going a little bit more. Yeah, pause it right there. Let us just review the anatomy with them real quick.
So yeah, so that's that umbilical, that straightward branch, and then that tortuous branch right next to it is going to be your bladder. And if the prostatic is coming off here, it's going to be that third branch off of that. So that would be what we call type 1 anatomy. As you continue on, the one that swings posterior and then comes anterior is going to be your pudendal. And then the one that parallels that pudendal and goes off the screen posteriorly is going to be your inferior glute.
Hey, Rob, while you work on this, what did you, by the way, on that run, were you very happy with the run? I mean, I wasn't super happy with the...
I'm not super happy. If you want, I can do it again.
Yeah, do you mind doing that run again? While you do that run, I'm just going to go to Michigan real quick and see how John is doing. Hey, Tiffany, can you switch over to John, please? We're going to switch over there. You redo the run, and we'll come right back. This is the advantage of having like three guys operating at the same time. Hey, John, can you hear us in Michigan?
Yeah, I can hear you just fine. Are you able to hear me now?
We are able to hear you. Okay. Tell us where you're at, first of all, like in terms of where you are.
So right now, I just went up and over with the Cobra, and I'm about to do the hypo run.
Okay, just tell me a little bit about the patient. I see they're born in 1967. How big is this prostate gland?
It's a 52-gram prostate.
So what we like is to have the operator frame it in the picture, because if that
Again, so base catheter is parked in that hypogastric or internal iliac. That first posterior going branch is going to be your superior gluteal. Then you have your anterior division. That one going off the screen posteriorly is going to be your inferior glute. As you continue, that goes posterior and then comes anterior is going to be your internal pudendal. The inverted Y is your obturator, and that bottom portion of that inverted Y is going to be hanging over that obturator foramen. You have that umbilical, and then that superior vesicle, and then that one that swings in between that obturator and that internal pudendal is most likely going to be your prostatic.
So John, you very quickly got into the umbilical artery, okay?
Yes.
Just real quick, what wire are you using?
So, Sonny, you're not going to like it, but I am using the Asahi double angle wire.
Oh, all right. I like that. Whatever you're using worked. So,
Yes.
So, all right, John. Maybe it's the United States Michigan luck. You guys need all the luck you can get with all the cold weather. Okay, so you're using an Asahi pre-shaped double angle wire, and what microcatheter?
A ProGrade 2.4 French micro.
And a Cobra Cook base catheter, right?
That's correct. Yeah.
So you have the microcatheter in the internal iliac, in the origin of the umbilical superior vesical trunk, right?
Correct.
We don't know if the prostatic artery here is yet, or do you think it is? Can you play the run first?
So I think there's potential two options here. So it's either going to be a type 1, because I see that branch that is coming down and heading laterally, going down towards the obturator, or it's going to be that branch that is coursing, over the obturator, heading lateral to the obturator, coming back across. But I think that might be potentially a rectal branch. So I wanted to rule out the type 1 first, and since the wire got into it very easily, I'm going to do an injection here and take a look.
Perfect. So he's stopping so John, do that run and we'll take a look. So you're stopping at the origin and doing that run, and we'll take a look and see how that looks, okay? Alex, when you do these, what are your tips in terms of where the artery is coming from? Like, how do you in your mind think, I'm going to check this artery over this artery? What are you thinking about?
I think a rule of thumb that I always live by is like, it's probably higher than you think. And if all else fails, rule out the type 1 before you do anything else. He's in that type 1 right now. There is a promising vessel crossing over. It's going posterior tortuous. For a 50-gram prostate, I would say that's pretty suspicious for being that main prostate. So that straightward going branch going anterior is going to be your umbilical. That next one over is going to be your superior vesicle. And if you have a third branch posterior to that, it's almost always the prostatic.
So that's a great tip. So if you have 3 branches off the first trunk, off the vesicoprostatic trunk, the third branch is always the prostate. And the reason why is anatomically you need an umbilical artery because it drapes over the top of the bladder, which is the straight branch. You need a branch going to the bladder, which is the superior vascular artery. And then the next branch, the third, would be the inferior vascular artery, which is really the same as the prostatic artery. So inferior vascular, prostatic are interchangeable terminology. So, John, looks like, so you got in here. Again, it looks like it popped out.
My catheter kicked out a little bit, so
Yeah.
I'm just reselecting, and then I'm gonna.
There you go. Whatever wire you're using, John, is working like easy.
Well, you know, hey.
So how far down here are you going to go here yet when you do this
I'm
run?
gonna get to this point. I'm gonna get to this point and just do a run here. I'm gonna go a little bit more proximal just to make sure that if this is, you know, the prostatic, as well as make sure there's not any, you know, branches heading elsewhere.
And you're not going to move anything right now, like move the C-arm. You're not going to move a table. Because at this point, and why do you do that, Alex, in terms of efficiency?
Well, so if it isn't the branch, then you don't lose the initial roadmap that you had, and you don't start back at square one. But
Perfect. So he's got a branch, and looks like that branch continues down low. Obviously, you're refluxing back up to the origin. But down low, that looks pretty promising, right, in terms of staining?
Yeah, I think that's definitely, you know, a prostate there, so I'm gonna go in a little bit further.
Okay.
And then I'll give nitro and repeat them.
So probably go down to here, and you have two branches that penetrate the prostate. Every prostate is fed by two branches, an anterior medial branch and a posterior lateral branch. So you need to get that central zone, which is more important, and then there's a posterior lateral, which supplies the periphery. John, while you do that, we're going to go to Georgia and come back. Is that okay?
Yep.
You go there, and then we'll come back and see where you are, and then Rob, can you hear us okay?
Yeah, you hear me?
We can hear you. You want to show us that repeat run?
Okay, here's the repeat hypo, it's much better.
Much better. What's your mixture of contrast to saline real quick on this run?
Yeah, you know, we did, this patient has a larger navitus, so we did mostly contrast. I think it was 6 contrast and 1 CC stable.
How big is the patient in pounds or kilograms?
Maybe 220.
All right, so about 100 kg. So nice size, nice size. And so we're in America. So what do we see here now? What are your thoughts? And by the way, in the audience, does anyone have an idea of where the prostatic artery is? Type 1, 2, 3, 4? Type 1. All right, Rob, do you agree with that?
Yeah, I agree.
And
I was fortunate.
And no, and here you're right. In the audience, they got that too already very quickly. And so type 1, go back to the hypo real quick. I just want to show something about the double density. Alex will talk about this real quick.
yeah, so here you see a double density right before it bifurcates there. So the origin is actually a little bit higher. So if you look at that rule, it's usually a little higher than you think. That's where the origin of the vessel comes from.
So that's important because oftentimes you think it's coming straight off that medial wall, but it's not. It's coming off the probably anterior aspect of that common trunk, if you will, of the hypogastric artery. So Rob, what did you do? You said you got really fortunate, so that means the wire probably went in too?
Yeah, popped right in.
Okay.
And I took a pullback run, so it's my microcatheter position. Oh, here, let me put on the next one.
Yeah, show us your pullback. So by the way, don't show us in Subtract. Just show us what it looks like live so people can see what this pullback run means. Like, what do you mean by a pullback run?
So I injected, I had a syringe with 3 cc straight contrast. And I injected it while pulling back the microcatheter. And we could see that it started filling umbilical and one of the vesical arteries, and then I popped back and it started filling the one that we suspected was the prostatic. I tried to shove the catheter forward a little bit at that point, but it reselected the umbilical.
Okay, good.
And I pulled back a little bit into the type 1 prostatic.
So that's a great job, but a key point there is you don't want to over-inject either when you're doing that, because you want to see where that origin is. So he's injecting just enough contrast to see what's in front of him, and then he stops when he opacifies that other branch. So he tried an advanced technique trying to. If you stop there and you're seeing the opacification of that main branch, if you come out slowly with the wire, you're almost always going to take it.
So this is a really big thing in PAE. Like in almost no other imaging does it matter. Like, you know, when you're in the liver, I mean, really anywhere, when you inject, we often intentionally reflux to see the branches behind us. But in PAE, what's nice is we call it like lacing the artery in front of you. You just want to see what's in front of you, like Alex said, and as you pull back, as soon as that other branch fills, you see in front. The reason it's so important in PAE is if you just inject really hard and it goes back to the origin, oftentimes your catheter is covering the other branch. So it doesn't fill antegrade very well, and then you don't know where to pause. And sometimes the origin is not, the neck of the origin is not that long. So you don't have much room for forgiveness, and you might just fall out. So Rob, where'd you go to next?
On the wire, and I just, since I have kind of pulled back enough to see the origin of this prosthetic, it went in nice and smooth.
Okay,
But I
perfect.
advanced them
And now,
just a little bit in.
just a little bit in, did you do a run here?
Yeah, and I did a run. You want to subtract it or unsubtract?
Subtract, it'd be good.
I did a run right in the pretty early portion of it.
Great, perfect. So that is going towards the top of the pubic symphysis. It's below the bladder branches. And I assume here you want it to go distal to that loop, correct?
Correct. I did probably a no-no, and I took the upper branch.
Ha,
right
okay.
away.
All right, let's see that run.
But I don't think it panned out for me.
Yeah, so that looks like it's feeding the outside of the capsule of the prostate. So what he says in his no-no is he went from one spot and he went past the next bifurcation. What he really wanted to do is just go down and pause before that bifurcation, because there's actually 1, 2, 3 vessels. And even though he may want to treat the capsule, he kind of wants, you need to get a diagnostic imaging of what's in front of you. So you pulled back and did another run?
This is where I'm at right now. So I can pull back to the horizontal segment. That's what I was thinking.
I would pull back an inch. Alex?
Pull back like a cm or two.
Yeah, and then let's do a run from here. And one of the things about these runs is we like to start light and then finish hard. So everyone, when they do their angiography training, learns all the phases of an angiogram. And I'm like maybe an older school angiography with vascular disease. So you want to get your early arterial phase, your peak arterial phase, your early venous phase, your late venous phase, like every phase of an angiogram. Well, when you do PAE, in order to get your prostate gland staining with your arterial phase, if you start light and then inject hard at the end of the run, you end up getting all of it together. So here he still has his main artery filling while he's staining the gland. That's something that you're working on with timing. You know, with a power injector, it's one consistent power, right? With your hand, you can actually control that. So he's getting staining. He's got a capsular vessel going posteriorly towards the obturator foramen, but he's still got very good staining of the gland. Rob, are you happy with that, or do you want to give some nitro maybe, repeat it and see what we think? I'm happy with it.
Some nitro. I mean, I was thinking, you know, I could check this middle branch. Would you disagree? Would you just say?
You could. I think you could check the middle branch because it's going to the gland, but I think Alex, I would feel comfortable embolizing from here, personally. Alex feels the same. He might just recenter lower and just take another run post nitro. While you do that, let's go to John real quick, because I think John is probably done with the left, but I just want to review it. So John, if you don't mind, I know you're going on to the right. Can we?
Actually, no, I was kind of pausing and waiting.
Oh, excellent. Show it.
100 nitro, and just now, and I was going to repeat this run.
Show us
I switched over to an AP projection just to kind of show what it looks like from there.
Okay, can you show us your LAO again? Go back 2 runs just to show us, because we didn't have that magged up. Last we left you, you got in the type 1, got in the bottom branch, and you were just about to go distal. Okay.
So here's the distal run, so,
So this is
nice glance.
nice gland staining, but it's a fairly small gland. I mean, they estimated at 50, kind of looks like 40 to 50 grams.
Yeah, so I just gave nitro, well, then I switched to the AP just to kind of show a different projection, see what that looks like, see how it kind of, stops at the midline there.
Let's see that AP and subtracted.
Yeah.
What do you look for, John, while you're doing this? What do you look for before you do your embolization? Like, here's your AP. Yeah, pause this right here. What are you looking for?
Well, I'm looking to see, again, how you were describing, I did a gentle injection, then a little bit more forceful to see where there are, when it refluxes, where other arteries show up. I'm also looking in this to see anything that is heading beyond the expected margin, where I would expect the prostate to be. So, typically the prostate is going to start, kind of over the symphysis and extend up. So anything that extends below that or kind of beyond that margin is something that is going either likely to penis or rectum. So I want to make sure that nothing heading in that direction.
How about in that oblique view, John, that vertically oriented branch that was anterior?
That vertical branch there, and,
Is that bone? Is that the edge of the pubic symphysis, or is that a branch? What do you think?
it looks like it's a branch. It doesn't subtract, when
Yeah.
I negative, it's still opacified there.
So there is that vertical branch down the middle. So when you see a vertical branch down the midline, what distal vessel does it always connect to?
Usually, it's going to go to the internal pudendal, I think.
Yeah,
right? And
exactly.
Then, so I always want to make sure that I don't get any beads there. So I just gave nitro. I'm going to go back to the oblique projection and repeat the run and then do the embo from there.
I think that's good.
And so your decision tree is, if it's a vertical branch that you think you can get to, would you coil it? But here it looks like it's kind of thready.
Here, I don't think there's any way I can get there to coil it. It's just too small. The branches leading up to it are too small, and if I were to try to get out that far, I would likely cause spasm and get a suboptimal embolization.
Yeah.
So,
I think that you're going to watch then as you embolize, right? So you're in the AP projection now, and you'll make sure that that midline branch doesn't feel antegrade going down. It's okay if it opacifies potentially, but I'm sure you're going to go very light with your thumb when you're using your embolic.
So here's the post-nitro run. And post-nitro, we don't see that.
We don't see your screen moving. Do that again for us. Hit play on yours. Or maybe what we'll do is, can we minimize Georgia? Sorry, maximize Georgia and then go back to Michigan real quick. Your screen appears to be a little frozen here. Let's see.
Oh, it's playing on our end.
Yeah, it's good. No, it's on our end, our Wi-Fi. Let's go back and maximize yours again. We're going to maximize Michigan again.
It looks like we got Falls Church.
There we go. All right, so play your run post-nitro again.
This is it, post-nitro here.
Yeah, we're still not seeing it. Their Wi-Fi did freeze up a little. What we'll do is we saw your post-nitro in AP.
And it wasn't there.
And it wasn't there. What size beads are you using?
Yeah, so it's not, that vertical branch is not here in the oblique on the post-nitro. Given the fact that it's a smaller gland, 52 grams, and it appears even smaller than that, I'm actually using 100 micron MOZ.
That sounds great, John. John, if you don't mind, if you guys can log off and then just rejoin, just to break our freezing Wi-Fi. I'm just going to go to Rob. Hey, Rob, how are things working out with you?
Good, good. Here's the run before I reposition and before nitro, just to kind of refresh. everyone's memory.
So that's before nitro. Okay, good.
There is that little branch, it's kind of thick, I don't know if it shows up, kind of overlying the cubic synthesis that continues down. Yep.
And then what did you see post nitro here?
Here's my post nitro. It looked good. I didn't see that branch anymore. I started slow and then ramped it up.
Much better. So that's got really good glandular staining, but can you pause it here during when you're at your peak opacity? Right there. To me, it looks like you have great glandular staining. You have a good long runway behind you in terms of not worrying about non-target proximally. But also, I would expect, based on this angiogram, to see the other side be the dominant side, because it doesn't seem to go all the way to the midline. It seems to go about a third of the way to the midline, but not all the way. So, so what size beads are you using here?
I'm just going to use the 200.
So 200 micron, what company's beads?
The Hydro Pearls.
Terumo Hydro Pearl? Okay. Okay, great. And then after you give your beads, are you going to follow with anything?
Yeah, typically follow with gel foam, just to kind of really reinforce and pack it in.
Okay. How do you, maybe Alex, while you're doing that, or when you get to a point where you're about to inject the gel foam, let us know and we're gonna take a look. Alex might talk real quick about how we mix the gel foam and why we use gel foam. And by the way, does anyone here use gel foam in PAE routinely, or anyone? Okay, great, yeah. Yeah, pretty routine.
Yeah, so we use the pre-cut Embo cube, or the gel foam that's pre-cut, mix it with contrast, and it's really thick and viscous, so we'll actually instill it with a 1 cc medallion. We typically won't flush the catheter through after using the microparticles or beads and go straight to the gel foam. One thing to note, we're using a 3 cc syringe for the HydroPearl or the particles. So the difference in PSI when you switch to the 1 cc medallion is going to change. So you really want to be cognizant about how you're pressing, because the way you get non-target isn't necessarily, oh, you're refluxing all the way back, but if you push too hard with that 1 cc medallion, you can have issues opening up channels or collaterals that are almost always there, even if you don't see it on your run.
Perfect. So that's why we're using gel foam, to get that immediate stasis right away. Rob, what are you doing now? You're doing your Embo?
Yep, I was using the Hydro Pearls there.
Okay.
Start switching to the gel foam.
So when you switch to the gel foam, I want to show them how it comes out. So that 5 cc's of contrast with the gel foam is mixed. It's like Alex said, injected with a 1 cc medallion. And you'll see as he pushes this out, it's going to travel forward almost in like a glue consistency. Is anybody using glue for PAE? Not yet? Okay, yeah. We typically use mainly beads and follow with gel foam just because of the longevity of data. But it'll be nice to see Rob do this. And then, Rob, once you're done with this, I'm going to go to Falls Church. So, Mike, just giving you a heads up, we're going to go to your case in Virginia, okay?
Can I probably start transitioning here soon?
Here it comes. So it looks like, yeah, so it's starting to get a little bit more dense. That's like kind of like a standing column of gel foam. Do you want to push the catheter in a little bit and maybe inject a little harder? Like advance the catheter a little bit like a perfected technique and see if you push it in a touch further.
Doesn't want to go, actually.
That's fine, yeah, that's okay. But you're starting to get that outline.
So transitioning from the beads to the gel foam, like that's kind of where the art is with this, right? Because, you know, one size fits all. It's not like a 100-gram prostate you're going to put in exactly this amount of beads. So what he's looking for is when he gets real stasis in that parent vessel, because you know you're going to have dead space in the microcatheter. So in a 2.4 French microcatheter, it's going to be about 0.4 ml of dead space. So he wants to stop before he's going to run into some reflux there.
Thanks, Rob. I just wanted to see that. So you're almost done with your gel foam, I imagine, right?
Yeah.
So you're not going to flush this gel foam through. It's just left in the microcatheter, right?
Yeah, but I was going to pull back a little bit and lace it more proximally.
Yeah, it looks like there you already have the gel foam coming back, which is nice. So what he's really doing is going for really like get the beads, get them distal, but get a very complete stasis. As we all know, if you leave gel foam across any of these other proximal branches, it's not as big of a deal. The other is you're getting this acute ischemic event that will, at least if it lasts 24 hours, you're going to get good cell death within the prostate, good glandular shrinkage, et cetera. So Rob, we're going to switch over to Falls Church, Virginia. We'll be back and check in on you, and then we'll also check back in on John before we go to Ari in Raleigh, who I know is getting started. Hey, Mike Abramson, can you hear us in Falls Church?
I can hear you well. Can you guys hear me?
We can hear you great. Mike, good morning. I know it's just after 6 a.m. there. I know you've gotten into the left side already, the left hypo. You want to show us this run here real quick and pause it? Yeah.
Yeah, absolutely. We're going to let it play a couple times, and then I'll pause it. We have, pretty much fully filled with contrast. Here we go.
Yeah, I mean.
So, I just wanted to mention that I like to put the catheter tip at the distal aspect of, right before the bifurcation here between the posterior and anterior division, but the catheter tip was facing a little bit more towards the superior gluteal, so I don't get the greatest run of the anterior division.
So, Mike, in this situation, do you just pull the catheter back and repeat the run? Or do you say, I'm just going to put the microcatheter in and start taking pictures of the anterior division? Meaning, what we can see off the anterior division is that there's a barely filling umbilical artery. After that, there's an obturator artery. Then there's a branch between the obturator and the gluteal, which may be a very small, skinny pudendal artery. So, what do you like to do here?
Well, I felt like I could see the anterior division reasonable enough. The gland size is pretty small in this gentleman. The last ultrasound showed it was just a little under 40 grams. So I thought that there was a potential candidate off the superior vesicle or umbilical branch.
Like a type 1, right?
Enough to be able to just get in each of the branches and take individual runs if necessary.
Perfect. So to give you an idea, if you cover 3 origins, you cover 95% of PAE. So if you cover the type 1 and you take a run from the origin, you cover the pudendal artery and you do a proximal run on the pudendal, you rule out a type 2 and a type 4. And if you cover the obturator artery, you rule out a type 3. So that covers 95, 96% of all prostatic arteries. And so if he can park the catheter in the beginning of either the pudendal or the type 1, he'll be able to at least get some imaging. So what did you do first? Looks like you got in the pudendal here.
Yeah, I had in mind that I wanted to get in the superior vesicle, but the wire just took the internal pudendal first, so I decided to just check it to make sure and get a better run. And so here I did a pullback from the proximal aspect of the pudendal back out of the pudendal, and you sort of start to see other branches start to fill once I get out of the origin of the pudendal.
Yep. Mike, pause that real quick. I want Alex just to talk him through the anatomy of this branch real quick. Pause it right there.
Yeah, so you see that pudendal, which is that big branch that swings posterior, comes anterior because it's going to supply the penis. The anterior branch, that's that inverted Y, is that obturator. But almost always off that mid portion of the pudendal, there's a branch that comes and stays more posterior. So it's important knowing this in PAE, but also in hemorrhoid embolizations. But that's going to be your middle rectal artery. So that's going to stay posterior. So it's important to keep these obliques to kind of orient yourself, because this will stay, it won't pass that anterior margin of that obturator foramen. It's going to stay posterior. It's going to be more vertically oriented. So that prostatic is going to have those micro tortuosities and kind of stay obliquely oriented, almost horizontal, like you saw in John and Rob's case. This will be vertically oriented, staying posterior and going below the pubic symphysis.
It's the most common artery when we train IR docs or we see them, or even when we look at cases online, that people think they're in the prostatic artery, and it's not. And it's the rectal artery. And it's because it's that artery that looks like it might make it all the way over to the pubic symphysis, but it's staying too far posterior over the top of the femoral head. And so just keep that in mind. Looks like we muted Georgia for now. Okay, so Mike, so when you went here, I think, like you said, you're not impressed by these branches, but you want to try and get into the origin of that type 1, right?
Yes, exactly. So I actually, I can see the outrigger fairly well from that, but I just happened to get into it, so I decided to do a pullback from that too.
Perfect.
Actually turned right at the
Oh, there it is. Yep.
the outrigger, you start to see this other branch fill, and that to me looked like the superior vesicle slash umbilical branch.
All right. So, yeah. So what'd you do? No, what'd you do next, Mike?
Well, to be honest with you, I was using the Asaki Meister with a gentle C curve. I tried to get into that branch, the superior vesicle, making a slightly sharper curve, and I couldn't. So I switched to the double angle GT wire.
So that double angle GT from Terumo.
Terumo, yep. And
We got a bunch of double angle wires. Say double angle from Terumo, double angle from Asahi. But it worked in this particular case, right? It got you in the origin of this artery, right?
Yeah, normally I wouldn't want to use that because I feel like the tip is so narrow that it doesn't give you enough room. But in this case, it was just a steep enough, and the air vessel was not that big, so I felt as though it might catch there, and it did. And so I did pull back. I think the initial portion, you see the two flat branches, and then right there, I felt that likely was the inferior vesical artery.
So you went into that most lateral branch, right? So you had the umbilical, superior vesical, and then you said, I'm going to go in this lateral branch. Looks pretty good there, like you're going to get some distal staining.
Yeah, so this is a run from that portion. It seems to correlate with the smaller size of the prostate gland.
Yeah.
I don't know if this works very well on your screen there, but there is a little bit of a narrowing or stenosis, like right where it crosses that loop of bowel. But nonetheless, it seemed like a good candidate to me. I don't know if you all agree.
I like it. I want to see one more run because go back to that previous run. Yeah, I was going to say something. This run here, even though I see staining in a small gland, so these are challenging to recognize. Big glands, a lot easier to recognize. The one thing about small glands is they have collaterals almost 100% of the time. And in larger glands, I still believe they have collaterals about 80% of the time. But here, there's a subtle straight branch going. Pause it right there, Mike. Just pause it at like the peak. Yeah, right there. There's that straight branch going down the middle of the artery. And this branch right here, that branch going down the middle is usually something that indicates it's going to keep going past the prostate.
And it's going anterior, so that's not good.
Yeah, and if it goes anterior, like Alex said, it's going to go towards the penis. So I would recenter and do a harder injection. And so, Mike, maybe you could do that for us.
Yeah, so I recentered. I looked a little bit lower, a little bit more central, and I actually advanced the catheter just a little bit. No, actually, let me show you one run back. Apologies, sorry about that. So I get a stronger run from sort of that same position, and you actually do see it.
Yeah, pause it there. Pause it at the peak opacity if you don't mind.
Yeah, I'm sorry.
No worries. No, it's a perfect job. All right, right there. So it looks like you have staining in a very small gland, like 30 cc kind of size, but you have a branch going beyond the gland, and go to the native to show them where it is relative to the bone. So it starts to go below the pubic symphysis. So that's anterior, like Alex said, and below the gland. and now you're worried about could that be going to the pudendal artery, which it does.
And Mike, when you were doing that injection, did you do the same force, or did you start slower and then kind of ramp up with that injection? Because it almost looked like there was like to and fro or some type of resistance in that distal branch there.
This run, I mean, obviously it's a small vessel, so I wasn't getting a ton of force, but this one was much more forceful than the run right beforehand.
Perfect. So just real quick, it's unlikely you'll be able to coil this. I mean, you might be able to get down there, but unlikely because I think your observation about that stenosis is real. So I assume your plan is to use nitro and just embolize, correct?
Yes, sir.
Okay.
I was concerned that trying to advance the wire through there was just going to lead to spasm. So I gave nitro, moved it a little bit more inferior. Probably went a little bit lighter. I wasn't quite as forceful.
Yeah.
And this was my post nitro run.
Much better. Hey, Mike, there was a question about size of the syringes you're using. For your injections, what size syringe you're using for your hypo run first?
Those are 10 cc syringes with half and half contrast.
Okay. And the total volume is what, like 6 or 7 cc's?
Yes, exactly.
And then for when you're using your micro, sometimes 8. Okay. If you use your microcatheter, what syringe size you're using for your injection?
Well, these are 3 cc syringes and typically with 100% contrast.
3 cc, 100% contrast. Are they, but to do a run like this, I assume you're only injecting a cc and a half, right?
Yeah, for this small gland, at most, maybe a cc,
Okay.
maybe even a little bit less than that.
Yeah.
Obviously, if the bigger the gland, I'm using more contrast.
Okay. And then as far as type of 3 cc syringe, is it a polycarbonate syringe like a medallion, or is it a regular 3 cc syringe?
No, these are for all of these injections, the regular standard syringes.
Perfect. So just from getting good imaging, because this ends up being, I mean, in all embolization work, right? No matter where we are, thyroid to prostate to neuro, the imaging prior to delivering of the therapeutic is the most important step. So getting that really good imaging is key. Mike, this looks great. Out of curiosity, what size beads you're using? I will tell you that I would use 100s, but I'm just curious what size beads you're using.
I'm using 100 micron.
There you go. All right, Mike. Nice job. All right. So we typically use hundreds for very small glands. I think in the beginning there was a question about what size beads. There is, in the largest study that was done comparing 1 to 3s and 3 to 5s, that study looked at the difference in outcomes and side effects. And the outcomes, albeit similar over the follow-up period, when a subset analysis was performed, the smaller size bead group actually had better outcomes at the last follow-up period. And it makes sense that smaller beads would cause more ischemia and more gland size shrinkage. The only difference, which is why the authors concluded that it didn't matter if you use smaller beads or larger beads, was because that the smaller bead group, and by smaller we mean hundreds versus intermediate size, which is, let's say 250, 300 size beads, was that the smaller size bead group had more immediate side effects. Those immediate side effects being urinary frequency, dysuria, etc. So if you look at gland size, you can tell the arteries are smaller, the terminal arteries in smaller glands. So if you were to pick your beads based on what your end target is, that's our rationale for that. So Mike, we're going to leave you real quick and go to John, because I think John is, we see a small little image, but it kind of looks like a prostate so far. So, and Rob. So let's, and Ari. We're going to go to Rob. We're going to go to John and Rob quick, and then we're going to go to Ari because we only have about 11 minutes left, and Ari will take us through his bring back case of what was so hard. Okay. So John, can you pause this and then we'll tell us what you think here so far, and I'm going to have Alex come up here and talk to you from here.
Yeah, so this is my hypo run, and when I was looking at this and kind of making a decision, I see this branch that could either be be coming from the obturator or the internal pudendal. It's coming down laterally, kind of diving medially towards the obturator and across. So I elected to get into the obturator first.
John, before you go forward, what base catheter do you have right now, and how do you have it formed?
So this is the 5 French Cobra, and when I go from the left side to the right, I create a Vulcan loop, and then bring it down into the ipsilateral side to select the internal iliac.
And I like how you have the nose of that catheter facing that lateral wall, right? So it'll help you buttress down that. Yeah.
Yeah, so I intentionally do that because it makes selecting particularly that type 1 a lot easier, because you're able to bounce the wire off of that lateral wall, and it will usually get it to course medially to be able to select that. So in this case, I decided to look at the operator first, and we'll see if I guessed correctly. And I didn't. So
John, can you hear me okay?
Yep.
Hey, just out of curiosity, so I agree, I would have thought it was from the obturator too, because it was going lateral then medial on your hypo run. But now that it's not from the obturator and you go back to your hypo, where do you think it is? There's really, I think, only one possibility, right?
Yeah, so now I think it's coming from the internal pudendal. I think it's a type 2.
So this is like from an algorithm standpoint, you know, everyone says, do you get CTA? How do you manage these cases? You figure out the anatomy. There's really 3 main possibilities. Yes, there are rare origins, but day to day, this is how you're efficient at PAE, right? You're just working an algorithm. It looks like it could come off the lateral wall of the obturator, but if it's not off the obturator, it's going to be off the pudendal-gluteal trunk, and it can't be a type 1. Because that artery can't be traced all the way back up to the umbilical artery. And so, John, what'd you do next?
So I was attempting to go down the internal pudendal, and since I was trying to take my time, I did get into the type 1 and just decided to take a look at it.
Yeah, nice job. It helps us. We like to see it.
Yeah. And then I just, you know, that umbilical was heading down, so I just thought I would go look more distally at that. And you can clearly see that, or at least I did clearly, that this is the umbilical. You can see some supply to the base of the bladder there.
Yeah, pause that, John. I want to show them something, because this artery is oftentimes mistaken for prostatic perfusion because it's in the right place. But what the umbilical artery does is, next time you guys look at a CAT scan of the pelvis with contrast, if you look at an artery on the surface of the bladder that then goes onto the surface of the prostate, that's the umbilical artery. So it's actually going on top of the bladder, very anterior, then goes on top of the prostate, that straight portion, then goes down, and then will fill the distal internal pudendal artery collaterals. So down low, it's like a straight branch, but it's on the surface. So it doesn't really have any transitional or central zone supply. And oftentimes people look at this and go, it's going to the right place. It can be a little bit like suspicious. They do a cone beam CT. But if it's straight and the first branch of a type 1, resist the urge. I know, John, you're taking a picture for our benefit, but resist the urge to embolize this.
Speaking of pitfalls, John, can you go back to that obturator artery? I just wanted to point out one other thing that sometimes people get caught up on. So what's that branch that just goes directly medial off that distal
Alex, why don't you
obturator?
point that branch out? Yeah, so this branch, John, that he's pointing to is the one that's straight off the medial wall of the obturator. John, you can hear us okay, right?
Oh, I can hear you fine. I just can't, because I'm talking on my phone. I actually can't see what you guys are
Oh
talking
yeah,
about.
sorry, yeah, the pubic symphysis branch. So that branch supplies the
already
bone.
pubic symphysis, yes.
So if you see a straight branch that's off the medial side of the obturator, it's almost always just a bony branch. There have been case reports, it's been published, of a bone infarct related to embolizing this branch. Typically, I would say typically, I mean like more than 95% of the time, if the prostatic artery comes off the obturator, it's going to go lateral then medial, not straight medial. The only other time you might get a medial branch that could supply the prostate is if the native pudendal artery is occluded and you have a medial branch, but it will go all the way down to the apex of the gland and come back up and feed it. Here, that's just going to be a bony branch. So, John, we're going to go to Ari, so if you could just show us the branch you got into off the pudendal, and then we're going to probably swing to him to finish up, because he's doing a case where he brought back, so I just want to show us where you are. That looks like you got in that nice pudendal branch. Very nice.
So that branch off the pudendal, there's a capsular branch and then a branch supplying more central gland. So I got into the branch supplying more central gland, and I'm going to treat from there.
All right, show us the run when you're in the central branch if you have it quick. That looks pretty good.
Yeah, I pulled back a little bit just because it filled that collateral so quickly.
Down the middle of the gland, right?
Yeah, so then, because that's that umbilical.
You got
See it takes the course of the umbilical. So I'm going to give nitro, repeat the run, and treat from here.
Exactly. So he's backfilling that umbilical branch, right? So oftentimes we think, well, there's multiple reasons why people have non-target embolization. One is they don't recognize the artery, right? They just put beads down. Two is they put the beads down with too much pressure. So it's really just mediated by your hand. It's like when you do glue embolization for an endoleak, right? If you inject really hard, you might end up with an issue. So same thing with beads. If you inject and overcome the intraarterial vascular resistance, your beads will go beyond your target into a collateral. Third reason is a combination of two and what three is, which is your catheter is just too distal. So now you want to get distal to the edge of the prostate gland when you do your embolization, but if you're almost in the gland like he is, you can then force those beads through the gland into a distal target. So something to avoid, but we're going to switch over to North Carolina, and I think, Ari, you're doing a case right now, and someone over here in India, Ari, if you can hear us okay, maybe you can go off of mute in Raleigh. Let's see if you guys are off of mute. Someone wanted to ask you a question about what you're doing.
Hey, Ari, are you embolizing the prostate or the knees right now?
I'm doing a prostate. Can you hear me?
Yep.
Yeah,
Okay.
we can.
Keith just wanted to ask you a question because he happened to be here. So, all right, tell us what's going on with this case. We can hear you. It's a little bit low on the volume, so just speak up for us.
Yeah, I'm trying to speak loudly. So this is a gentleman who came in. He has about a 60-gram gland, and he was here about 3 weeks ago, and we did his left side, but the right side was very tricky, and so I decided I would bring him back and do a left-sided access to try to get the right side embolized. What's that? Yeah, please.
Left side access. We can. Okay, so you came over from the left. It looks like what, an MPA or a C2? What is that?
I started with the saw to get over, and then I switched out, and what I have in now is a comfy catheter.
Comfy catheter. Okay. I noticed we're going to mute you, John, by the way, over in Michigan, and you guys can hop off if you want as well.
Oh yeah, sorry about that.
No worries.
Thank
No.
you.
And
Thanks, John.
Ari, why you brought him back and you said it's tricky? What do you mean? I know you don't mean the Beastie Boys song. It's tricky. What do you mean by it's tricky?
Yeah, so he has a type 1 origin, and the problem, the issue is that there's an upgoing segment, a superiorly going segment at the very proximal aspect. So I have to get a wire to basically do a full loop and go upwards. If you can see the image on the screen now,
we can.
What you see, yeah, there's an umbilical artery that's headed medially and downward, and then just lateral to that is the prostatic artery.
We got you.
And it goes upwards first. I'm trying to see if I can find my best picture to show you that.
Okay, so it looks like you moved your catheter up and down here to get a couple repeat runs. Are you just doing this because it was a challenging case? Like, you don't normally do this, obviously, right?
All these runs? No, it's hard. I'm trying to find the right angle. See, here's the thing. In order to get the wire to make that turn and go upwards, I have to have a lot of support from the base cap. Push in. So I'm trying to figure out what angle and what base cap to use to get the maximum amount of support.
Okay, by the way, this is a really good image because I finally see what you're talking about. Do you mean that little double density on the medial wall of the anterior division? And that's the actual origin, and then it goes up and then down, right?
Correct. Yeah.
So let me ask you a question. Why not try like a J-shaped microcatheter?
That's actually what we have in right now. I just placed that.
Okay,
so
so
we're going to try that.
Awesome. Before you do that, because I do want to see that go in, show me, do you have other runs? Did you go to a contralateral oblique or anything else? Oh, it looks like, oh, you already got into
This run right here. This is still a ipsilateral, but this shows you. So I'm in the umbilical artery here, and you can see that proximal segment going upward.
Nice. So are you going to put the J-shaped catheter in the umbilical and bring it back slowly and point it up, or are you going to get into this from outside the ostium?
That's my plan. Try to get into the umbilical with the direction of the J-shape.
Okay, so just for everyone, so it's a J-shaped, pre-shaped microcatheter, J-shape, from which manufacturer and what size?
It's a Boston Scientific direction, and it's 135 millimeter, 2.4 French.
So 130, 2.4 French, J-tip, Boston Scientific direction catheter. The purple one, if I remember correctly. Okay, so you're going to feed it. You're going to feed it in over what wire?
Right now, I'm using a fathom wire. That's what I got in.
All right, so you have a Boston Scientific shop over there. So Boston Scientific.
I'll stand here.
All right, good. And real quick, did that microcatheter fall out of the ostium? Mike.
It wasn't in to begin with. I had to take it out. I didn't
Oh,
exchange it.
okay, so interesting. Okay, so that's interesting. So at one point you had the microcatheter in the umbilical. I guess the only option could be to like exchange it over a 300 centimeter microwire like Command or anything 300 centimeter. Okay, but you're out of it, so this will be better because I personally wanted to see, I wanted you to show them how you do the trick where you form the J shape and pull back to engage the ostium like while doing a puff. Do you mind showing them that? I mean, I'm confident you're going to get into it, so I'm not worried.
I'm glad you are.
The only thing I would suggest, so if it was me, because I know this is a hard case, I would leave the J in the anterior division. I would back my base catheter up to the common trunk where it's like a little aneurysmal. And then, you already hooked it. Did you already hook it? Yeah, it looks like you hooked something already. You know, every case we go to, you guys are really just too good. Just finish the case. So what did you do there real quick? Can you just play that for us? Don't slow down. You're our finale, aren't you?
What did I do? I did what you said to do. I formed the J shape, distal, and I pulled it back.
Okay, and then you just did a run. Can you just did that live or you did it in a run format that you can show?
Run is fluoro.
Fluoro. Okay, do a run here, and I just want to see where you are. It looks like you're in the ostium, but I just want to see it before you put the wire in. All right, that's better. Now me and Keith can actually see the images. Our eyes are getting older back here. All right, good. All right, so now that's a great picture. So you're kind of, initially in the run, you're favoring filling the umbilical, right? In the very beginning of the run, the umbilical fills first. So the prostatic is probably like a couple millimeters back from where you are, right?
Yeah, that's right.
All right, so you go on roadmap, and what wire are you going to use to get around here? And then what are the challenges of that now that you have to get this J shape around this bend? What are you going to do?
Well, the first step is to get the wire and take that upward turn, which is still, that's a big step. And I'm still using a fathom, but I might switch to a softer wire in a second.
Okay.
It definitely to go down the umbilical first. That's where it's headed.
Could you do a light pullback with that microcatheter until you preferentially fill the prostatic, and then you know you're kind of like hooked on the prostatic?
We could definitely do that. I think that I would probably pop out because I'm very, there's not a lot of wiggle room there, but let's give it a shot.
Yeah, you know, we say, even though you don't want to fall out, you know, we say scared money don't make money, so you're going to have to try.
Yeah.
And there's a lot of music lovers in here. There's two references. All right, pull back, a touch, pull back. Right. There. But I think getting into it, honestly, from here, like play that run again, I actually think when the wire comes out here, you're almost out of the ostium, so it'll point up. I think you'll probably get it. Pretty optimistic.
All right.
Let's see what you got here. So we're gonna have to hop off because our session's coming to an end. I do wanna, but obviously I wanna see you get in here, and I know you will, but I wanna make sure, does anyone have any questions? Size, particles, devices, shaped microcapsules. I think you guys saw like sort of anything and everything. But does anyone in the audience have any questions? Yeah, sure, there's one question here coming.
The completion of your embolization of the particles or the beads, when do you choose between coils and gel foam?
Perfect. So Ari, this is a question. We'll pivot to you. So at the end of embolization, when you're done with your beads, or you think you're done with the beads, when do you pivot to gel foam? And or if you were to use coils, could you address that after that? Okay.
The first answer is I don't use coils after particles or gel foam. It's not my technique. I don't think it's a good practice because it eliminates your ability to return, to come back and do another embolization. So coils are out. As far as what's my endpoint for particles, I like to go to when the flow is sluggish. The things that I'm looking for are either if the particles are starting to reflux or if they're going down towards the penis or the rectum or someplace I don't want them to go. That would be an endpoint. And so I get to, and the other thing that we talk about is that there's also a proprioceptive aspect, meaning that you can feel greater resistance on the plunger of the syringe as well. And so that's also a bit of a stimulus to potentially stop. So I take all those things together. I don't go to stasis with the particles. I go to sluggish, and then I finish with the gel foam and take back to stasis.
Thank you.
All right, why don't you try with this wire for a minute while I just make sure there's one more question. Keep doing what you're doing, of course. I still think leave the base there. I mean, leave the micro there, pull the base back. Like sort of push the micro in and leave the base back. And I think it might, yeah, there you go. Okay, one more question.
I know you use.
I would, leave the micro down like you did, form the J, and then slowly pull it back like you did, but pull the base back, because I just think it'll give it a little bit more, there you go, now spin, and I think try it.
What do you think about changing the wire?
Yeah, I'm gonna go with softer wires. This is my next move.
Yeah. Okay.
I know you use embossing particles, but most of the data, especially the older one, has on PVA particles, the irregular sized one. I just wanted to know your experience between the two. Does it really make a difference between embossing versus irregular PVA particles?
I don't think it makes a difference. I think the size of the particles is what makes a difference. So if you're going to use a regular shape, irregular shaped particles as opposed to spherical particles, just make sure that if you're using irregular shapes, you use smaller size for corresponding spherical size, like you would. 100 micron irregular is essentially equal to a 200 micron spherical particle. I don't think it makes any difference. In fact, the largest published data in the world is with irregular PVA. So just to be clear, I would say the largest experience in the world, however, is with spherical particles. In our practice, we do about 25,000 embolizations a year. So when you're watching these guys operate, they do a lot of embolization work. Everybody's very experienced. They all pretty much, as you could tell, use a pretty standardized technique. I will say that our preference is still in the 100 micron, whether irregular or not, 100 micron to really 200, 250 maybe at max. The primary reason why we don't generally go over that size is because when you look at any of the studies where patients had 300 to 500 micron size embolization for prostates of median size, 80 grams, 68 to 80 grams. Most of those particles did not even make it into the prostate gland at all. And if you look at Ricardo Garcia Monaco's paper on intraprostatic arteriolar size, the size of the arteries inside the nodules and around the nodules are only 60 micron to 180, 200 micron. So you really want to get your particles in that territory. But I agree, from a regular to non, I would say the most important thing is comfort. On Sunday morning, I think we have a PAE session, prostate Euro session, and Alex is giving a talk both on a talk tomorrow in the musculoskeletal section on just different embolic types and sort of their features and why you would use them related to GAE and shoulder, et cetera. But the same talk applies to prostate and everything else. But really understanding what you're comfortable with and what the features are of beads. We don't have like a one bead works for everything. I mean, that's the reality is every particle has some degree of advantages over another, depending on the application you're using. So, what was the other question? Yeah, please.
Any experience, I don't know, about with NextSpheres, the reabsorbable?
Yeah, so not for PA in our institution yet. I think obviously in the musculoskeletal space, it definitely shows some promise. But in the United States, at least I can speak for our team, we don't have any significant experience with it. Obviously, the big challenge will be in terms of the resorbability rate being it's a rapid resorbable as opposed to a long-acting resorbable. And actually Alex talks about that in his talk too, is quick soluble resorbables versus intermediate and long-term resorbables, which there's some big difference, as you know about.
They also have special catheters and wires to actually facilitate the...
Yes, and so the catheters and wires at certain devices, we have, in the US, we don't have those available. Through partnerships and distributor arrangements, we may, but not direct, as you probably know.
Thank you.
You're welcome, absolutely. Yeah, so question is, when do you expect the size of the prostate to decrease? Alex, I'm going to take that too.
Yeah, so actually initially there's going to be a degree of inflammation. So we usually educate our patients the first 2 to 5 days, they're actually going to be pretty annoyed with us because they're going to be peeing more frequently and the prostate can actually swell. So those patients who are susceptible to going into urinary retention, like high PVR or have required a Foley catheter in the past, required a Foley catheter in the past could go into retention. They'll start to gradually notice improvement in their symptoms probably by the second or third week. We say at about a month, they're about 60 to 70% of the way improved. And at 3 months, you can expect their maximal improvement. At that point, you would expect maybe 30% reduction in total volume of the prostate size.
We are going to close out, just out of respect, my apologies. We are a few minutes over, and I know there's another session to follow. And so we're going to wrap up. Ari, our only other tip might be just to push the J-tape in and actually point it more vertically. But we'll show a follow-up to your case images on our session on Sunday. But I really would like to thank everybody for attending. Thank you so much for their activity. And thank you to all these physicians who perform these cases live. If any of you have ever performed a case live for a big room or audience with questions, it is never an easy thing to do. You never know what might
It's 6
happen.
a.m. in the morning over there.
6 a.m. there, and so we appreciate it. Thank you so much.
Thank you.
So on behalf of ISVIR, we thank Dr. Sandeep Bagla and Dr. Alex Pavindappa. We would request to, can we have a small picture? Yeah.
An industry-sponsored session on shaping the microcatheter and wire. Thank you.
Oh, okay. Okay. Hi, I'm Dr. Anubhav, and so I'm going to talk about shaping of microcatheters and microwires. And I think it was good that we had this session where we saw that we were not able to get inside a vessel where we wanted to go. So I guess this session would be helpful in some way or the other. And I think the whole theme is we have to think beyond the concept of push and pray that the wire would go into the vessel where we want to go, to actually shape it so that we know it will go where we want it to go. So that's what it's all about. So the thing is, why to shape? I mean, is there a need? Yes, because the wires that we get and the anatomies that we face in everyday challenge, you know, it's just impossible to go through this. Look at these arteries. I mean, if you have to do splenic pulp embolization and you have to negotiate your catheters through this kind of artery, it just seems to be impossible to reach the lower pole of splenic pulp. Or even when you're doing hepatic arteries and, you know, tumor feeders, and you have a very tortuous vessel you have to reach. So, it won't work, okay. So anyway, so actually the catheters, the wires which come, they come either straight or they just pre-shaped at an angle. And usually that shape won't get you in every vessel that you want to go in. So definitely you need to know how to shape your catheter. Now, why are we talking about Asahi in particular? And that's because ever since I got to use these catheters and wires, I think things have changed a lot. It's become much easier for us to shape the catheters, have the catheters and wires retain the shape that we make, and reshape these wires. You know, that helps in using one single catheter and one single wire for the entire case. And the reason why that is possible is because of the Act 1 technology that Asahi uses, which is very specific to their system, which is not used by any other wire or catheters in the industry, especially the wires. So what is Act 1 technology? So basically what it is, they have multiple so they have multiple micro wires. Can you run this video? Yeah, so they have these micro wires which are intertwined and which actually gives it a much more torque and pushability. Within this core, within this wire, you have a stainless steel core, and you have another twist wire over it, and then you have a coil around it. This is very specific because all other wires will just have a stainless steel core and then a coiled wire around it. So that intertwined wire actually gives it that property that you can push these catheters and have the torque. Now what you want to achieve is 1:1 torque. What exactly that means is that the amount of rotation that you give at the hub, the tip also rotates that much. A simple example and a demonstration is this. If you see, the blue wire is getting, it's the one which is being twisted, and the red one. So as you rotate the red wire, it actually rotates that much at the tip. So we need this thing from our wires because that would help us in knowing how to twist a wire inside the arteries that we want to get into. Now, Maester 16 is the wire that we use, and this is just to show how to shape. It comes with a shapener, so it's a thin needle kind of thing, and you just have to apply a simple, gentle pressure on the wire tip and do it multiple times, and you'll get the shape. The more you keep doing it, you'll get the shape more, it'll increase the shape of the wire. So that's how you do it, and especially after this presentation, I'll also show you hands-on, we can have that, how we can make different shapes. The good thing about these wires are that they retain that shape throughout the procedure. You know, when you're doing it, it'll not lose its shape. You can bring it out, you can reshape it, and then again go in. So for the simple reason that these are steel wires and not nitinol, so reshaping is also possible. Now I'll talk about I'm not going to talk about all the shapes, but 4 magical shapes that I call it as, which makes it a child's play. You getting inside the vessels, tortuous anatomy, it's just so much simpler. So the first one is a gentle curve that I just showed. It gets you for most of the simpler twists and turns. Second one is double curve. This helps when, suppose you're in a larger vessel which has a large diameter, and then you have a small vessel taking off from, either the superior or the inferior wall. And you need that wire to actually go inside it. So what you need to do is make a gentle curve at the tip and then make another gentle curve little proximal to it. That would it will make it lift up that vessel and hook the superior one. Then is the S shape, or you can say a reverse curve. I'll show you where this is helpful, but there's just a simple demonstration how to make it. So you have the tip already curved, you rotate it, and at the back of the wire, you start making another gentle curve so that you get a S shape of this. And if you want to increase the tip again, so you can just go in and do another gentle push on the tip, and then you can increase the tip. Where it helps, for example, this. Now, if you'll see, when you have your wire coming in, it always has a tendency to rest against the wall and never travel in the center of the vessel. So once you have a tortuous anatomy like this, and you have another vessel which is coming out like that, the wire will tend to come like this, and it will rest on this wall on which the vessel you have to go in. And a gentle curve, just a simple gentle curve, will not let you flip it in a way to hook this. It will always have a tendency to point it on the opposite direction, and it becomes really frustrating to get it point in this direction. So what you need to do is, once you make an S shape, what you do is you actually lift it off this wall, and then the shape would always point towards that. So that's where the S shape helps. That's how you get inside these vessels easily. And the fourth one is the most famous shepherd hook, which is almost like shape of a SIM catheter, and it always helps in opposite direction, hooking the opposite direction. Like the last case that we saw, there was a prostate artery which was coming off it was coming on the opposite, and they were saying that do a J shape and all that. The problem with J shape is that if you do a J shape, it will come and hook here, but it will not give us enough support for the catheter device. So you need something which would just go inside like that, and it can only be if you have reverse curve coming up like that over there, then you can have this wire go in. I'll just show you an example of that in a while. So this is just to show like how we achieve reaching these vessels easily with these wires. So this is a very tortuous splenic artery. We had to do a splenic pulp embolization, had to reach the lower pole artery. And you can see that the guiding catheter is found way proximal. You have all these curves negotiated with these wires and catheters without any traction, and you can easily reach the artery which you want to. Similarly, over here you have a tumor feeder. This is the space, and this was the segment 6 artery. So there was one full curve, and then there was an upward curve and going down. You can see that the microcatheter and wire are easily parked there. One thing to note is that if you see the guiding catheter, it's not even in the frame. It's that far behind. Usually it's not possible with any other catheter and wires that you have a guiding catheter which is not supporting your micro. You always need your guiding catheter far inside to support your micro. So you can achieve this with these catheters and wires, and simply because of the technology that they use. It's fantastic. So the case that I was talking about. So over here you have the vessel which is coming off, and that's just to show. Sorry. Yes. So that's. Can we not run every video? Yeah. So see, you have a vessel. Now it's an upturning vessel. There's also a bend downwards. When you take your wire, it tends to go in the vessel which is just in that direction because the catheter is pointing downwards. So you make these shapes, and even if you try to push the wire inside, it's very difficult for wire to have that much small support and go inside that vessel. So if you do a shepherd hook shape and you twist it and bring it back, it will hook it. If you just have to rotate. See, that's how it hooks that vessel, and then you can slide the catheter over it. That's how you do it. Another example, you have a small artery which is coming from the superior wall. Now the thing is that it's not just a straight takeoff. It has a little bit of bend. It's a curve which is there. Just an angio to show. You can see that there's a double density there, which is actually showing that it has a twist there. Again, the same problem. If you have one curve, it'll tend to kind of go in one direction, and having a wire turn on itself, hook the artery, and also allow your catheter to climb over it, and the moment it will hook, then again there's another twist. So a wire doing that without a supportive catheter is usually very difficult. But if you have a shepherd hook shape, it can help you. And then once the wire is in, it's much easier to climb with the catheter. Coming to the micro catheters, again, it's much more simpler to shape these catheters even without steam. So I'm talking about a 1.98 Masters Parkway soft, which can be shaped without, it's exactly like how you shape the wires. Just take the shapener needle and just put simple pressure with the thumb and finger, and you can shape these. However, if you look at 1.7 French volute catheters, you do need to be very careful with them because they have a very thin lumen, and if you put extra pressure, it might kink the lumen. So I would suggest that if you're shaping 1.7, you can shape it. If you're very comfortable shaping these manually, you can shape 1.7, but steam shaping is much more recommended for that. Another important thing with 1.7 volute is that it retains the shape much more longer, and it is a little difficult to reshape it, while 1.98 you can shape and reshape. This is just an example for that. So that's the micro catheter. And you take that stillet and you just apply pressure, and that's how you shape it. So you can shape the micro catheter, and at least for one case, it'll stay like that. So that's, and if you want to reshape it, you want to straighten it, just apply gentle pressure on the opposite direction, and it'll straighten it out. That's how easy it is. You can just shape and reshape according to the vessels. Thank you.
Cut it. Easy. Practically like a neuro catheter.
Yeah. The 1.7 you're holding. Yeah. Absolutely. And the good part about volute is that it mostly doesn't require a wire. You can just, it has such a good pushability that if you shape this, it actually works like a wire. You just push the catheter and it'll go. The only thing is that if you're doing particulate embolization and all that, and if you're planning to use anything above 500, then I think this is not the catheter. If you're planning to do coiling, then this is not the catheter, because it'll only take 016, 017, that's it, not more than that. So 018 wires won't go.
So वो Maester 16 के साथ shaper आता है. Okay, but this can take a neurocoil.
Yeah, this will take a neurocoil, absolutely.
So it comes with the 2.6 wrench, and the wire is just preloaded, but with 1.7, 1.9.
That's the wire. So this
So it comes with
is how the wire is.
Yeah.
It has a.
If you people want to sit, we will be displaying
Okay.
it on the screen. So it will be very easy for everybody to see. Yeah.
Oh, इसको निकालना.
With wire. Yeah.
वो चाहिए.
So this is a
Saline.
different wire. Saline one. That one.
Yeah.
Saline और लेके आ रहा हूँ.
Syringe भी भर देना. Yeah.
Open कर दो.
ये already twist हो गई है.
We'll have another one. Maester 16, one more one.
Gloves हैं
Gloves.
नहीं है? Okay. So that's how the shapener is. I don't know if, yeah, I think you can see it. So this shapener has varying width. So you have a fatter part in the more proximal, and then you have a thinner. So usually when we are shaping wires, we use the thinner one, and when we are shaping the microcatheter, then we use the thicker part of it. Also, a thinner part lets you have very small and very sharp curves. If you use, if you have to have a very sharp curve, then thinner portion lets you have that. Thicker is more for a gentle, larger curves. Okay. Okay, so this is how I was showing you. So one thing is that you have to wet your wires nicely and just apply gentle pressure, and you can shape it. The S shape that I was talking about, you just turn the wire and then use the fatter part of it, and then just do a gentle pressure on the opposite side. And depending on how much you want, you can just give the pressure. The key is that start gently. Whenever you're doing it, just start gently so that you don't kink the wire. Most of the wires will start to reshape if you start applying. Actually, I'm not wearing gloves, so I think that anything sharp should not be used because it rips off the coating. Yeah. So if you have gloves, then it's much easier. So you can I just removed that S shape that I made, and again you can have the normal curve. If you want to straighten it further, you can again put pressure on it, and you can. Is there another wire? Yeah. So coming to shepherd hook. So that's again. So what you do is you start making a gentle curve and a little sharper one at the tip. So you start from there. So this much is okay. So I think with doing it over and over again, you get to gauge that how much is the size of the vessel and and sometimes what I do in my practice is I put the wire first and see how it's behaving, and then accordingly keep changing it. So that's how I do it. And then you start again making that S shape and start putting more pressure on it. So you start getting that shepherd hook shape to it. So it all depends how much you want. what is the length in which you want to get in, and that's how the shepherd hook is. The only thing is that the tip is much more reshapeable than the proximal shaft. So I would say whenever you have to use shepherd hook, keep it for the last, because then reshaping it would be a challenge. So I think this shape, if there's any other vessel you want to go and do that, come back to it and do it last.
How do you frame that in the vessel? Like a seal have to go in there?
That's a good question. So it'll come out, there was actually a diagram just to show. So what happens is it comes out like this. Yeah. So what happens is when it comes out of the vessel, it doesn't come out like that. So it comes out like a S-shaped thing. Now what you want is that when it's going in somewhere, now I don't have that vascular thing. Otherwise what it'll do is it'll go straight and it'll hook another branch. And when it hooks another branch, you just push it. When you push it in, it forms that sim. And then you rotate it and you bring it back. Now see, I was talking about the torque. See, I'm just doing it, just a flick, and it just turns like that. So it's got a fantastic torque quality. Shaping of the microcatheter. So if you'll see all of the 1.98 catheters have, if you'll take out from the pack, they'll have a gentle twist, or I would say a gentle curve to one side. You just have to notice that where it is, because the shaping has to happen from that side only. So once you know that it's turning this side, put it towards you and just start shaping it just like how you did it for wire, and use the thicker part of the shapener. So that's how you can shape it. If you think it's too much, just put gentle pressure on the other side, make it straight. That's it. It's simple. But it helps. I think, so our policy in our department is that either you change the shape of the wire or you change the person who's doing it. Change of hands or change of shape. 20 minutes is the time limit. If you can't get inside a vessel in 20 minutes, either the operator has to be different or the wire has to be taken out and shaped. And it usually works. It usually works. Because with more and more cert, tear, want of being super selective, and all these hepatic arterial, the tumor feeders are all twisted. They are all neoangiogenetic vessels. They all have a lot of twists and turns, and I think it helps. So this is our go-to catheter. I mean, since 22, I think 2022, I think we've not used any other catheter in our department. This has been our only go-to catheter and wire. We've started using Veloute a lot because of being even more super selective. So that's 1.7 French, and it works well with our Y90 therapies. So I think we are using that as well quite a bit. So you guys can try. I mean, you have extra wires.
Yeah. When you use a sim-shaped wire, so after engaging the vessel, do you change the shape of the wire to go in, further go in, or
no? So usually these vessels in which we are going are very thin. So they actually make this wire go straight only. So once we are inside, we can. If suppose we have to take another turn, we can bring out this wire and then try to shape it. But as I said, if you're using a very long length to make the second bend, then it will become difficult at times to straighten it. Then you have to keep another wire with you.
Do you also use 1.9 for conventional taste also, sir?
1 point?
For conventional test, do you use Master Parkway Soft, sir, or?
Yeah, we use only Master Parkway Soft. We don't use any other catheter now.
What is this person?
This is so once you've made I introduce. So once you've made a shape, then how to get it inside the hub of the catheter. So this helps you do that. So you backload it. So you backload it from the back and then bring it to the front and then you load it.
If you force it, you can.
Sorry?
It's not, yes, it can be removed.
Yeah.
Just twist it.
You recently changed this hub over?
No. This is same. Previous ones, I remember there was a ledge between
Okay.
this. Previous Parkways had a ledge between this and
So you can put a torquer on this. Like this is the torquer which comes with the wire.
Oh, you provide the fixed one and this one both.
And torquer.
That is actually with the mandrel. It is fixed in
That's for the tube, over tube. Yeah.
So then the torquer is there and you can use it.
Yeah.
So this wire goes with volute.
You can use it
being
with
over
that as well, right?
as
It's a
well
very
as
good
this.
torquer there.
There, yeah. I know.
That was, no? You can use it without doing it, and that's a very good torquer. So is
But
it
Maestro
only
16
the
has this one.
Maestro 16 which is having this Maestro 16
Maestro
technology
16.
or every wire of that?
No, so they have only one wire. I mean, the wire which we use for our catheters, they have other neuro wires and they have CTO wires and all that. But this is Maestro 16, which actually is used. Yeah, it will be used for both. It's 016. So it's amazing that 016 works for both. Even with the ledge there in the 1.98, it still works very nicely.
And that is 11.
Yeah, and they're not expensive. So I think it's...
So actually since 6 years, 2019 we launched it in India, we have not increased our prices. So we're keeping same price till now and 7% GST down, again the prices came down.
You're not giving it together as a kit, like direction
So
and
wire
fathom
can,
comes as a kit.
so wire can be used for other procedures as well, other than
Other
using
catheters also, no? So 1.7, the same wire can be used with 1.7 catheter also.
2-point tapering to 1.9.
Approximately all our catheters are 2.8.
Another thing is I didn't cover that because it was shaping it. So 022. So it is the largest that you get in this size from any other catheter in the industry. So what it allows you is to have good angio runs. So that's another thing which is there.
If you're using IDC, you have to be careful. No, you put distal. Distal is 420. Okay. IDC not going. You interlock this out. 4 to 7
Thank you so much, sir.
Yeah. Thanks. Yeah. आप ये रखोगे?